Bismillah wa salatu wa salam ala Rasulillah. Good morning everyone and welcome to our Saudi Hematology Annual Conference. I would like to thank those who are joining us in person and those who are joining virtually. This meeting will address different aspects in hematology, from benign hematology to advanced CAR T-cell therapy. And for this, I would like to thank the organizing committee who put a great effort for this conference to see the lights. We have over 12,000 online registration. And also I would like to thank the Saudi Society of Blood Disorder who harbored this meeting since 2017, and also for our sponsor for supporting our meetings. Thank you for coming early on Friday and to attend this meeting, and also those who are joining us virtually. Special thanks to our speaker who joined us and said welcome to Riyadh, and those who will be joining us virtually. Without any further delay, I would like to ask Dr. Tariq Aweda to come and discuss more about our scientific program. Thank you and welcome.
Assalamu alaikum. Good morning. I would like to start by welcoming everybody joining us from here, from abroad, and virtually. It's our great pleasure and honor to have you all here, to meet, to interact, exchange knowledge. The goal of the scientific committee was to try to cover a wide spectrum aspects of hematology. I was telling people when I started, the hematology was few chapters. Now each specialty is a chapter by itself, and to have or to cover topics in hematology, different aspects of hematology, 3 days wouldn't be enough to cover. So we had a lot of challenges to see which one we need to bring, which one we this year to select to update our colleagues locally about what's going on in the field of hematology. And that's why we had divided the sessions to cover the benign hematology, the thrombosis, hemostasis, anemias, laboratory hematology, and the various parts of the malignant hematology, and ended by the stem cell, CAR T, and cellular therapy. I hope you will find the program interested. I hope, and I'm sure our colleagues joining us from abroad and our local colleagues will be updating us about what's going on in the field of different specialties of hematology. I wish you good conference, and I wish good stay in Riyadh, and welcome again. Thank you.
Good morning, everyone. It's my great pleasure to introduce Dr. Fahd Al-Ubaid, Manager of Continuous Medical Education at King Faisal Specialist Hospital, who will be giving KFSH welcome message. Dr. Fahd.
Assalamu alaikum. Good morning, everyone, and thank you for joining us today and Friday morning in attending one of the landmark congress actually in the kingdom, the annual Saudi Hematology Congress 2023. On behalf of the academic affair at King Faisal Specialist Hospital and Research Center, we are extremely proud in establishing an official partnership with the Hematology Society. As we all know, our healthcare system is going through a major transformation through the vision of our Royal Highness Prince Mohammed bin Salman. And as we all know, the hematology and oncology specialties is a core of that transformation. In this regard, We are happy to continue supporting the Hematology Society and wishing them more and more success with every year Congress. I wish for everyone to have a great time, and for our speakers who's coming from outside the city, I wish you that you enjoy the spirit of Riyadh. Thank you very much, and thank you for the invitation, Dr. Firas. Thank you.
Assalamu alaikum. So we'll invite our moderator, Dr. Ashraf Warsi and Dr. Ahmad Tarawa, to moderate our first session for today.
Bismillah ar-Rahman ar-Rahim, alhamdulillah, wa salatu wa salam ala Rasulullah. Welcome everybody to the annual Saudi Society of Blood Disorder Congress. Thank you to the Society for holding this meeting with this quality every year. Welcome to this session where we are going to talk about thrombosis more, either in pediatric or adult, and my co-chair, Dr. Ashraf Warsi, will know the figures in thrombosis in Saudi Arabia, and he is going to start.
Thanks for the kind introduction, Dr. Ahmed. So without further delay, we'll start with our first session. It's going to be a recorded session. It's Dr. Giancarlo Casaman is the head of Bleeding Disorders and Coagulation Center, Department of Oncology at Carnegie University Hospital, Italy, and he will talk about EHA ISTH guidelines for management of anticoagulation in hemophilia. So could we have the presentation, please?
Hi, I'm Carlo Castaman, Director of Center for Bleeding Disorders and Coagulation, the Carnegie University Hospital in Florence, Italy. First of all, I would like to thank the organizing committee and particularly Professor Howaida for inviting me to present the expert opinion on antithrombotic treatment in patients with hemophilia. Here with my disclosures. Well, there is no doubt that antithrombotic treatment is highly effective in the general population for managing and preventing cardiovascular disorders. And of course, the primary safety concern is represented by major bleeding. On the other hand, we have no randomized clinical trial available for patients with hemophilia, but we know that there is an increasing prevalence of cardiovascular disorders as long as the life expectancy in this patient population is increasing. And of course, the bleeding risk is inherently increased. Here you can see summarized the recent data from the US registry suggesting that also for patients with hemophilia, deep vein thrombosis, myocardial infarction, and thrombotic stroke are the most prevalent cardiovascular disorders occurring in this patient population. So a working group has been set up by the European Hematology Association, jointly with the ISTH, the EAHAD, the European Stroke Organization, and the European Society of Cardiology Working Group on Thrombosis. So as to the methodology, there was a deep literature review collecting 151 references, producing some case vignettes for clinical questions, split in 6 chapters, and at the end, a 3-level grading system were used. The strongest is recommendation, and the weakest is suggestion. So the first question is to consider whether patients with hemophilia are naturally anticoagulated. We have the results of some studies on endogenous thrombotic potential in patients with different severity of hemophilia, and the results suggest that patients with the lowest levels, below 10 units per deciliter, appear naturally anticoagulated to similar extent to patients on warfarin treatment in therapeutic levels. Levels between 10 to 20 appears to be similarly non-anticoagulated as for patients with on treatment with warfarin between the INR 1.5, 1.9. As to the suggested minimal trough level for factor VIII considered to start antithrombotic treatment, we have available several single center, extra opinion, DEFI consensus, or registry evidence suggesting you see a wide range of the minimum trough level for starting a single antiplatelet treatment, dual antiplatelet treatment, warfarin, or direct oral anticoagulant. So there is a need to reach a more unanimous, more homogeneous consensus among the experts to suggest which are the minimum trough level for the different antithrombotic treatments. The only study suggesting in some way what would be the best minimum trough is a registry, the French COACH registry, including some a population of around 50 patients on, with atrial fibrillation or myocardial infarction. And the patients on the antithrombotic treatment were compared to a population of hemophilia patients without antithrombotic treatment with the same severity of factor deficiency. And here you can see that those patients on antithrombotic treatment up to the level of 20% were characterized by an increased risk of the annualized bleeding rate compared to the population of patients not on antithrombotic treatment. So it's reasonable to set up the minimum trough level of 20 units per deciliter as the threshold for starting anticoagulant or antiplatelet treatment without need of additional prophylactic treatment. So first of all, since most of these situations are characterized by an increased risk of gastrointestinal bleeding, the first recommendation is the use of empiric proton pump inhibition in all these patients on aspirin. Then we have to firmly recommend that any antithrombotic therapy, including single antiplatelet treatment without clotting factor prophylaxis, is not feasible in patients with severe hemophilia. Patients with inhibitors not using emicizumab, similarly, antithrombotic treatment is not recommended, while a minimum trough of 1.5 to 5 units per deciliter are recommended for single antiplatelet therapy, aspirin, either aspirin or clopidogrel, and a minimum trough of 20 units per deciliter for dual antiplatelet therapy or oral anticoagulation is recommended. So, considering, as we already said, that patients with hemophilia with levels below 20 units per deciliter are to be considered as being naturally anticoagulated, those patients with level greater than 20 units per deciliter needing any form of antithrombotic treatment can start antithrombotic treatment without additional factor prophylaxis. Of course, it is of importance careful monitoring of bleeding in this situation. Those patients with levels below 20 units per deciliter, there is no recommendation to start oral anticoagulant treatment with additional factor prophylaxis. So for patients with severe hemophilia on prophylaxis in long-term treatment with oral anticoagulant drugs is considered, we should adapt the clotting factor prophylaxis to a maximum peak level of 25 units per deciliter to avoid peak levels that could be associated with a relapse or increase the risk of thrombosis without having a significant increase also bleeding on the other hand. So this means a more frequent lower dose compared to once weekly higher dose clotting factor prophylaxis. For patients with hemophilia prophylaxis with need of long-term prevention of thrombotic complication with single agent, antiplatelet agent, we can start a single antiplatelet treatment without adapting clotting factor prophylaxis. The same concept will apply to patients on demand. We have to start regular prophylaxis to maintain at least the level of 1 to 5% for a single agent, and levels greater than 20 units per deciliter when dual antiplatelet treatment is advised or anticoagulation is advised. We recommend also, particularly about the choice of a specific drug, is the use of DOACs compared to warfarin in non-valvular atrial fibrillation or venous thromboembolism due to their favorable safety profile and the ability to individualize treatment regimen. We know that is particularly feasible to adapt the treatment with DOACs with a reduced dose without having lower efficacy and especially minimizing the risk of bleeding these patients. So we recommend giving DOACs in reduced dose to those patients with hemophilia who meet the criteria of anticoagulant dose reduction, similarly to what happens in the general population. So a particularly aspect is dedicated to emicizumab because we know that this agent is a game changer in hemophilia treatment, and we know that the use of emicizumab has been considered to be similar to having levels around 10 to 15% of factor VIII into circulation. So in patients with hemophilia using emicizumab, we consider it acceptable to use a single antiplatelet treatment without any additional prophylaxis. At the present, there is no data to draw conclusion on the safety of dual antiplatelet treatment or oral anticoagulation in patients on emicizumab, and then we can only suggest not to switch these patients from factor VIII prophylaxis to emicizumab just for this purpose. A particular aspect is the management of atrial fibrillation and to prevent especially the risk of stroke, because this is an increasing clinical situation. You see that, of course, patients aged more than 60 years have an increased risk of having atrial fibrillation, and in association with this risk, there are also the presence of other cardiovascular risk factors that are implemented in the CHA2DS2-VASc score to decide what is the best treatment and when start treatment for these patients. And on the contrary, we have also the HAS-BLED score that consider also the risk of potential high risk of bleeding in these patients. Of course, there is no validation of these scores for patients with hemophilia, so we have to judge case by case according to the possibility to manage differently also atrial fibrillation in patients with hemophilia. So we suggest considering the CHA2DS2 score to assess the individual stroke risk in patients with hemophilia, similarly to what happens in general population, but we cannot recommend specific predictive thresholds. So at the end of the day, expert balance of thrombotic and bleeding risk must be taken into consideration for patients with hemophilia. We consider these patients as being primarily at high risk for bleeding in any bleeding score, regardless of factor level. So this is a strong consideration and a strong thinking prior to decide about the best treatment for these patients. So in this patient, we recommend oral anticoagulation over the use of aspirin. There is also another possibility to manage atrial fibrillation, that is the left atrial appendage closure device. With this device, you can close the auricula and to reduce the risk of embolize from the left atrium. Here you can see some examples of patients treated with left atrial appendage closure. You see about the level, the trough level considered for managing this situation. But you see again, what about the antithrombotic therapy? You see that in some patients, warfarin has been used, in some other dual antiplatelet treatment, and some patients also a single agent antiplatelet treatment. The trough during antithrombotic treatment again is highly variable, and the long-term anticoagulation has been considered in some situations according to the individual risk, while for other patients, no treatment has been considered from the long-term follow-up. So To summarize, in patients with atrial fibrillation having factor level greater than 20 units per deciliter, according to the individual risk assessment and the presence of high thrombotic risk, we can consider direct oral anticoagulation. In those with factor level below 20 units per deciliter that are considered being naturally anticoagulated, we can consider the left atrial appendage occlusion or no anticoagulation according to the presence or not of a specific risk factor for this decision. As to the acute and coronary and chronic coronary syndromes, you see that for presence of chronic coronary or acute syndrome, you see that you have a different approach, of course, in terms of recommendation, especially to maintain a trough level 1 to 5 units per deciliter to start with low dose aspirin or clopidogrel, or clotting factor concentrate to maintain level greater than 20 units per deciliter, or when you are starting with the antithrombotic drug, or for a single antiplatelet agent, again, the level between 1 to 5 units per deciliter. And finally, if you have a severe acute myocardial infarction, you see that the level you should try to achieve before PCI is around 80 to 100%, and maintaining level greater than 50 units per deciliter for 24-48 hours, and then again, according to the different situation, when decided for dual antiplatelet treatment and then for single agent antiplatelet treatment, you have to manage the factor level accordingly. How to manage? So to summarize acute coronary syndrome, you see that there is, of course, the need for percutaneous coronary intervention, and according to this, the radial access is the preferred route of insertion of the catheter. Trough factor level around 80 to 100% are considered. A second generation drug-eluting stent also is recommended, and then do an antiplatelet treatment at least for 4 weeks, maintaining a trough factor level 20 units per deciliter is recommended, and then definitely they use a single antiplatelet treatment. And so what about the ischemic stroke? Of course, if the ischemic stroke is depending on as a atrial fibrillation related event, oral anticoagulants, direct oral anticoagulants are preferred. Otherwise, you can use aspirin, typically a loading dose of 300 milligrams, followed by daily 100 milligrams. In the case that on the neurologic criteria, you can consider mechanical thrombectomy, you can again achieve a level of around 100 units per deciliter for at least 40 hours, and then as long-term prophylaxis, you can use aspirin or DOACs. So to conclude, despite the fact that, of course, this is mainly based on consensus among experts rather than on grading evidence, we can definitely say that antithrombotic therapy in hemophilia is feasible. We have very limited data on patients with hemophilia B. We have always to consider to carefully balancing individual risk in every patient according to each situation. The prevention programs for patients with hemophilia are the key to avoid, of course, the need for antithrombotic treatment in these patients. And of course, additional studies are needed to obtain evidence. Thank you for your attention. I'm here to catch your questions. Thank you.
Thank you, Professor Kastman. And now we turn to the pediatric side with Professor Paul Mongol. Professor Paul is a professor of pediatric at Royal Children's Hospital, the University of Melbourne, Australia. And probably over the last couple of years, we are talking about DUAC in adult, but now we talk about DUAC in pediatrics. So the second talk will be DUAC in pediatrics. Yes, please.
Thank you very much for inviting me to be with you today, and I'm sorry that I can't be with you in person, but I'm delighted to have this opportunity to speak to you, and I thank the organisers for asking me, and I hope everyone's having a good meeting. My name's Paul Monegal and I'm from Melbourne, and I'm going to talk to you today about DOACs in children. My disclosures: I have no financial disclosures at all. I don't take money from any pharmaceutical companies. I have been involved at a steering committee level of the Einstein Junior and the Saxophone studies, and have also enrolled patients into the canine studies. My research team has received research support from a number of companies, but none of which is directly relevant to today's discussion. I just want to remind you all that before all of the current DOAC studies came along, the amount of information that we had about anticoagulation in children was really minimal. This was the data from the American Society of Hematology VTE guidelines that we published in 2018. And what it showed, for example, was that for VTE treatment, we only had 36 children who had been involved in an RCT exposed to low molecular weight heparin, and 40 children that had been in an RCT exposed to vitamin K antagonists in children. So the RCT data supporting our standard of care was minimal prior to the DOAC studies. Over the last few years, however, we've had large paediatric programs by four DOACs: dabigatran, rivaroxaban, edoxaban, and apixaban. And each of them has run a sequence of studies looking at a number of different things. When we think about it in terms of what the indications were, in terms of primary VTE prevention, apixaban did the Prevapix ALL study, which I'll come to. In terms of cardiac prevention, apixaban, edoxaban, and rivaroxaban have all done studies of cardiac prevention. And then in terms of VTE treatment or secondary prevention, all of the drugs have been involved in those studies, but not all of them have been completed yet, and I'll come back to that. Both rivaroxaban and edoxaban, and dabigatran are now approved for use in the United States, UK, and the European Union in children. So just starting with the Einstein Junior phase 3 study, rivaroxaban compared to standard of care, large study, 335 children in the rivaroxaban arm, treated for 3 months, possibility of 12 months follow-up if required. Like all of the DOAC studies, the DOAC was not started until after at least 5 days of a heparinoid treatment after initial diagnosis, and that's important to remember. In terms of the results of the study, no difference really in recurrent VTE, no difference in mortality, no difference in major bleeding or clinically relevant non-major bleeding. So essentially, it looked like rivaroxaban is equivalent to our standard of care in terms of risk and benefits. There have now been a dozen publications out of the Einstein Junior program from the initial in vitro work through the PK data and through the results of the RCT, and then some subgroup analysis over the last year or so. The Universe study was rivaroxaban versus aspirin for primary prevention post-Fontan. And this study was a small study that initially enrolled 10 patients in a non-randomized way and exposed them to rivaroxaban in a dose that was half what was used in the Einstein Junior program, so equivalent dose to 10 milligrams once daily in adults, whereas Einstein Junior used 20 milligrams once daily in adults equivalents. After the initial cohort followed up for 12 months, they then had a randomized phase, 2-to-1 randomization in favor of rivaroxaban compared to aspirin, and again for exposure to the drug for 12 months. Interestingly, the Riva patients didn't really start their drug treatment until about 45 days post-Fontan. The aspirin started around 37 days post-Fontan. So looking at the Universe study, there was the small cohort at the start and then a small number of patients, 66 with rivaroxaban and 34 with aspirin. And what's interesting in this study is the bleeding rates. You know, using half the dose that was used in the Einstein Junior program, they had almost 3 times the bleeding rates. And, you know, bleeding rates in terms of clinically relevant non-major bleeding of 6 and 8% in rivaroxaban and 9% in aspirin. So I think there was a definition problem in this study because a 9% bleeding rate on aspirin just is hard to make a lot of sense of. So when we put together all of the Riva studies that have been done, rivaroxaban studies, what are the main things that we can say? Well, you can see from this table that there has been a relatively small number of children under 2 years of age who have been exposed to rivaroxaban, only 37 children. And interestingly, CVL-associated clots only made up 27% of the study population in the Einstein Junior program, when that's usually a much higher percentage of the clots that we actually see. And of course, anyone who had any multi-system disease or was premature were excluded from the studies. So what can we say based on all of the rivaroxaban data? We can say that it's got predictable PK and PD when we administer it orally, both in tablet and liquid form. The studies were completed without routine monitoring, and so we can say there's no need for routine laboratory monitoring. And we think it's at least as effective and safe a standard of care for acute VTE treatment, for secondary VTE prophylaxis, and for thromboprophylaxis in children with Fontan. But we need to understand that the studies involved a higher proportion of older children, and there were no children with severe illness or comorbidities. If we move on to dabigatran, the diversity study, I think the main points I want to make about the diversity study is that it had a different design to the Einstein Junior. So patients, when they were enrolled and they were randomized to dabigatran, had a monitoring assay taken within a week of commencing the dabigatran. If that assay showed their plasma concentration was lower than the target that they were aiming for, the patients were allowed a single dose adjustment to adjust the dose upwards. And then if on a second test a further week later, the patient was still not in the therapeutic target range, the patients were excluded or discontinued from the study. And that happened in over 10% of the patients. So if we think about the dabigatran studies, it had similar issues to the Riva studies, very small numbers of children under 2 years of age, a high proportion of children with inherited thrombophilia, and a low proportion of CVL-associated thromboses, and once again excluded anyone who was premature, anyone with multi-system disease. So what can we say at the end of the dabigatran's pediatric program? Well, we can say it's probably got reasonably predictable PK/PD, but I don't think we can say it doesn't need laboratory monitoring, because that's not what they did in the trial. We can say that once you are therapeutic on it, then it appears to be at least as effective and safe a standard of care for acute VTE treatment and for secondary VTE prophylaxis. Once again, there were no special disease populations studied, and the studies included a higher proportion of older children. The Enobolate study, the study of edoxaban, also came out in late 2022. This study, again, was a 2-to-1 randomization to edoxaban and standard of care for prevention of clot in cardiac patients. And then patients could go on to an extension period where they received edoxaban for up to 12 months. At the end of the main treatment period, 109 children received edoxaban, 58 children standard of care, no difference in bleeding rates and no difference in thrombosis rates. So again, it would appear equivalent to standard of care as primary prophylaxis in cardiac patients. There are a number of programs that are still actually ongoing. And in particular, with apixaban, there is the saxophone trial and the Prevapix ALL trial, both of which have been completed and published and presented in abstract form, but have not been published as yet in peer-reviewed publications. The canine study has been running for a long time, and it is limited by the fact that they have completed enrolments for all age groups other than the neonatal age group, which was one of their FDA requirements. And the study has been stuck trying to recruit some very small infants for the last 2 years now, before we can actually, that study can be closed out and the data made available. Edoxaban has also had a VTE treatment study completed, but not yet published. So I mentioned that that the saxophone study had been presented in abstract form at ISTH in 2022. So it was almost 200 patients screened, 192 randomised, 129 to apixaban, 63 to standard of care. This was primary thromboprevention in children with underlying cardiac disease. And as you can see, almost 3/4 of the patients were single ventricle Fontan type patients. But there was also a number of children who had had Kawasaki disease or other forms of congenital heart disease. And in terms of the primary endpoint of the study, a composite of major and clinically relevant non-major bleeding, no difference between the apixaban arm and the standard of care arm. In terms of any bleeding, there was an increase in minor epistaxis in the apixaban arm compared to standard of care. And that's, I think, relevant because when we get to the next study, which was the Prevapix ALL study, so this was a study that, excuse me, enrolled children with ALL or lymphoblastic lymphoma who were receiving induction chemotherapy with asparaginase, and it randomised them 1-to-1 to either apixaban primary prophylaxis versus standard of care, which is no anticoagulation. They had an extremity ultrasound and an echo at day 29, which was the endpoint of the study. And this involves 74 centres across 10 countries and was independent blinded adjudication. This was the dosing schedule that was used in the Prevapix ALL study, and I'll come back to the dosing schedule that was used in rivaroxaban and in Einstein Jr., and in saxophone in a second. 256 patients randomised to apixaban, of whom 198 completed treatment, and 256 randomised to standard of care, of whom 245 completed treatment. And at the end of the day, no difference in the thrombosis rate between the apixaban and the standard of care, which remember was no anticoagulation. And when we look at bleeding, no statistically significant difference in bleeding as well. Just as you could suggest there might be a trend to reduced thrombosis in the apixaban treated arm, there's also a trend towards increased bleeding in the apixaban treated arm. So at the end of all of those DOAC studies, what can we say so far in general? We can say that the DOACs appear to be well tolerated in children. They achieve similar drug exposures to adults, and they have some favourable clinical benefits and equivalent efficacy and safety. We can use them for treatment of acute VTE, secondary VTE prevention, and probably prevention in the setting of congenital heart disease. The populations that have been studied were heavily weighted towards older children and adolescents who were relatively healthy. Young age groups were underrepresented, and premature infants and those with severe comorbidities were excluded. And so we have limited experience in specific disease populations. I think with the exception of dabigatran, we can say that routine monitoring is not necessary. But whether that is true in populations that were excluded from the trials, for example, children on long-term TPN, or children with renal or liver disease? We don't know the answer to that. And the endpoints that were studied in all of the studies were straightforward endpoints: recurrent thrombosis, thrombus resolution or progression, mortality, major bleeding, clinically relevant non-major bleeding. What we haven't looked at is longer term things like post-thrombotic syndrome, and with the exception of the saxophone study, none of the studies made an attempt to address quality of life. But at the end of the day, the DOACs are now the most studied anticoagulant agents that we have in children. So this is just the dosing schedule that was used in the Einstein Junior program. And the really important thing to note here was that it was once daily dosing above 30 kilos, twice daily dosing from 12 to 30 kilos, and then 3 times a day dosing in children under 12 kilos. There is a liquid preparation for rivaroxaban, an oral suspension, and I'm unsure whether that's available for you in Saudi Arabia. For us, it's not readily available in Australia at the minute because the drug has not been licensed by the Therapeutic Goods Administration, which is our equivalent to the FDA or EMA in Europe. When we look at the apixaban dosing, we don't have the real data, or we don't have any data yet from the canine study in terms of VTE treatment because it's not completed. But in terms of what was used in the saxophone study, again, it was a twice daily regime across all of the age groups, and then with a weight-adjusted regime. The important thing to know is that while an oral preparation, an oral suspension of apixaban was made, after the study completed, the EMA changed their regulations around how much propylene glycol was acceptable within oral suspensions for children, and apixaban did not meet those guidelines. So the oral suspension cannot be given to children under 5 years of age, and because of that, I believe that the companies are not going to market the oral suspension. Their workaround was to create 0.5 milligram tablets that could be used for small children. And so I think that's how we're going to have to dose our children if we wish to use apixaban going forward. Now, that's all of the randomized trials, but another interesting study that's just been published within the last couple of months is this. The team at for a variety of reasons, they made prophylaxis cohort from long-term warfarin over to apixaban during the pandemic. Because it was prior to the completion of any studies, Christina decided to apixaban levels of 80 to 150 nanograms per mil in patients for primary prophylaxis and 100 to 300 nanograms per mil in patients requiring treatment, with all of those levels taken at 4 hours post-dose. Because this was outside of a trial, she did not have access to the 0.5 milligram tablets. And so this was made by using fractions of the adult size tablets. So for the small children, she either used a quarter or a half of the 2.5 milligram tablet and went with twice daily dosing. So that large cohort study and real world experience has now also been published. I also just wanted to briefly mention that as the DOACs are taking more and more prime place in adult care, then it is more and more likely that we are going to see children who overdose on a DOAC. This table comes from a paper that's currently being prepared as a result of a child who presented to Sydney Children's Hospital who had managed to get hold of their grandmother's apixaban tablets, and a 12-kilo child took 40 milligrams of apixaban, so 8 5-milligram tablets. The child had markedly prolonged coagulation but received no therapy, and within 24 to 48 hours, the coagulation came back to normal and the child never had any bleeding at any stage. So this table suggests that if you actually document an apixaban overdose and you're within 6 hours of ingestion, then administering charcoal is probably a good thing to do. Other than that, you just monitor and then treat on the basis of clinical bleeding. So what am I planning in terms of use of the DOACs? I will always use an initial heparinoid for treating a VTE because that's what all of the DOAC trials did. I plan to use rivaroxaban primarily for VTE treatment, except in the teenage girl population. While it didn't really come out in the trials, I think we are clearly seeing in real world experience much higher rates of heavy menstrual bleeding in girls exposed to rivaroxaban compared to other agents. Apixaban, I'm happy with for prophylaxis and will probably use it in the very young and also in my teenage girls. At the minute, I'm not using either dabigatran or edoxaban, and that's for two reasons. One, I was less impressed with the dabigatran data because of those issues I spoke about. But two, I think it makes a lot of sense for an institution to try and limit the options for anticoagulation available in treatment. You know, over the last 20 years, we've only ever used one low molecular weight heparin, enoxaparin, and despite the fact that there were other ones on the market, because we just felt in a paediatric institution, a lot of clinicians aren't used to anticoagulation, and having multiple drugs around was just going to increase our risk of an error and a problem. So I'm probably going to push forward with rivaroxaban and apixaban. And I am not going to monitor in standard care, but in situations where I'm worried about absorption or renal clearance or liver disease or at extremes of age and weight, then it may well be appropriate to do so. And I've currently treated now about half a dozen children with short gut who are on long-term thromboprophylaxis for their central line with apixaban, and we've got relatively good absorption on standard doses. And I think the most important thing is that we have to continually review as the studies come out and new real-world data becomes available. To get the knowledge and make these presentations, and I hope this has been helpful for you, and I look forward to receiving any questions.
So we thank Dr. Managal for the presentation, and Mlango. Johnny Mlango is a professor of hematology and head of School of Pathology at Charlotte Maxeke Johannesburg Academic Hospital, South Africa, and who will talk about exploring
It's an absolute pleasure for me the annual Saudi Hematology Congress. I'd like to thank the Congress Scientific Committee for inviting me to be part of this Congress this year. I was telling someone here that this is my second visit. You know, we always talk about pre-COVID. I was here pre-COVID. To share some of the therapy, as most of you are aware that gene therapy is with us. In fact, you'll see in the data that I'm presenting later that there are 4 patients that have been treated with commercial gene therapies. This is in addition to just under 300 patients that have been treated to date. These are my conflict of interest disclosures, reflecting largely my interface with the role players in the clinical trial space where I spend most of my life. In today's agenda, I will perhaps remind you why hemophilia is an attractive option for gene therapy. Then I'll give you an update on gene therapy programs that are currently continuing. And then I will share with you the strategies for patients who fail gene therapy screening. And I'll end this presentation with some concluding remarks. Perhaps a biggest reminder is that we've seen this unprecedented evolution of therapies in hemophilia, starting with blood and blood products. When DNA technology became available in the 1980s, we moved on to recombinant clotting factor concentrates, and more recently, recombinant clotting factor concentrates with extended half-life. The replacement therapy, of course, is not without any limitations. I've listed here only 3 of those limitations, immunogenicity being one of the biggest limitations. As you know, once you've developed inhibitors, you may well be treated with bypassing agent, and our strategies currently with the options for inhibitor patients are very limited. Sometimes the bypassing agents do not work, or the immune tolerance induction, in fact, doesn't work as well as one expects. The second limitation is the burden of treatment associated with replacement therapy. We do know that they have to be given intravenously, and that imposes a huge treatment burden to our patients. And of course, the last one is intrinsic in the pharmacokinetics of replacement therapy. The peaks and troughs result in areas of vulnerability for patients where the troughs result in breakthrough bleeds. And that is inevitable, as evidenced by many avenues, including the finding of hemosiderin deposit in the joints of these patients. It is in that context that gene therapy has actually been developed. We hope that, in fact, gene therapy will be able to address the unmet needs in these patients. And I've summarized here the AAV-based hemophilia gene therapy currently in phase 3 as you stages of development, phase 1, phase 2. I'm only going to focus on those programs here that are hemophilia A gene programs in phase 3, valoctocogene roxapavovec and giroctocogene fitelpavovec, both of which in fact now are in quite advanced stages, and I'll take you through some of the developments in those. For hemophilia B, is tranacogene desapavovec and fidanacogene elapavovec, both of which are also quite advanced in their development. Just to remind you that they are sponsored by different companies, and if you want more details on eligibility, which we're going to talk about later here, and I'd urge you to perhaps look at clinicaltrials.gov. Perhaps I want to point out here that we're not using, in terms of the genes, the normal genes as we know them in replacement therapy. In the context of hemophilia A, we're using the B domain deleted factor 8. As you'd recall, it is the B domain deleted factor 8 that can fit into the vehicle, the AAV, which can only take a certain amount of cargo. In the context of hemophilia B, we're using the Padua variant, which is the hyperfunctional variant of factor 9. And perhaps the reason I'm pointing this out, there is a difference post-gene therapy in how these 2 transgenes are managing. Perhaps importantly, they all use AAV, mostly AAV5, but also AAV2, AAV6, and AAV8. And I'll show you some of the data of the antibodies directed against these various naturally occurring AAV serotypes. The dosing regimens, they range from 5 times 10 to the 11 to 6 times 10 to the 13 in the valoctocogene roxapavovec program. And perhaps not surprisingly, there's been a lot of enthusiasm. Just under 300 patients, in fact, have been treated with these 4 programs, with a large largest cohort, of course, in the valoctocogene roxapavovec. They've only been tried in the adult setting, 18 years and above. We don't have as yet gene therapy in the pediatric setting that is coming soon. And of course, we do know that some of these have been approved by regulatory authorities around the world. As you can see here, that valoctocogene and etracogen have been approved by the FDA, the EMA, and we've got, at least as of last week, 4 commercially dosed patients. One from Germany with Roctavian, which is valoctocogene roxapavovec, and 3 from the US with Hemgenix, which is the etranacogene desapavovec. And perhaps more importantly, and I'll put this data into context as to why so few patients have been dosed in the context of commercially available gene therapy. Let's just remind you of the importance of the outcomes. In hemophilia B, we've seen very impressive rise in factor IX activity. This is the data from Hemgenix showing that following a single infusion with this gene, you can see a steady state factor IX activity over time, going out to 24 months, at least in this particular data set. We do know that these patients are now approaching the 3rd year. And that is particularly important to keep in mind because we're using the Padua variant of the factor IX here, and that may explain why one has a steady state approach. Of course, the factor IX gene much smaller than the factor VIII gene. That is probably another explanation as to why the pharmacokinetic of factor IX post Hemgenix looks differently for hemophilia B compared to A. What is particularly important with the hemophilia B gene therapy is that patients have been dosed that have got pre-existing neutralizing antibodies against AAV, and that data is shown here. Beg your pardon. You can see here that if one looks at the entire analysis set, there is a 64% reduction in annualized bleed rate. If one looks at only those patients that were neutralizing antibody negative, there was a 72% reduction, and if one will look, 79% reduction, and if one were to look at those with positive for neutralizing antibody, it came down to 61%. And we can talk about as to why is there a difference between those who were positive compared to those who were negative. But nevertheless, the drug is approved for both negative and positive individuals. This is the proportion of individuals that required factor IX replacement therapy, 96% reduction in the utilization of factor IX. Just want to switch over now to factor VIII, and I beg your pardon, I just need to grab some water. I beg your pardon there. Factor VIII is slightly different from factor IX. This is data that we presented recently at EHED and ISTH. You can see that the data goes out to at least 3 years. In fact, some of our patients have actually gone up to 4 years. And the data shows that, in fact, it's a triphasic approach. There is a rise following the infusion of the factor VIII, and then a rapid drop, and then a very slow drop in the factor VIII activity. This is all chromogenic assay. Factor VIII activity is not one stage. The data is slightly different from a one-stage assay. And perhaps more importantly, one can see that there is actually a drop, compared to factor IX. And for the reasons that I've already mentioned, one needs to keep that in mind. What about the factor VIII utilization following gene therapy? We were very much impressed. There was a 98% reduction in both the factor VIII utilization and the infusion rates in the patients at the end of year 2. We've got data that now shows exactly the same figures at the end of the year 3. Now, what is important perhaps, and something that I'm going to talk about for the rest of this talk, is the key eligibility criteria in these AAV-based hemophilia gene therapies. You will note that they're more or less the same across the 4 programs. Patients with inhibitors are excluded. Patients with anti-AAV antibodies are also excluded. And patients with any liver pathology that is currently active are also excluded, and of course those with HIV. The exception, of course, is the patients who are currently considered for hemophilia B gene therapy, who may have anti-AAV antibodies. They are currently not completely excluded, as you can see in the schema there. And I want to talk mainly about the first 2 exclusion criteria and what mitigating measures are in place. There's no doubt in my mind that there's a lot one can do with patients who are HIV positive, and they are not completely excluded as long as the disease is controlled. And one obviously does a large number of imaging studies to evaluate if the liver is capable of carrying the gene, the transgene that one is infusing. So I'm not going to talk about the last 2, but I'm going to talk about the first 2. Just to remind you that we do have a fair number of options for managing patients with inhibitors at our disposal. These are the regimens that we use for immune tolerance induction. The Bond regimen has got a success rate of 100%, and the Dutch regimen 87%, and the Malmo regimen 63%. Overall, if one were to take all of this together, we're thinking about 60 to 70% of our patients may well have the opportunity to have the inhibitor eradicated, essentially making them eligible to be able to participate in gene therapy. And in fact, the question you may ask, well, what about the 35 to 40% of individuals where you cannot eradicate the inhibitor? In that case, in fact, there is light at the end of the tunnel. David Wilcox in the US has been working on this for the last 3 decades. And in fact, his persistence and patience is beginning to bear some fruit. And I'll urge you to go and read some of these papers, which sound like science fiction, but they're actually becoming a reality. And the reason I'm saying they're a reality is that he started a phase 1, phase 2 study in human, where he's going to use lentiviral gene therapy in patients with hemophilia with inhibitors, and to see in fact if it works. The last time I spoke to him was at ISTH in July, and he has just dosed the first patient. And I would urge you to keep your eyes and ears open, because if this technology works, then the limitation of inhibitor patients goes away completely. And admittedly, we're talking about a small number of patients, the 30 to 40% that are not amenable to inhibitor eradication or any other therapy for inhibitors. What about the patients with antibodies directed against AAV? It has been a big issue, and for those of us who are not in the space, maybe let me put those into context. In our center, we did a small study in collaboration with the Dutch group, where we wanted to know what the seroprevalence was in our hemophilia B patients. Shown on the left here, you can see we looked specifically at antibodies directed against AAV1, 2, 5, 6, and 8. We were very surprised that the prevalence was very high. in fact, to the level at which we thought none of our patients could qualify for any gene therapy for that matter. Well, we're not the only ones. If you look at the graph on the left, this is a graph from the Indian group, Alok Srivastava. They are developing lentiviral gene therapy using an AAV3 vector. And they wanted to know what the prevalence was. As you can see, and I apologize, it is slightly smaller, but you can see that the prevalence was also very, very high. So in reality, in our population, we are facing a problem. And the problem is the high prevalence of anti-AAV therapies. And of course, some of us participate quite extensively in global surveys. This is one such study, and for most of you, you'll see that South Africa actually sticks out with a very, very high prevalence of anti-AAV therapy. Well, of course, you think that we cannot participate in any gene therapy with that level of prevalence. We've dosed just over 30 patients with gene therapy in our center. And in fact, I'm going to talk about the strategies that one can use in the future. The first one that we are all familiar with is plasmapheresis that can mechanically remove the anti-AAV antibodies. Plasmapheresis, it's not anything new to this audience. It's routinely used in hematology, neurology, and oncology. You remove the plasma using the machine, and you use the immunoadsorption columns to get rid of the antibody and infuse the plasma back. The good news, of course, is that it is agnostic to any immunoglobulin, essentially takes out all immunoglobulins, irrespective of what their function would be. That one hopes that, in fact, it also removes the anti-AAV antibodies. And if in one cycle, one can get as much as 80% out of the system. In high titer anti-AAV antibody, one might require a number of these cycles. So what are some of the advantages of plasmapheresis? It is available in most gene therapy centers, in most hematology centers. We use it routinely for TTP, etc. Tried and tested and effective in removing antibodies, and does not require any additional expertise when used by people who are going to do gene therapy. The downsides, of course, is you are sticking large bore needles into individuals with a bleeding diathesis, with hemophilia. It may cause patient discomfort, and sometimes patients may actually bleed extensively. The efficacy may well be unpredictable. Depending, of course, on the antibody titer, you may need to repeat the procedure a number of times. It may require a number of rounds of procedures over time, with the patient having a large bore needle stuck in their veins, or for the sake of the plasmapheresis. And perhaps the biggest limitation, I've done just over 30 gene therapies. Not a single one of our patients have been admitted to hospital. We do it as an outpatient procedure. But if you're going to do plasmapheresis, you can't send a patient home with the catheter. You probably have to look after them in the hospital so that if they do bleed, you can manage that appropriately. And of course, one has to balance the risk-benefit ratio in patients with bleeding diathesis, such as in hemophilia. The second strategy is that of an endopeptidase called imlifidase. This is an endopeptidase that is cleaving the immunoglobulin. First published in the NEJM a couple of years ago in 2019, used in the context of transplantation in oncology. And the graph there speaks for itself. If you give it as a single dose to the patients, you can see a drop in total immunoglobulin, and over time that actually recover. In fact, the recovery is very important because we do know that other than the anti-AAV antibodies, there are other antibodies that we do need. We don't want those to go away forever. The recovery is, of course, on the slow side, because the patients were given myeloablative therapies, and in fact, the subsequent studies done in non-oncology patients shows that the recovery recovery is much, much quicker. What is shown on the right is the proof of concept that it can work with anti-AV8 antibodies. If you give it as a single dose, shown in the two graphs there, you can see that you give the immunoglobulin and then you give the IDES, which is this endopeptidase. You can see the drop in immunoglobulin, which is statistically significant. It hasn't been tried yet in the context of human beings, but in fact it is in the process of being tried. We should see the results very quickly. One hopes that in fact it works at least in humans, and one can start to use that to get rid of the anti-AV antibodies, essentially meaning that countries such as South Africa and many other countries where the anti-AV antibody titer is very high, one may be able to use it as a once-off to reduce the antibodies and therefore be able to infuse the patient. It creates a nice window to be able to infuse the patient. In fact, yesterday I was in New York and I was speaking to someone who does a lot of preclinical studies, and he told me that all you need is 30 minutes window during which after the infusion you'll be able to get your transgene and the vector into the liver. You actually don't need days on end to be able to do this. I mean, if this works, essentially the story of the anti-AV antibodies being the limitation to gene therapy would be a story that one can forget about. And I want to come back here that in fact the inhibitors and the anti-AAV are not the biggest limitations. Just to remind you that we're talking here about 4 gene therapies that are probably going to all be commercialized very soon. 2 of these are already commercialized. In fact, the biggest limitation is the fact that they cost a lot of money. It is the access. Just to give you an indication here, if one looks at, and I'm going to go back to the previous slide, if you look at the valactocogene roxapavovec, it has actually been approved for over a year, and yet there's only 1 patient who has been dosed, and that patient was actually dosed 2 weeks ago. And the biggest limitation is the cost. At some stage, one hopes that the price will come down and these drugs become commercially viable. The cost at the moment is $3.25 million just for a single dose. Obviously, it costs a lot of money. And the same, in fact, with Hemgenix. Only 3 patients have been dosed, and these were not in big academic centers. These were in small centers in the US, which could afford the treatment here. So what can you conclude from this? That there are limitations to replacement therapies, and there are unmet needs, and gene therapy certainly will be able to address those unmet needs. There are currently 4 gene therapies in phase 3 human studies that are currently ongoing, and they show very promising results, both in terms of efficacy, but more importantly, acceptable safety profile. There are several strategies that are being developed to remove the barriers to gene therapies, and I've alluded to at least 2 of those strategies. Despite these limitations, it is amazing that in fact just over 300 patients have received gene therapy in hemophilia to date, and I'm sure that in fact many more are going to come once we start to address the question of access and price being the biggest barrier to date. With that, I would like to thank you for your attention, and I'm looking forward to the question and answer session.
Thank you, Johnny. It's my pleasure to introduce Dr. Gregor Legal. Dr. Gregor is head of Thrombosis Program Division of Hematology, Department of Medicine, Ottawa General Hospital in Canada, and he will talk to us about VTE and major bleeding in patients with acute medical illnesses receiving thromboprophylaxis with enoxaparin. Dr. Legal.
Thank you very much. Hi, everyone. Thank you to the organizing committee for having me. It's a great honor and pleasure to be with you at this annual meeting. Thank you also for the King Faisal Research Institute for the logistical aspects of me coming here. And before I start as well, I want to send warm greetings to my former Saudi fellows at the Division of Hematology at the University of Ottawa. We're very fortunate to welcome every year a few of your younger colleagues, and it's always an amazing experience to have them with us for a year or two, and I hope they're doing well, and I hope I will meet some of them, and really thank you for your trust again in our ability to train them during their stay with us. So these are my disclosures. And what I wanted to do today was just briefly review the epidemiology and the current evidence around prevention of thrombosis in acutely ill medical patients, identify some of the knowledge gaps, and then discuss the results of a ongoing project about using real-world evidence to further improve the knowledge around the prevention of VTE in medical patients. This is just to show you that's where I used to live before moving to Canada in Britain. Were, surrounded by the sea, so it was very easy for us to do epidemiological studies diagnosed with their VTE, so it was easy to capture all the cases around, so during repeated years. So we did the exercise in 1998, 2006, 2013, and showing that overall there was a slight reduction over time in the incidence of VTE, but certainly not no reduction in the risk of VTE. But what we did as well in one of these exercises was to try to get a better sense of where these patients were coming from and how many of these venous thromboembolism could we attribute to a stay in hospital. So during one of these years, we had a total of 458 new diagnoses of VTE, and what was very interesting was that obviously the vast majority of them were diagnosed with VTE as outpatients, and only a few, maybe 10, 15% of them were patients who were inpatients at the time of the diagnosis of their VTE, and a few others were from a long-term care institution. But what was very interesting was that when you would ask outpatients whether they had a recent admission to hospital, answer was yes in 92 patients, meaning that a total of over a third of all the VTEs that we diagnosed in the entire province during this year were related to a hospital stay. And interestingly, the majority of them were diagnosed not during their hospital stay, but after they had gone home. So it really shows us that not only we still see a lot of cases of VTE related to hospital stay, but that many of them are diagnosed after the patient is back home. And that begs the question of what to do to prevent VTE after discharge from hospital. The main tool we have to prevent VTE is low molecular weight heparin. These are all clinical trials consistently showing a 50 to 60% reduction in the risk of VTE when using a low molecular weight heparin versus placebo at the expense of an only minimal non-significant increase in the risk of major bleeding. And actually, if you synthesize the evidence around that, the studies consistently show, including a reduction in the risk, 60% reduction in the risk of fatal PE when you use thromboprophylaxis in medical patients without a significant increase in the risk of major bleeding. Why don't we use DOACs in that indication? We discussed DOACs before. Well, so two large clinical trials have been made trying to use DOACs for prevention of thrombosis in medical patients. The two of them actually failed. The trial using apixaban did not meet their non-inferiority margin, meaning that you could not exclude that it was doing actually less well than enoxaparin. And there was also a trial using rivaroxaban in this indication, but that one failed for a significant increase in the risk of major bleeding when using rivaroxaban rather than enoxaparin. So With all this data, current guidelines certainly recommend that in patients at increased risk of thrombosis, we use thromboprophylaxis, mostly using heparins, either low molecular weight heparin or low-dose unfractionated heparin, but that in those with either a low risk of thrombosis or a high risk of bleeding, we would rather not do that. And that becomes tricky then, because it means that we need to be able to determine who are these high risk of thrombosis patients who can clearly derive benefit from thromboprophylaxis and who is at risk of bleeding as well. And through the years, we've seen many clinical decision rules being proposed with various levels of validation, but they are often a bit complex based on non-standardized criteria. And I must say as well that all were derived at the time where we were already using low molecular weight heparin. So we don't have a perfect, we're using the PADUA, we're using the improved risk score, but none of them are really perfect in terms of assessing these risks. And maybe as a result of that, for many years now, we know that all over the planet, in fact, although the upper part of the graph shows you the proportion of patients deemed at high risk of VTE when they are admitted to hospital, and the lower part of the graph shows which proportion of these patients were actually receiving thromboprophylaxis during their stay. And as you can see, consistently, half of medical patients are high risk of thrombosis, yet only a limited proportion of them do receive thromboprophylaxis when they are admitted. So we clearly need to do a better job at identifying high-risk patients and proposing them thromboprophylaxis. How can we do that? Well, we know that likely what works best is to implement some alerts, either electronic alerts or human alert in the patient's chart. So as soon as a patient meets the criteria for prophylaxis, either the electronic medical record would trigger a pop-up or a message to the physician saying, hey, be careful, that patient has some high-risk feature, or having a pharmacist or a trained nurse reviewing the chart and identifying those patients. And this has actually been shown to be effective at preventing the actual risk of VTE. And then, as I was alluding to before, the issue is that despite that, some patients will still be able to develop a blood clot, including after they went back home. And this is a conceptual slide showing that actually that's a majority of them. And this begs the question of what to do when the patient goes home, particularly in the context of length of stay being shorter and shorter as time goes, right? The current average length of stay for most medical diagnoses might be 4 or 5 days in hospital. And that's tricky because the clinical trials that validated the use of low molecular weight heparin actually tested 10 days or 6 to 14 days. So when you send a patient home before a week, say, then what to do? Because you didn't give kind of the minimal duration of thromboprophylaxis that was ever tested. So again, there we likely have a gap where we should be able to do a better job at finding some of them who are still at risk of thrombosis when they go home and maybe should go home on something. And actually, so far, clinical trials in that regards have been quite disappointing, showing a reduction in the risk of VTE when you do use thromboprophylaxis after hospital discharge, but at the cost of a significant increase in the risk of major bleeding when you do that. So that points out again towards risk stratification and how to best identify those patients at risk of clotting, maybe with a lower risk of bleeding, that could benefit from being on extended thromboprophylaxis beyond their hospital stay. But until we have that, clearly the clinical guidelines do not recommend using extended thromboprophylaxis in medical patients. I like the last one from the NICE who points out to an interesting question again, that one of patients who go home very early in their stay, and the NICE guidelines say, well, maybe in these patients we need to consider keeping them on a low molecular weight heparin for at least 7 days, even if they go home before day 7. So in the last part of the talk, I want to present that ongoing project that we have about using real-world evidence to try to better understand risk stratification. And I want to acknowledge here the contribution of Dr. Uwaida, our scientific committee chairman here, who has been part of this group with other distinguished colleagues from around the world. And so what we've been trying to do is to try to understand heterogeneity among patients and work towards an individualized approach to VTE thromboprophylaxis. So the first step of that project was to describe risk of VTE and major bleeding in those patients receiving thromboprophylaxis, and also try to see if we could identify some risk factors for VTE and for major bleeding, describing also the duration of thromboprophylaxis. So we're using a large database from the US, the Optum database. It's a de-identified database where we have all information about comorbidities, concomitant medications, blood work results, and so on and so on. So what we did is that we took patients older than 40 who had one of these 6 diagnoses listed here on the left, but who did not have any of the exclusion criteria here on the right. So we didn't want patients with a just recent VT or major bleed, patients who just had a major surgery or who did require full dose anticoagulant therapy, those with AFib, because obviously they would be anticoagulated as well. And we also excluded patients with severe kidney disease. Primary endpoint was symptomatic VTE, and we were also collecting major bleeding as a safety endpoint. These are the definitions, and we use some survival analysis to run the analysis on this project. So as you can see, the initial database was more than 5 million patients. Of them, 640,000 were without any of the exclusion criteria and had been using low molecular weight heparin during their stay in hospital. Eventually, after excluding either the ones who did not have enough data in the database to be able to run the analysis, and that was a big chunk of the patients because we wanted to have info on them for at least 1 year preceding their entry in the database, and then excluded the ones on anticoagulants or the ones younger than 40. At the end of the day, our final cohort here was 123,000 patients. These are the baseline characteristics of the patients, and on the middle you find most of their diagnosis, and you can see that up to 20% had a history of cancer. Some of them had a history of ischemic stroke, and on the right side you find also their previous history of VTE for some of them, previous history of major bleeding, but again these were not recent events, these were events in the past. So age distribution and BMI as well. So this is the distribution among the 6 diagnoses that we were interested in. The majority of patients were admitted for infection, and then came respiratory insufficiency, and less people had either cancer, ischemic stroke, inflammatory conditions, or heart failure. That's a very interesting slide to me, and it's actually looking at how many days of enoxaparin did this patient receive. And as you can see, very soon after their admission, well, a lot of people are either the thromboprophylaxis is discontinued, or they go home and the thromboprophylaxis is stopped. So when you look at, again, which proportion of patients received that minimum 7 days of thromboprophylaxis that was tested in clinical trials, it's only maybe 20% of them. And most people will have their thromboprophylaxis discontinued after only 4 or 5 days. And post-discharge, that's another interesting information as well, only 2% of patients went home on thromboprophylaxis. So it shows that actually in line with the guidelines that I've shown you before, only a very small proportion of patients would be on extended thromboprophylaxis beyond their stay. This is a main result of the study, showing that overall at day 90 following admission, up to 3.5% of patients will have developed a VTE. while 2.2% of them will have developed a major bleeding. So again, showing that rather tight risk-benefit balance where definitely a significant number of patients will develop a VTE following their hospital discharge, but some of them also have some major bleeding, despite the fact that, again, only a very small number of them were receiving anticoagulant therapy when they went home. And that's very interesting finding from this data is that the risk of both VTE and of major bleeding is actually highly variable depending on the indication for the admission to hospital. You can see right away on the right top corner there that cancer patients behave very, very differently, with a risk of VTEs that was double the one seen in the global cohort, 7%, and a risk of major bleeding that was also slightly higher than in the other population. On the opposite, patients with ischemic stroke at the left bottom part of the graph were the only group in which the risk of major bleeding was actually higher than their risk of having a VTE post-discharge. So you can see that, you know, not all patients are equal, and definitely the risk of VTE and of bleeding varies quite a lot depending on why are patients admitted to the hospital. And this is again the end of that first step, where we went on then to look at all the risk factors that could help us predict the risk. Here as shown all the ones that were significantly associated with a higher risk of VTE on the left, higher risk of major bleeding on the two subsequent columns. And nothing really surprising there. You know, patients with cancer again, patients with a previous VTE, those with thrombophilia, have a higher risk of developing VTE, while the ones who were admitted for a stroke, the ones who had cancer, or the ones who had a history of previous bleed, had a much higher risk of bleeding. And I can let you appreciate here the list of the other risk factors that were found associated with an increase in these risks. So moving forward, we will certainly keep working on that database now, again to try to see if we can find a group of patients where thromboprophylaxis could be of benefit, particularly when they go home. So as a conclusion, substantial heterogeneity in both the risk of VTE and of major bleeding in patients admitted for acute medical illness despite thromboprophylaxis. And I think we clearly need better risk stratification to help identifying and help setting up optimal strategies for prophylaxis in this population. We were very fortunate or very lucky to be able to identify several risk factors that are able to prognosticate increase in this risk. So again, the next step out is to keep working on that now and to try to improve our strategy. And with that, I would thank you for your attention, and we'll be happy to take any questions in the Q&A session as well. Thank you.
Thank you for all our speakers. And now this is the time for the discussion. Anyone has any question? Let me start with the first two speakers. They are online. Hopefully they are online with us right now. Any question to Dr. Crossman? Tariq? We need a mic here, please.
Thank you. I hope Giancarlo is still with us. Can you hear us?
No.
We need help from the audio. Okay, maybe you can proceed. We can make it
Okay.
later after.
Okay. Any question to Dr. Paul Mongol? Is him with us online, guys? Yes. So, any question to Dr. Mongol? Yes, please, there. Mike to the second row at the end of there. Yes, please.
Is he still? Is he with us?
Is him?
Hello, Paul.
Yes,
Hello,
I
Paul.
can hear you.
Nice. I have a very brief question in regards to where is the cut point where you put for the adolescent, where you start treating them as adults rather than as children, because we know that the dosing for the adults might differ. Although according to your slides, the Pixaban dose and the rivaroxaban dose might not differ if the weight of the child is above 35. It's almost like similar to the adult. But where do you start implementing that or saying that, okay, this adolescent patient, it's going to behave more like an adult or not behave for more, the evidence of the adult population is going to be more suitable for this patient rather than the children? Because in Saudi Arabia, we deal with children above 14 years old, the adult hematologists, and I tend to struggle to define where the cut point is that, okay, this patient, is he part of the, still part of the children population, or is he going to be treated as a part of the adult population? I hope my question is clear.
Yes, thank you very much. And it's an important question for a number of reasons, not just in terms of the exact dose, but also because, as you know, in the adult trials for treatment, they tend to go straight to the DOAC, either rivaroxaban or apixaban, and often have a slightly higher dose in the initial treatment period, whereas in all the pediatric studies, it was initial heparinoid treatment followed by a DOAC treatment. So my feeling is that there were no adults under 20 years of age, there were no people under 20 years of age included in any of the adult trials. And in the children trials, certainly they included children right up until 18. So I would say anyone under 18 years of age, then you should use the paediatric data because that is a direct line of evidence. And then above 18 years of age, whether or not you use a paediatric dose or whether or not you move straight onto the adult dosing, I think is a difficult choice, but I would probably go straight to adult.
Tariq?
Thank you. Thanks a lot, Giancarlo, for your excellent presentation of the guidelines we worked for. You had addressed quite nicely for people with hemophilia A and B, probably. But what about the rare bleeding disorders? We know all that rare bleeding disorder, the presentation completely different, and the phenotype is completely different. I'm raising this because, and Johnny will be talking later about rare bleeding disorders. What we see here in our area, geographical area, that the rare bleeding disorders maybe not as rare as we think and being reported. Today I was talking to Ashraf and he was telling me he had 8 patients, 8 and 5, which is something quite interesting. So when it comes to the patient with rare bleeding disorders and thrombosis, what do you think, where we gonna go and what could be, do we need to go for another round of recommendation for these people, or we can extrapolate some from the work being done? Thank you.
Thank you, Tarek. Good morning, everybody. I think that, of course, this is an interesting question, but you know that if we have very few evidence for patients with hemophilia, we have even less evidence for patients with rare bleeding disorders. So so far there is no clear indication how to manage this situation in these rare conditions. I think that it could be useful, especially for countries where these disorders are particularly frequent because of several reasons, that in some way a consensus could be reached about how to manage these patients. I think that at least in the Western countries, these disorders, I'm referring of course to coagulation disorders, not platelet function disorders, are very rare, so it's very difficult to think about some guidelines, but rather recommendation or consensus expert opinion that could be really useful for the different investigators treating with these patients. But again, it's a very rare situation that is very difficult to try to share a convincing consensus among the experts. So probably it's better again to treat case by case.
Thank you. Sir?
Assalamu alaikum. Thank you for the good presentation. I'm Dr. Farooq Badiuddin from Al-Hamadi Hospital. My question to Dr. Johnny. What makes 5 million? Is it the content, or is it the process, or is the time taken? Some of the diseases like hemophilia, they have their scourge basically in childhood. So most of your medicines which you are telling are restricted in that age group. It causes hemarthrosis, and by the time the proper dosing is not given and the proper treatment, they go into joint disabilities. So the main stress should be on research and treatment during the pediatric age group. Rather, when they survive this scourge and come to the adult, then you are giving this. That's also.
You may answer the two questions.
I was going to answer that question, but I wanted to ask Giancarlo just one question, if you don't mind, Chair, and then perhaps I can come back and try and answer the question here.
Hi, Johnny.
Good to see you, Giancarlo. The question, really, and thanks again for a brilliant presentation on the anticoagulation in hemophilia. I wanted to get your take on how does your committee view the peri-surgical anticoagulation. As you know, most of our patients, and that is actually the question being asked at the moment, they do have arthropathies, and in some centers they give anticoagulation, and other centers they don't. Like my center, we've done over 100 arthroplasties without anticoagulation. Maybe you could share your practice in that regard.
Yeah, thank you, John. Yeah, to be honest, some part of your question I've been completely missed because of problems with the voice. But if I correctly understood your question, you are talking about prophylaxis during orthopedic surgery in hemophilia patients, correct?
That's correct.
Okay. I can tell you our experience. We recently reviewed, in according to the need for the preparation of the document, and over more than 150 patients over the years treated for joint prosthesis at our centers. We never applied by default anticoagulant prophylaxis for thrombotic events, and indeed we have a single episode occurring in a patient with a high-risk situation, but it occurred in the past. So right now we prefer also to use anticoagulation in patients with a high-risk profile for venous thromboembolism. But I can say that usually also in patients on emicizumab, using bypassing agents during orthopedic surgery, we do not routinely perform anti-thrombotic prophylaxis. I must say that also the physiotherapy approach has completely evolved over the years. So in the second day, the patient usually starting the rehabilitation phase. So they usually have a very earlier mobilization compared to the past.
Yeah, thanks, Giancarlo. It is also our practice not to give anticoagulation at all. And I'm glad that at least that practice is also in your center. Chair, if you don't mind, can I then answer the question that was asked? Important question. I'm not sure if I understood it. One related to the cost of gene therapy, and the second one related to why is this therapy not started in pediatric will have the greatest benefit. Are those the two questions? Thank you very much. Yeah. Now, with regard to the first question, we've actually done this assessment many times in many platforms, whether one is looking at ASGCT, ISTH or WFH, where we've interrogated the cost. The cost of the actual transgene and vector is minimal. In fact, what I had 2 days ago, what literally it costs 1 cent to produce an AAV vector, literally. So the rest of the cost, it would appear, relates to the other commercialization costs. And obviously not being in the space, it's difficult for me to comment on that. but your observation is right, that the cost is not related to the production. The cost is more of a commercial aspect. Gene therapy is going to come to pediatric patients as with all medication. But my take is that we just need to give it time.
If you remember, Johnny, that 7 months ago when we were discussing the same issue probably during EHAD, February, and the matter of the side effects, the transaminases, the liver issues, antibodies, and so on, in addition to the matter of cost. So I think still in pediatric, it's worrying that people start a trial in pediatric with all of this concern. I think so. Any more questions? Yes, sir.
So thank you for your kind presentation. I have just a question to Dr. Legal. So what's the rationale for this DOAC is not working in acutely prophylactic, acutely medical illness, while it works for treatment, and it works for atrial fibrillation prophylaxis, while it doesn't work with valvular atrial fibrillation? So what's the rationale behind that?
Yeah, it's a good question. I don't think we know, right? As you said on the AFib, I think, well, the valvular and the mechanical valves, and likely there will be some issues with the, it's mostly about that on the efficacy side, right? That maybe they don't manage to be as, I don't know, exhaustive or as comprehensive than the warfarin is at inhibiting all the factors, and maybe that plays a role or something like that. In medical patients prevention, likely it sounds that it's mostly the risk of bleeding, right? And the same that was alluded to before about, risk, or it was Dr. Monagle discussing risk of bleeding in young females, taking DOACs, and in terms of heavy menstrual bleeding and things. We know it looks like the DOACs have a tendency to make mucosa bleed, right? A bit more than, DOACs have worked very well for prevention of VTE after orthopedic surgery, for example, but that's bone, right? But they didn't go much into the general surgery field or the urology field. And so I think maybe that's why. Maybe that's tendency to a bit more bleeding from the mucosa, and that in a medical patient who is getting procedures, who is getting some, I don't know, infections and inflammation, could be that that's a reason why they tend to bleed more than the low-weight heparin, but I don't think we have the exact answer.
Just to keep on time, the last question from here.
Yeah, thank you. My question to Prof. Malango. Thank you for the very informative presentation. My question regarding the challenges facing viral-based hemophilia gene therapy. Is there any progress in non-viral-based gene therapy like CRISPR technology? It did show some success in other diseases like sickle cell disease?
Sorry? Oh, yes, yeah. Thanks for clarifying that, moderator.
Talk about the CRISPR technology.
Yeah, thank you very much. It's a very important question, and some of us, in fact, are extremely excited that AAV-based gene therapy is just the beginning. In fact, there should be soon phase 1 data being presented for the CRISPR-Cas-based gene therapy. It is beyond proof of concept. It works in non-human primates. And one obviously is looking forward to those results being shared. Some of those results will be shared at ASH in this year, and some of those results will be shared in the 2 congresses next year. There is, of course, other modalities other than AAV. As you know, there is lentiviral-based gene therapy. There is nanoparticle-based gene therapy, all of which, in my view, are progressing rapidly. So if you're thinking about alternative to AAV, there are many of those alternatives. And most of those alternatives, in fact, are beyond the proof of concept. They are going to be seen in humans very soon.
Thank you.
Thank you. Thank you to our speakers, either here on the stage or on air. And I leave the floor for Ashraf.
So thank you very much for sharing your talks with us. It was great listening to you. We'll move on to our next speaker, Dr. Al-Fadil Al-Shaybani. He's a consultant hematologist and oncologist at King Faisal Specialist Hospital and Research Center, Riyadh. And he will talk about unraveling the role of CCR4 as a therapeutic target in cutaneous T-cell lymphomas.
Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Al-Fadil Al-Shaybani. Okay, here we go. So today what I'm going to talk about is basically unraveling the role of CCR4 chemokine co-receptor 4 in targeting basically in cutaneous T-cell lymphoma. This is my disclosure. We'll start by cutaneous T-cell lymphoma overview. As you know, when it comes to systemic B-cell, systemic lymphoma, majority are actually B-cell lymphoma, around 80–85%. 15% accounts for the T cells and NK cells. When it comes to cutaneous T-cell or cutaneous lymphomas, exactly the opposite. Majority of cases are actually T-cell lymphoma, what we call it cutaneous T-cell lymphoma, which accounts for around 80% of the cases. For the rare minority of cases, 20–25% cutaneous B-cell lymphoma, and those even B-cell lymphomas, urinary, they are indolent, they are very responsive to localized therapy. Our focus today will be about cutaneous T-cell lymphoma. So this is the latest WHO EORTC classification of cutaneous T-cell lymphoma. Majority of these cases are actually under the category of mycosis fungoid Sézary syndrome, accounts for around 70% of the cases. Then you have other lymphomas that can mimic mycosis fungoid and Sézary syndrome, such as adult T-cell leukemia lymphoma, which we don't see here in the region. It's usually in Japan and in the Caribbean. You have the extracutaneous NK T-cell lymphoma, which can share a similar morphological appearance of mycosis fungoides and Sézary syndrome. So Sézary syndrome is a multi-compartment disease. Majority of the cases, yes, stick to the skin. Okay, it involves the CD4 memory cells of the skin. However, the disease can spread to lymph node, can spread to the blood, and can spread to the viscera as well. On an initial assessment and subsequent assessment by a lymphoma doctor, these sites should be reassessed for the presence of the disease because the treatment really varies, depends on what stage you're dealing with. Majority of cases are actually limited, but around third of the cases, they go beyond the skin. So chemokine co-receptor 4 is a marker that is present in many cells, in T regulatory cells, in CD4 homing T cells, in cutaneous lymphocyte antigen T cells, etc. This chemokine receptor 4 is highly expressed in mycosis fungoid and Sézary syndrome, and it's present as well in adult T-cell leukemia lymphoma. Actually, the treatment mogamulizumab for cutaneous T-cell lymphoma was started initially on adult T-cell leukemia lymphoma cases. This marker, CCR4, it's a ligand for CCL17 and CCL22. This has a very important pathophysiology in cutaneous T-cell lymphoma cases. This is basically links the blood compartment to the skin compartment, and this is how the malignant cell infiltrate. As you can see here in the picture, CCR4 interact with CCL17, CCL22, and this step considered crucial for migration from the blood component to skin component and to the pathophysiology of the disease. This marker is highly expressed in mycosis fungoides and Sézary syndrome, and this is how you can see it in here. In minority of normal, healthy-looking T cells, it's expressed around 20%. But however, when it comes to the disease, it's a higher frequency. Because this CCR4 is an important target for therapy, it's an important pathophysiological, has an important pathophysiological role in the progression of the disease. This is a target for an excellent medications, and several medications target CCR4, and we'll come to this. For example, mogamulizumab, which I'm going to talk about today, is a target CCR4. Pixarotene retinoid, which is commonly used in a less advanced disease, again suppresses CCR4 expression, as well as vorinostat. Vorinostat actually because vorinostat is a histone deacetylase. Deacetylhistone increases wrapping of DNA around the histone, decreases the expression, subsequently decreases CCR4 expression. So let's dive more into mogamulizumab. Mogamulizumab is an anti-CC4 antibody. It basically binds to CCR4 on the malignant cell and basically recruit natural killer cell to release cytokines to kill the cells, or in another way, it's an antibody-dependent cellular cytotoxicity mechanism of action. The study that put mogamulizumab on the map is basically the MAVORIC trial. In this trial, patients with from stage 1B to stage 4B, histologically confirmed mycosis fungoides and Sézary syndrome, who at least progressed through one line of therapy, who had an adequate performance status, were randomized to receive either mogamulizumab or vorinostat, and the treatment continued until progression of the disease or untolerated toxicity. Please note that CCR4 expression was not mandated in this trial, so in reality we don't test for this medication, for this marker. If you look here to the baseline characteristic of the study, actually it was well balanced between vorinostat and mogamulizumab in terms of age, in terms of performance status, in form of whether this is a mycosis fungoid or Sézary syndrome, and even when it comes to the clinical stage of the disease. The median number of prior systemic therapy was around 3. And the primary endpoint for this trial was the progression-free survival. As you can see here, mogamulizumab is superior to vorinostat when it comes to median progression-free survival of around 7 months compared to 3 months. And this is a common theme when it comes to cutaneous T-cell lymphoma in general. With other lymphoma, with other systemic lymphoma, diffuse large B-cell lymphoma, Hodgkin lymphoma, etc., your target here is cure. However, for cutaneous T-cell lymphoma, unfortunately, cure is not attainable unless you do an allogeneic stem cell transplant. Other modality, sort of prolonged remission, switching between therapies, taking the therapy that has the most higher chance of CR and longest duration of CR as well. And this is where mogamulizumab excel at. If we look here to the subgroup analysis, it really doesn't matter if the patient is age is young or old. I have to mention that the median age here in this trial was around 60, 65. This is opposite to what we see here. Majority, I can tell you from my experience, we do have a multidisciplinary cutaneous T-cell lymphoma clinic in King Faisal where we get referrals from all over the country. And the median age I can see here is 40, around 50, 30 years of age. So the age difference, I would say, is different than the Western population. You see responses whether this is a mycosis fungoid or Sézary syndrome, and of course, the more advanced the stage of the disease is, the higher the response. So looking here into the overall response rate, the overall response rate of mogamulizumab was around 30% compared to around 4%. And this is higher as you go. So stage 4 disease actually is around 40%. Median duration of response is actually as well longer with mogamulizumab compared to vorinostat. If we look to the compartment, all the compartments show the response, but the highest seen in blood compartment. And this is something that we'll see in subsequent slides. Patients with Sézary syndrome who have a high Sézary cells in peripheral blood, they do have a higher response to mogamulizumab in comparison to any other agent. This is the best. This is a waterfall plot for the best skin responses. As you can see here, it's highest with mogamulizumab. When it comes to safety, side effects leading to discontinuation of the therapies occur around 20% of the patients. This is mainly a skin reaction, skin ulcerations, or infusion reactions, leading to death around 1% only of patients who took mogamulizumab. When it comes to the safety, the drug is pretty safe. For infusion reaction, it happens around 30% and usually happens with the first couple of doses. A skin eruption can happen as well in 20-30% of cases. This typically happens 3 months, 6 months on treatment, does not happen with the start of the treatment. And this actually correlates with the response, especially with patients with Sézary syndrome. This is similar to the common phenomena with cetuximab, with other targeted agents in solid tumor. So in summary, for MAVORIC trial, this is the first randomized 3 trial that looks into the patients with cutaneous T-cell lymphoma, and the progression-free survival was the primary endpoint. Mogamulizumab was associated with a higher response rate in all compartments, especially in blood compartment, in which you're talking about 70% compared to 20%. Several post-hoc analysis was done on this MAVORIC trial, which looked into many different aspects of patients' population. For example, the number of prior systemic therapy. For mogamulizumab, it doesn't matter whether this is the first line of treatment or this is the 3rd or 4th line of treatment. This is opposite to the ECP, extracorporeal photopheresis, in which there are evidence that it should be incorporated. If we're going to use it for a Sézary syndrome, it should be incorporated within the first 2 lines of therapy. Beyond that, the efficacy of ECP in treating Sézary syndromes is less evident. When it comes to mogamulizumab, is seen across, regardless of the number of prior therapies. This is, you can see it here, you see responses whether the patient received a targeted agent, romidepsin, methotrexate, interferon, ECP, pixarotine. You still continue to see responses with mogamulizumab. Time to next treatment, because higher progression-free survival with the mogamulizumab, time to next treatment with mogamulizumab is longer, as expected, and this is, you can see it as well, and with the higher the stage of the patient, the longer duration of response. So stage 3 or 4, their median time of response was around 12 months. What about concomitant steroid use? Cutaneous T-cell lymphoma, because it involves many compartments, we usually combine systemic therapy with the skin-directed therapy. Part of the skin-directed therapy is steroids, which can be applied locally, and sometimes even in acutely ill, itchy patients, you can give them oral steroid just to alleviate the itchiness and improve the patient's symptoms. So the question that was raised, whether really concomitant steroid, can it really dampen the response of mogamulizumab or not? And the opposite is true. Actually, giving steroid with mogamulizumab increases the response rate of mogamulizumab, as opposite to vorinostat. If you look here, patients who were on steroid, if they took vorinostat, steroid does not really affect the outcome of varinostat, but however, it does affect the outcome of mogamulizumab. And this is because you're targeting many different compartments at the same time. You're targeting the skin component. Mogamulizumab is helping with that as well, and you're targeting the blood component as well. So, so here, the higher the stage, this is a common phenomenon that we see. Higher the stage, the higher the responses to mogamulizumab, and overall response rate with higher with mogamulizumab treated patients receiving concomitant steroid relative to the intention to treatment population. Patients still, as I mentioned, patients who were on steroid and received concomitant mogamulizumab had a higher response rate than a patient who did not. And there is really, when it comes to safety profile, concomitant steroid is pretty safe, did not really alter the side effect expected with the treatment. What about the efficacy and safety on a blood classification, which is basically the main focus of, one of the main focuses of this treatment, because honestly, when it comes to Sézary syndrome, when you have a Sézary syndrome more than 1,000 in peripheral blood, there are really limited options that you can use for these patients. Unfortunately, chemotherapy does not work on those patients. ECP takes around 3-6 months to respond. Mogamulizumab has actually a good outcomes when it comes to blood component, and we're waiting for more and more medications targeting mainly blood component. As you can see here, the higher the B involvement or blood involvement, the higher the response rate to mogamulizumab. As you can see here, B2 more than 1,000 Sézary cells in peripheral blood. The response rate and the duration of response is actually longer, close to 1 year, which is something unheard of when it comes to Sézary syndrome and high peripheral blood involvement. Mogamulizumab looked into the efficacy as well. If you can see here, this is the number of overall response rate. The overall response rate is higher with higher blood involvement. And this basically underlies the importance of doing flow cytometry for majority of patients with peripheral T-cell lymphoma, because you really want to know the percentage of Sézary cells in peripheral blood. This can direct your therapy, whether to go with Moga or to go with other agents. As you can see here, mogamulizumab, the time to next treatment, it's longer with mogamulizumab compared to varinostat. And this is the Kaplan-Meier curve, especially in patients with B2. As you can see here, the curve here is the separation of the curve is more evident in patients with a high Sézary syndrome. Patients who do have high Sézary cells involvement in peripheral blood, they do respond better, even when it comes to other components. The higher skin responses in patients with a high blood component. One of the, let's say, acknowledgeable or noticeable side effects of mogamulizumab is a skin rash, and this can be confusing sometimes because cutaneous T-cell lymphoma patients, they do present with a skin rash, they do present with itchiness. And when patients develop a skin drug rash related to mogamulizumab, it sometimes becomes challenging for physicians to know whether they are dealing with a skin rash related to mogamulizumab or actually this is a progression of the disease. So let's look into the drug rash associated with mogamulizumab. This happens in around 20% of patients, leading to discontinuation of around 7% of patients. Majority of patients, even if this happens, you can give them steroid, hold the medication for some time, resume the medication, and they have a good tolerance to the drug. As I mentioned, it happens around 20% of the patient, the drug rash. However, leading to discontinuation of the treatment happens in only 7%. Taking a skin biopsy is very important in these situations to figure out whether you're dealing with a drug reaction versus an actual disease of progression. And this happens as well it's higher with Sézary syndrome compared to mycosis fungoid. Good to know that in the trial they did not notice any Stevens-Johnson syndrome or toxic epidermal necrolysis. Actually having the presence of drug rash correlates with a higher response, especially in patients with Sézary syndrome. So the proportion of Sézary syndrome responders who developed a drug rash was significantly higher than responders without rash. So developing the skin rash on patients who have Sézary syndrome may give you a hint that this patient is actually responding to the treatment. But however, you need to address the drug rash first and then continue on the treatment. This is not true when it comes to mycosis fungoides, so there is really no difference in a responder who developed rash versus a responder who did not. Overall, the median time, as I mentioned, for developing a drug rash is around 106 days, around 3 months. The initial drug rash occurred after responses to mogamulizumab. However, majority of those patients can continue on the treatment and can resume the treatment. This leads to discontinuation of the medications around 7% of patients only. How to manage these skin rashes? If this is a grade 1, you're allowed to continue the treatment and use topical steroid. But however, if it's grade 2 or higher, this treatment should be stopped for sometimes give topical steroid. I sometimes use even systemic steroid, though in the trial was prohibited for sometimes until the skin rash is under control, and then resume again mogamulizumab. And for my own experience, I've seen good responses with this methodology. Quality of life is a very, 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 very important measures when it comes to patients with cutaneous T-cell lymphoma. Remember, this is a very disfiguring disease. Patients, they do have a huge psychological burden when it comes to the disease. This is a disease that patients continue scratching all day long. Their face may be disfigured. People are looking to them at the street. They cannot go outside. They cannot socialize. So this quality of life is a very important metrics when it comes to the treatment of any patients with cutaneous T-cell lymphoma. And when it comes to the assessment, the skin dex 29 symptoms, which basically looks into many of the skin component and quality of life components. This was higher in patients treated with mogamulizumab. Of course, this takes some time, so you don't expect it to happen within 2 weeks or 1 month. The patients start to notice an improvement after a couple of months of treatment. As you can see here, when it comes to emotion, it's higher on patients who took or received mogamulizumab. So in summary, CCR4 is an important receptor for skin trafficking T cells, and this marker is highly expressed in all mycosis fungoides and Sézary syndrome. Mogamulizumab is the first in-class human anti-CCR4 monoclonal antibody that demonstrated efficacy over a standard of care vorinostat in previously treated patients, especially in blood component, in which you see a response around 70% of patients. Mogamulizumab is associated with a higher quality of life, as well as higher response rate. Rash is common with mogamulizumab. However, it leads to discontinuation of the treatment in minority of cases, and mogamulizumab can induce a long-term remission in preclinical models. This is my presentation, and thank you.
Thank you, Dr. Shebani. Any question to Dr. Al-Fadl, either physically or from the virtual attendees? Yes, please. If you can pass the mic.
Yeah, thank you, Dr. Al-Fadl, for your nice talk. So my question regarding the patient enrolled in the study for using MOGA. Is there any cut limit for the age, or only ECOG is enough?
Okay, No, there is no cut limit. Usually, ECOG was was mandated when it comes to the clinical trial itself. However, we know that majority of patients, unfortunately, when I see them, at least my own experience, when I see them in the clinic, they come late. The referral comes late to my clinic. Majority of those patients, their poor performance status is secondary to the disease itself. So what I do, I usually use sort of like steroids, something to get the disease under control, to get them into a better shape. And then I introduce, if there is a high blood component, Caesar cells more than 1,000, I introduce mogamulizumab. Sometimes I can sometimes use interferon, methotrexate to get the disease under control a little bit, try to target the skin condition first, get them into a better shape to tolerate the treatment. But for your question, there is no age cut limit.
Thank you.
I see there is no other question, so thank you, Dr. Shibani. So we'll conclude the first session for now, and we'll have prayer break as well as lunch. Lunch will be served at 12 noon, and we'll be reconnecting at 2 p.m. Saudi time. So thank you all.
Hello, everybody, again. I'm honored to assume the role session that I introduce Professor Armando potential are truly impressive. Molecular biology at the Faculty of Medicine at Prof. Tribudi is active thrombosis as a chair, co-chair, president, and member of several influential committees. Additionally, his prestigious academic journals. He's very active in publication with more than 400 articles, books, chapters, and reviews. In the interest of time, I will now conclude my remarks. Professor Tribudi, please proceed with your talk.
My first slides? Okay, that's fine. Thanks very much for, I'm very pleased to be here connected with you, and I wish to thank the organizers for this invitation. These are my disclosure for this talk today. As you probably know, over the last 20 years, the so-called coagulopathy of chronic liver disease underwent dramatic changes. And in fact, up to 2005, cirrhosis was recognized as the epitome of the acquired hemorrhagic diseases. And in fact, we know very well that cirrhosis is characterized by impaired synthesis of all coagulation factors, with the exception of factor VIII and molecular factor. I will come later on this aspect. And also, cirrhosis is associated with thrombocytopathy, thrombocytopenia, and probably hyperfibrinolysis. As a matter of fact, these complex defects have been historically documented in the laboratory through the measurement of the prothrombin and activated partial thromboplastin time, and also the skin bleeding time was used, and platelet count, and also finally the measurement of the fibrinolytic components of this system. Unfortunately, there was a dogma until recently on this aspect, as shown by the fact that the concept of a causal relationship between abnormal hemostasis and bleeding, which was widely accepted, as shown by the common practice to screen patients with hemostasis test, and finally to treat them in order to correct the abnormality prior to invasive procedure or surgery. Starting from 2005, this dogma has been challenged, and the new concept of rebalanced hemostasis has been introduced. There are at least 3 issues which can be taken as evidence challenging the dogma. Let's see first the clinical challenging of this dogma. We know very well that gastrointestinal bleeding is the most common hemorrhagic event in cirrhosis. But on the other hand, we know that the conventional coagulation tests do correlate poorly with the gastrointestinal bleeding in these conditions. And finally, as was shown by Dr. Massicot some years ago, coagulation defects do not predict blood product requirement during liver transplantation. And in fact, there were several evidence of a poor correlation between conventional hemostasis test and bleeding in cirrhosis. This is a review of the literature. I'm particularly interested in the first paper published by Dr. Eve in 1981. You see a figure from that paper. You know that the author tried to measure the liver bleeding time, that is the bleeding time directly on the liver during a laparoscopic liver biopsy in a patient. And he also tried to correlate the liver bleeding time with the peripheral prothrombin time. And as you can see here, there was no correlation at all. Now, one may wonder why PT and APTT are not correlated with the bleeding during liver biopsy. We thought about this apparent paradox, and we came to the conclusion some years ago that PT and APTT do not reflect the in vivo coagulation balance that occur in vivo, particularly in acquired coagulopathies such as cirrhosis, where in addition to the procoagulants, also protein C and antithrombin are reduced to the same extent. And finally, protein C in vitro is activated to a limited extent in the absence of thrombomodulin. You know that thrombomodulin is located on endothelial cells and much less in plasma. And in fact, protein C is activated by thrombin on the membrane of endothelial cells where there are some receptors. The first one is the EPCR, which is the receptor for plasma protein C. Very close to the PCR, there is another receptor which is called the thrombomodulin. This is this receptor for free thrombin. And because of these two receptors, the substrate protein C and the enzyme thrombin will come to a close contact, and therefore protein C will be quickly activated. And finally, the activated protein C in combination with its cofactor protein S is able to form a complex, and this complex is eventually able to inhibit the activated forms of factor VIII and factor V, thus quenching thrombin generation. For many years, it has kept the attention that the plasma reagents needed to perform PT and APTT do not contain thrombomodulin, and therefore this assay, this test are not valuable in the context of an acquired coagulopathy such as cirrhosis. Essentially, we can conclude this part of my talk today saying that probably PT and APTT are responsive to procoagulant factors, as you can see here, which correspond to the ascending arm of the thrombin generation curve. But PT and APTT are much less responsive to the anticoagulant factors, which are shown here by the descending part of the thrombin generation curve. So essentially, PT and APTT can tell us whether a patient is deficient in one or more procoagulants. That's why they are used in hemophilia and allied disorders, but they cannot tell us whether this deficiency is counterbalanced by a concomitant deficiency of the anticoagulant factors, which happens in acquired coagulation disorder, such as chronic liver disease. The second evidence challenging the dogma is pathophysiological. I'm very brief here. You know that coagulation is the result of the action of procoagulants, which are contrasted by the anticoagulants. But we know that the pro and anticoagulant factors are concomitantly reduced in cirrhosis. So there should be a rebalance of coagulation in this condition. And finally, what is the laboratory evidence challenging the dogma? In 2005, we first demonstrated, provide evidence of normal thrombin generation in cirrhosis, despite the fact that this patient may have abnormal conventional coagulation tests, such as PT and APTT. And in fact, we investigated thrombin generation in platelet-poor plasma in these patients. And as you can see here, in the absence of thrombomodulin in the system, patients displayed significantly reduced level of thrombin generation with respect to the controls. And this was completely expected because it reflects the partial deficiency of procoagulants in these conditions, which is not counteracted by the partial deficiency of anticoagulants because here there is no thrombomodulin in the system. And in fact, when we repeated this experiment by introducing a soluble thrombomodulin in the system, as expected, control population generated much less thrombin, and this was expected because actually in the control population in this system, we activated massively protein C, and therefore thrombin generation was reduced. But actually, even in cirrhotic patient, the thrombin generation was reduced to much lesser extent, as you can see here, so that there was no longer statistically significant difference between controls and cirrhotic patients. We interpreted this result as the evidence of a balanced coagulation of in cirrhosis whenever you add thrombomodulin in the system. Later on, these results were confirmed by Dr. Lisman. He published normal to increase thrombin generation in patients with liver disease, and also by Dr. Gatt in another study which was published very soon. So in summary, we can say that coagulation is not abnormal in cirrhosis, provided that it is assessed with global tests reflecting the function of pro and anticoagulants. And what are the consequences of these findings? There are at least two important consequences which may be of interest for the audience. First, there is little value of PT and APTT to assess the bleeding risk in this patient. And second, the common practice of prophylactic infusion of hemostatic agents in this patient should be reconsidered. And in fact, I looked at the literature over the years, and you can see that there were at least 4 randomized clinical trials using recombinant factor 7A to try to stop bleeding in patients with cirrhosis. 2 of these trials were on variceal bleeding, and the other 2 were on transplantation. Now, in all these trials, there was a poor efficacy of recombinant 7A to stop bleeding in this patient. And this supports the concept that thrombin generation is normal in vivo in these subjects, and therefore there is no need to, optimize the thrombin generation in this patient, in spite of the fact that recombinant 7A is actually effective in shortening the prothrombin time in this patient, but no clinical effect. What about the role of platelets? Because we know that patients with cirrhosis are thrombocytopenic, and platelets, we know they have a role in hemostasis. First of all, platelets adhere to the site of vessel wall injury to the subendothelial matrix, and this addition is potentiated by von Willebrand factor, which is heavily increased in patients with cirrhosis. And the second role of platelets is in thrombin generation, because as you can see here on the surface of activated platelet will adhere some vitamin K dependent coagulation factors which speed up thrombin generation in this mechanism. So Tom Lisman again some years ago provide evidence that elevated levels of von Willebrand factors may compensate for the functions of a number of platelets in cirrhosis. In other words, patients with cirrhosis are thrombocytopenic, but because of the increased levels of von Willebrand factor, which is the adhesive protein, this defect is partially compensated. And this was demonstrated in a flow system, which is mimic more or less what happens in vivo. The year later, we produced evidence on the role of platelets in thrombin generation, and essentially we concluded from our experiment that platelets from patients with cirrhosis seems to be qualitatively adequate to support thrombin generation, provided that the number is adequate. Finally, I would like to convey with you this cartoon, which is a sort of summary. In the healthy subjects, the balance of coagulation is very stable because in this subject there is a great excess of procoagulants, anticoagulants, and platelet. But in cirrhosis, the situation is quite different. The balance of coagulation is very unstable because here we have a partial deficit of procoagulants, anticoagulants, and platelets, and therefore the balance may tip towards hemorrhage or thrombosis in the same patients, depending on the prevailing circumstantial risk factor to which the patients are exposed. So now the question would be, why do patients with the cirrhosis occasionally bleed if thrombin generation and hemostasis is rebalanced? There could be 2 explanations. The first one, as I mentioned, is that the restored hemostatic balance in cirrhosis is not very stable as it is in healthy individuals, and therefore steroid alteration may lead to hemorrhage or thrombosis. This seems to be paradoxical, but it's the situation which happens very often. And also, we should understand that there may be underlying conditions in cirrhosis which may favor bleeding. For instance, you know very well that portal hypertension may be a cause of bleeding, for instance, for varices. Endothelial dysfunction, bacterial infection, may be hyperfibrinolysis, and renal failure may be additional factors triggering hemorrhage. So I would say that the therapeutic intervention correcting these abnormalities probably are much more effective than correcting the coagulopathy itself. And finally, the last part of my presentation is concerned with the cirrhosis as a prothrombotic condition, which started to emerge at least 10 years ago. The first evidence of this fact is this epidemiological observation made in 2006 by Dr. Northup in the United States. They show that the coagulopathy does not fully protect hospitalized patients with cirrhosis from peripheral venous thromboembolism. Following this first paper, there were at least two case control studies, population-based case control studies made in Denmark, which showed as a conclusion that patients with the cirrhosis had a relative risk of venous thromboembolism, which is close to 2. And when the analysis was restricted to unprovoked VTE, the relative risk was even higher. And the last paper in this aspect, epidemiological evidence, is this paper in which the authors investigated the risk and outcome of venous and arterial thrombosis in patients with the cirrhosis, again, in Denmark. Essentially, the authors found that the relative risk of venous thromboembolism in this patient is nearly 2, as you can see here, with the relatively tight confidence interval. And they also found that the compensation increased the risk of acute myocardial infarction. And finally, following thrombosis, patients with the cirrhosis seems to have a higher 9-day mortality than non-cirrhotic patients. So what are the implications of the procoagulant imbalance in cirrhosis? First of all, I would say that the secondary prevention of venous thromboembolism with vitamin T antagonist or weight heparin should be more extensively used whenever there is indication in patients with the cirrhosis. I must remember the audience that until recently, the use, for instance, of vitamin K antagonist was strongly contraindicated in this patient. And also, we believe that the primary portal vein thrombosis prevention should be considered in patients awaiting for liver transplantation. And in fact, there were some clinical trials assessing the value of this prophylaxis. And Dr. Villa, in fact, published some studies some years ago in which she demonstrated that the use of low molecular weight heparin is really useful to prevent PVT in patients awaiting for liver transplantation. And also, I would say that some other non-coagulation thrombin effect should be considered in patients with the cirrhosis. Thrombin may have some other effects which are not directly related with coagulation, and this should be taken into consideration in this patient. And I hope that there will be future research in this field. And these are my take-home message, and I conclude my presentation today. According to the evidence I showed, the concept of rebalancing hemostasis questions quite dramatically the old therapeutic strategy in cirrhosis, so this should be reconsidered. For instance, there is no value to screen patients with PT and APTT because these are not valid in this context. And there is also no value to correct the abnormal hemostasis prior to surgery, as I shown before. And patients with cirrhosis finally are not naturally anticoagulated, as it was believed for many years until recently. I finish here and thank you very much for your attention.
Thank you, Dr. Armando, for your extraordinary talk. Now I will let Dr. Reem Rabih to introduce our next guest.
Assalamu alaikum. Our next distinguished speaker is Professor Emmanuel Favaloro. He's the principal hospital scientist in charge of the hemostasis laboratories. He has co-authored over 700 papers and is the current editor-in-chief of seminars in thrombosis and hemostasis. On Willebrand disease, updates on new tests for diagnosis.
I'd like to thank the organisers of this meeting for asking me to speak on Willebrand disease, my favourite topic, in particular on new tests for diagnosis. My name is Emmanuel Favalora. I'm from the Sydney Centres for Thrombosis and Hemostasis at Westmead Hospital, and there's my email address should you wish to communicate with me. So I have no disclosures to make. Von Willebrand disease is the most common inherited bleeding disorder. It's actually more common than haemophilia A, but it's less well known. And it's due to a loss of von Willebrand factor and or its function. There are three main types of von Willebrand disease. Type 1 von Willebrand disease, where you have loss of von Willebrand factor, but the von Willebrand factor that remains has normal function. Type 2, where you have a loss of von Willebrand factor function, with or without a loss of VWF of level. And there are four subtypes of type 2, and I'll speak about those in the next slide. And then you have type 3, where there is no von Willebrand produced. And type 3 von Willebrand disease is the most serious or severe form of von Willebrand disease. In type 2 von Willebrand disease, there are four subtypes. You have type 2A, where you have a loss of high molecular weight VWF, and high molecular weight VWF is the most adhesive form of von Willebrand factor, or the most functional. In 2B, you have a hyperadhesive form of von Willebrand factor, where VWF binds spontaneously to platelets, leading to clearance of high molecular weight VWF and also platelets, so you might get a mild thrombocytopenia. In 2N, von Willebrand disease, you have a loss of factor VIII binding, so the factor VIII degrades very quickly, so you have a low level of plasma factor VIII. And 2M, where you have a loss of von Willebrand factor function that's not associated with a loss of high molecular weight VWF. A lot of people have difficulty with the 2M type. Essentially, it's a diagnosis of exclusion. So if you don't have type 1, type 2A, 2B, 2N, or type 3, then by definition, you have type 2M. So von Willebrand factor is an adhesive plasma protein that has binding sites for various agonists, various ligands. You have a binding site for platelet glycoprotein 1B, the VWF receptor on platelets. You also have binding sites for collagen, and also platelet sites, binding sites for factor VIII. So all these binding sites contribute to the functionality of von Willebrand factor. And if you have a deficiency of von Willebrand factor or defect in von Willebrand factor, then you have bleeding because you have von Willebrand disease. And on the right, I'm just showing you a simple cartoon where you have platelets attaching to the site of vascular injury, because the platelets will bind to von Willebrand factor, which binds to the collagen subendothelial matrix component, and it will arrest platelets at that site of injury, and then you get a formation of a platelet plug through formation of von Willebrand bridging platelets to damaged endothelium and also to each other. So if we look at the global pattern of bleeding disorder reporting, this is data from the World Federation for Haemophilia Annual Global Report 2021. And on the right, I'm showing you a graph which suggests the percentage of estimated that are reported in different countries. And if you look at developed countries, and the reported level of estimated is actually very close. In other words, the reported numbers of bleeding disorders are very close to the estimated level of in developing or Asia Pacific, and sometimes in Middle Eastern countries, there's a potential for underreporting of bleeding disorders. So I've just shown you some example of countries there, and Saudi Arabia is shown in the red bar. If you look at the global pattern of von Willebrand disease diagnosis, it's similar. So in developed countries, you have similar levels of von Willebrand disease and haemophilia reported. So the ratio of haemophilia to von Willebrand disease is approximately 1. In developing countries, Asia Pacific countries, Middle Eastern countries, the number of patients with haemophilia reported is much greater than that of von Willebrand disease. So the ratio inevitably is greater than 1. In some of those countries, for example, in Indonesia, the ratio can reach up to 150. And I've also shown Saudi Arabia in that graph as well. If we look at the main assays that are used to diagnose von Willebrand disease, I've just shown you a table here. You have factor VIII coagulant, you have von Willebrand factor antigen, and then you have a number of activity-based assays. The glycoprotein 1B binding activity assays that include racine cofactor, glycoprotein 1B binding using recombinant glycoprotein 1B, glycoprotein 1B binding using recombinant mutant glycoprotein 1B, von Willebrand factor collagen binding, factor VIII binding assay, And then you have the classical risk-induced platelet aggregation, and also you have multimers, VWF multimers. And I'll talk about some of those, in particular the newer assays, the glycoprotein 1b binding activity assays, and collagen binding using an AccuStar assay. In terms of guidelines, there are a number of guidelines now available, with the latest guidelines published in Blood Advances in 2021 by James et al. And they differ in terms of the recommended test panels, initial test panels. The US guidelines and the latest guidelines recommend an initial 3-test panel. The British guidelines recommend an initial 4-test panel. In our laboratory, we actually use an initial 4-test panel, and that is our actually recommendation as well. The guidelines also differ in terms of the cutoff for type 1 versus type 2, being 0.5, 0.6, or 0.7. And they also differ in terms of the test panels that are recommended by those guidelines. And I'll briefly talk about, in particular, the latest guidelines. So the latest guidelines actually have an algorithm which they proposed that laboratories use. I won't talk about this algorithm. We don't particularly follow this algorithm because we use a 4-test panel, not a 3-test panel. And I'll talk a little bit about that as well. In terms of some of the recommendations, I'm only showing selective recommendations from the guidelines. One of the recommendations that they suggest you're using in the newer assays that measure the platelet binding activity of von Willebrand factor, in other words, the glycoprotein 1bm, the glycoprotein 1br, over the risk-seeking cofactor assay, automated or not automated for von Willebrand diagnosis. Another recommendation is that they suggest against using a platelet-dependent VWF activity to antigen cutoff of 0.5, instead using a cutoff of 0.7. In our laboratory, we actually use a cutoff of 0.6. And that would be our recommendation, unless you could see that 0.7 is actually better. They also suggest using either von Willebrand factor multimer analysis or collagen binding to antigen ratio to help diagnose type 2 von Willebrand disease for patients who are suspected of type 2A, 2B, or 2M, and we think that's a good recommendation. They suggest targeted genetic testing over low-dose risk-induced platelet agglutination to diagnose 2B von Willebrand disease for patients suspected of type 2A or 2B in need of additional testing. We think that can use RIPA analysis, and we actually use RIPA analysis and mixing studies ahead of genetic studies in our laboratories. And genetic studies are not always available in all countries. And they also suggest using either a factor binding assay or targeted genetic testing whenever available for suspected 2N von Willebrand disease, and we think that's a good recommendation. So before I talk about some of the new assays, I think it's important to talk about some of the older assays and some of the standard assays. VWF antigen, historically formed by ELISA, now mostly by latex nation, and that's an example I'm showing on the card to the right. Sometimes on the AccuStar, for example, is performed in our laboratory. Now, von Willebrand factor antigen provides an estimate of the level of von Willebrand factor in plasma, and every lab that tests the von Willebrand disease should perform this assay. However, it has limited utility on its own. A normal VWF antigen, some type 2M, 2B, and platelet type von Willebrand disease will have normal levels of VWF antigen, and an abnormal von Willebrand factor antigen does tell you what type of von Willebrand disease it is. It may be a type 1 or type 2. So you must also perform assays for VWF activity. So the first class of assays typically performed as agglutination assays. Sometimes you can perform other systems, for example, the AccuStar. And there are now three different types of assays. The classical risk-seeking cofactor assay, the glycoprotein 1br, recombinant, and the glycoprotein 1m, mutant. They're all binding assays. Glycoprotein 1b binding assays. And every lab that tests von Willebrand disease should perform one of these assays. However, these have limited utility on their own. A normal level may not exclude all forms of von Willebrand disease, for example, TB and platelet type von Willebrand disease. Some patients will give normal levels of glycoprotein 1b binding. And an abnormal level doesn't tell you what type of von Willebrand disease you have. You may have type 1 or type 2. So you must also perform levels for VWF, antigen, and factor VIII at the minimum. So the first of the glycoprotein 1b right, so typically performed B, you add succeeding, that unfolds. on the AccuStar theoretically has lower assay variability and possibly better low VWF sensitivity than certain cofactor. And it's recommended as I indicated by the latest VWD diagnosis guidelines. And I'm showing you as an agglutination assay. The other assay is a more modern alternative, is the glycoprotein 1B, which stands for mutant. So this is a gain of function glycoprotein 1B that's used in this assay. Typically performed by latex agglutination assay, particularly if you're talking about the commercial automated assay, but sometimes can be performed as an ELISA. Theoretically has lower assay variability and possibly better low VWF sensitivity than certain cofactor. And in theory, there are no false low levels or low values, VWF polymorphisms that sometimes affect glycoprotein, sometimes affect receipt and binding. And as I said, it's recommended by the latest VWD diagnosis guidelines. I'm showing you the cartoon on the right, the automated process, the automated glycoprotein 1B assay. Then there's another assay, it's a VWF collagen binding assay. Typically performed by ELISA, informed in our laboratory on the AccuStar, and I'm showing you the AccuStar on the right, and the methodology in the cartoon on the right as well. And it's important to note that this is actually an additional marker of VWF activity. And there's also the in vivo correlate, VWF tissue binding will immobilize platelets outside of injury. So in our laboratory and our recommendation is that this assay should be performed. Also will help detect the occasional rare VWF variants that are not detected using a three-test panel. And it also reduces diagnostic errors of a three-test associated with a three-test panel. I'll show you some data in a little while. Now, it can be performed selectively or in other words, at a central site. If you have a laboratory, that's great. If not performed, then you need additional strategies to circumvent diagnostic errors using three-test panels. So one of the problems with formula-bound factor testing is the lower limit of VWF detection in the assay. So some of the assays, in particular the recent cofactor assays I'm showing you on the right, cannot detect levels less than 10 units per deciliter. In other words, labs who have these assays cannot distinguish formula-bound disease type 3 from severe type 1 or 2A formula-bound disease. And it also affects the VWF activity antigen calculation. So it compromises the detection of high molecular weight, deficient or qualitative defects such as 2A, 2M, and 2B formula-bound disease. And the clear methodology performed on the AccuStar has the best lower limit detection. It can actually get down to less than 1 unit per deciliter, which is similar to what's in a factor VIII assay for hemophilia. Another main problem with assays formula-bound factor are assay variabilities, and this cartoon on the right is showing you some of the variability. Some assays are much more variable than others, and again, the cofactor is one of the more variable assays, but also in our study, the glycoprotein 1BM was quite variable, and also the collagen binding performed by ELISA is quite variable. But the least variable assays are those performed on the AccuStar or the clear methodology. And if you have a highly variable assay, then that leads to force VWF activity to antigen concordance in type 2 and also force discordance in type 1. And again, I said that clear is the least variable. This is similar slide to the other previous slide, but I'm showing you now the assay variability type 2 formula-bound disease testing, and it's actually worse than in type 1. And again, the more variable the assay, the worse type 1 versus type 2 formula-bound disease discrimination. And again, the clear methodology has the least variability, and that's shown on green in the figure on the right. But some assays are quite variable. We're seeing cofactor assay, even the modern alternatives, glycoprotein 1B and glycoprotein 1BM are also quite variable in type 2 formula-bound disease. Just a point that assay variability depends to some extent on the level of formula-bound factor. So the lower the level of formula-bound factor, then the higher the assay variability. And it helps to explain why there's greater variability in type 2 formula-bound disease, because in type 2 the VWF antigen is often above 20% or 20 units per deciliter. but the activity is often lower than 20 units per deciliter. I'm just showing you one slide on the optimal cutoff values for ratios. I indicated the latest guidelines suggest a ratio of 0.7 preferred to 0.5. We also agree that 0.7 is preferred to 0.5, but we use 0.6, and that's the ratio that's recommended by the UK guidelines, and that seems to work better with our methodology, which is a clear methodology. And in the RSPA QAP data, we could see complete separation of type 1 versus type 2 vulnerable around disease cohorts using a clear methodology and a cutoff of 0.6, and that clear separation was not achieved. Panel, as indicated, the latest guidelines suggest an initial 3-test panel. We recommend an initial 4-test panel. And if you use a 3-test panel, you're going to have a higher rate of errors than if you use a 4-test panel, about twice the error rate. It also depends on the type of vulnerable around disease. The error rate for type 2, misinterpreted as type 1, for a 3-test panel is almost is as high as 15 or 20%. So use a 4-test panel, you get much lower error rates. In terms of the best methodology, I think it's without doubt now that we recommend that the CLEAR methodology has the best methodology. And overall, in this data that I'm showing you, there were no errors associated with VWF antigen and collagen binding in the RSPA years, and only one error for glycoprotein 1BR when performed as a CLEAR methodology. And that compares to an extensive number of errors, 116 errors for type 2, misidentified as type 1, and 35 errors for type 1, misidentified as type 2, and all of those were due to other methodologies, not to CLEAR methodology, except for one error. Just lastly, I just want to mention that there are new methodologies also for VWF multimers. This shows some VWF multimers from our laboratory. I won't go through it other than to say this is a methodology using an instrument. So it's a semi-automated methodology, and it also can provide a semi-quantitative data. And this is actually a very good and reproducible methodology, and it's performed on a HydraSys system. This is just a slide showing you our own algorithm. I'm not going to go through it. It's available, and I'm happy to share a copy of this algorithm to anybody who wishes to see it. Just send me an email. I will say one thing about post-analytical. So laboratories often have difficulty in interpreting their own results. So one of the issues that we found in the RSPA QAP data is that laboratories have a problem actually interpreting their own data. This is a particular problem for type 2 vulnerable around disease, where laboratories actually misinterpreted type 2 pattern that they actually found by testing as type 1 vulnerable around disease, and it was responsible for about 40% of all type 2 vulnerable around disease. So this is an educational issue. So you need to be aware of interpretation of your test patterns appropriately. That's the end of my talk. I'm sorry that I've had to rush through the talk. You know, there was only 20 minutes that I was given to talk about newer methodologies, but I'm happy to answer any questions at the question time. Again, thank you very much for inviting me, and thank you very much for listening to me.
Thank you, Professor Favallaro. We'll keep the questions at the end of the session. Our next distinguished speaker is actually a repeat speaker, Dr. Johnny Mahalangu. Professor Johnny is a professor of hematology Hospital in South Africa, and he will talk to us about updates in treatment of rare bleeding patients.
And an absolute pleasure to talk to you about a subject which is stick around. I actually move the taking the leaf and learnings from our current experience with hemophilia. These are my essentially to introduce the concept of non-factor therapies and the unmet needs, and give you some indication of the latest results on that disorders, because I think it's opportune indications and applications of these therapies, and then perhaps and see how the non-factor therapies may change in rare bleeding disorders. I don't have to remind you that we're talking about a fairly large number of conditions. Many of you, in fact, are experts in the treatment of the. You can see here that they range from fibrinogen deficiency to factor 13 deficiency, and a range of other conditions that to use hemophilia as an anchor to indicate what kind of treatment possibilities and paradigms could be available for these conditions. Just to remind, it is bleeding into the joints, predominantly leading to chronic synovitis, leading to arthropathy, and of course joint dysfunction. We don't have a similar picture in many of these rare bleeding disorders, is that they bleed. They may not bleed into the joints, but they bleed into various tissues. And the one handle we've used very well in the context of event way. In other words, a clotting protein, whatever the clotting protein is. And particularly exciting, I think, is, and you've seen this slide in my previous presentation, is this unprecedented therapeutic landscape, and in a similar picture in rare bleeding disorders. And perhaps the reason I'm showing this is, keep in mind that whilst this is very much exciting for hemophilia, hemophilia does have a number of limitations in terms of the replacement therapies. We have the peaks and troughs, and it doesn't really matter whether you're using standard half-life or extended half-life products. In fact, the troughs are the areas of the greatest vulnerability. So for the rest of the rare bleeding disorders, if you're thinking about the replacement therapies, just bear in mind that you'll be learning the same lessons that we are learning from hemophilia, that the troughs, in fact, are the greatest enemies in our therapeutic effort. We are battling in hemophilia to achieve optimal bleed control and to increase the number of individuals who do not bleed at all, the so-called zero bleed rates. The zero bleed rates in the latest extended half-life products, and I've summarized it here, is less than 50%. And if one looks at the real-world data, in fact, it talks of even a worst-case scenario of about only a third of the patients actually achieving zero bleed rates. So whilst you're thinking about what would be the therapeutic advantages of replacement therapy in rare bleeding disorders, just bear in mind that it is possible that you may not reach the therapeutic as we have learned with hemophilia. Therapy doesn't stop bleeding at all. This is a series of studies. These are real-world data from the Thunder and the Head study. With replacement therapy, they do bleed, and they bleed, in fact, to the level where they damage the joints. And similarly, in the context of rare bleeding disorders, I want you to keep that in mind, that if you do have a therapeutic agent, it is possible that you might still encounter complications relating to the bleeds. And in fact, in the context of hemophilia, we do know that the bleeding leads to arthropathy, and impaired joint function, and it affects all joints. It really is not selective as to which joint is going to affect. What I would really want to introduce here is the concept of replacement therapy for rare bleeding disorders, bearing in mind the limitations of the replacement therapies that I've just pointed out to you. We are in an extremely exciting era in the bleedings. Have had several phase 3 studies completed. The antithrombin small molecules, in fact, the studies were published early this year. The monoclonal antibodies directed against the tissue factor pathway inhibitors are equally important, and I'm only going to mention two: the concizumab, which was published about a week ago, and mestacimab, which is currently, in fact, in phase 2 studies, going to phase 3 studies. And very early in the development is antibodies against the activated protein C. These molecules are important not just for the treatment of patients with hemophilia. In my view, they are actually agnostic to the bleeding phenotype. In my view, they should be able to treat all bleeding diatheses, including patients with rare bleeding disorder. And in fact, I just want to give you examples of how effective they are. When we do replacement therapy, there's no doubt in my mind that all of us are familiar with the complications associated with replacement therapies, amongst which is finding the veins. Veins may be difficult, they may be destroyed, infected, and thrombosed, and that applies across all bleeding diatheses. And in the non-replacement therapies, by and large, are actually given subcutaneously and not intravenously, so they do have an advantage. This is an example of how many times one has to inject replacement therapy in hemophilia when you're taking prophylaxis 3 times a week. By the age of 20, if someone is very adherent to therapy, you would have injected into these veins 3,120 times. You'll agree that veins were not meant to be injected that many times, at least not in human beings. It is my view that if we shift our mindset towards alternative way of giving these drugs, it will make a huge difference, particularly across all bleeding disorders, including rare bleeding disorders. Professor Tripodi touched on the concept of balancing or rebalancing hemostasis. We do know that replacement therapies are characterized by peaks and troughs, and it really doesn't matter whether one is using standard half-life products or extended half-life products. And what you really want is a consistent hemostasis that do not have peaks and troughs. And the non-replacement therapies, in fact, we have seen it in the context of hemophilia. They do not have peaks and troughs. And I have no doubt that many of these non-replacement therapies will be suitable for rare bleeding disorders if applied to the rare bleeding disorders with the understanding that they will provide consistent hemostatic protection, as you can see here on the right. Just examples of the kind of efficacy outcomes that one would expect for the non-replacement therapies. This is data from the phase 3 emicizumab efficacy data. There are about 8 phase 3 studies that have been completed in emicizumab. And the typical example in an inhibitor patient, we're talking about 87% reduction in annualized bleed rates. And in non-inhibitor patients on the right, we're talking about 96 and 97% reduction in annualized bleed rate. And I have no doubt in my mind that if the mechanism of bleeding in the rare bleeding disorder is mediated through thrombin generation, One could expect similar results when one is using, of course, the factor 8 mimetic, where the factor 8 is deficient or, in fact, is required. If you move on to the other non-replacement therapies, such as the fitusiran, an antithrombin molecule, this data was recently updated actually in the publication in Lancet and Lancet Hematology published early this year. It is agnostic to the phenotype of the bleeding disorder in terms of hemophilia. And I would want to argue that it's probably going to be agnostic to the bleeding phenotype of any bleeding disorder as long as the bleeding is mediated through thrombin generation. You can see the data here. In fact, one is looking at hemophilia A and B with and without inhibitor, and the reduction in bleeding rate is impressive. It's very, very much significant. And I want us to start to think along those lines, that for the rare bleeding disorders, it is time for us to start applying this concept across the bleeding spectrum rather than restricting them to the bleeding diathesis. And the one that was published in the NEJM last week, many of you might have seen it, is the concizumab. The data, again, very impressive, self-explanatory, very high efficacy in the reduction of the bleeding in patients who are receiving prophylaxis with this concizumab. By the way, concizumab is an anti-TFPR that is given on a daily basis. You might think that it adds to the treatment burden, but for some of us who are actually participating in the study, patients prefer it that way. In fact, the compliance is much better than having to give it every maybe 2 weeks or every month, because they may forget that they've given it again. And again, concizumab or any of the anti-tissue factor pathway inhibitors may well have some efficacy elements in the context of rare bleeding disorders. It's something that you need to start to think about over time. And the biggest limitation, of course, in many of these is the fact that we are not able to achieve the new goals in the treatment of bleeding diathesis. In hemophilia, we are managing to break through that ceiling of only achieving less than 50% zero bleed rates. And that is the evidence from the Haven 1 to 4. And that is actually a comforting thought that one could apply these concepts to rare bleeding disorders and achieve much higher goals than we can currently achieve with replacement therapy. And of course, joint resolution and the most difficult joints in hemophilia, as you know, are target joints. I've no doubt that in the rare bleeding disorder space, there may well be places where the bleeding is actually difficult. And with this non-replacement therapy, one can only hope that in fact will have a similar impact in refractory bleeds and bleeds that are difficult to manage. And I want to take on the concept of an evolving goals in the bleeding disorders. Up to now, we've been thinking about treating patients with bleeding diathesis only from the point of view of stopping the bleed, and in the case of hemophilia, preventing joint damage. The non-factor therapies give us the potential to allow our patients to have normal activities of daily living, but more importantly, to have their lives that are very close to the lives of patients without bleeding diathesis. And that is my hope, and in fact that we should develop the relevant tools to be able to measure that over time. It has been very difficult up to now to get the right tools to be able to evaluate the quality of life of patients. And in fact, it will also allow us, the non-factor therapies in the bleeding diathesis space, it will allow us to fully comprehend and implement the care delivery model. CARE stands for, in reality, the clinical care, the advocacy, education, and research that we need to do. What we have done up to now, almost exclusively, is the clinical care of patients. We have not had the opportunity to advocate effectively. We have not had opportunity to do research and limited opportunity to do education. And I'm hoping that, in fact, by this evolving landscape of non-factor therapies across the bleeding diathesis, we'll be able to move on to the next stages of hemophilia, of bleeding disorder care in our environment. And perhaps the single thought that I want to leave you with is the concept of a mindset shift from disease categorization as measured by the deficient clotting factor or protein to a phenotypic categorization as we understand it, in other words, bleeding and the severity of bleeding. The limitations of a disease categorization approach is that when you look at some of these rare bleeding disorders, in fact, it's sometimes very difficult to measure the protein that is missing, unless you work in a very specialized environment, such as Professor Favaloro and Professor Tripoli, who are experts at measuring these proteins. But in a routine setting, they may well be difficult. And it might be prudent on us in the bleeding community to start thinking of the evaluation of these patients in terms of the phenotype, the clinical outcomes, and the life goals that the patients would want to achieve, as opposed to what they need to, in order to stop the bleeding. Some of you might be following an exciting conversation currently at JTH, where we are proposing that, in fact, we need to reclassify the bleeding disorders over time, and we're getting exciting reaction for a number of quarters within the community. With that, in fact, I want to summarize, and I hope I've shown you that there are a number of unmet needs in the current replacement therapy in the treatment of rare bleeding disorders. And in fact, the non-replacement therapies have evolved in order to address some of these unmet needs, and they actually apply across the board of all bleeding diatheses, including the rare bleeding disorders. And I've shown and shared with you the data, at least from the clinical trials of the non-replacement therapies, that indicate that they are very efficacious in preventing bleeds, and in fact some of them are agnostic to the phenotype of the bleeding disorder. And it is my hope that they may well be repurposed in the near future to be used across a range of rare bleeding disorders. Non-replacement therapies, in my view, represent a paradigm shift in the management of the rare bleeding disorders. With that, I would like to thank you for your attention, and I'm looking forward to the question and answer.
Thank you, Professor, for this excellent talk. We will we'll start our questions. The first question is from myself to our first speaker, Dr. Armando Tripodi. What are your thoughts on using off-label PCCs and fibrinogen concentrates in bleeding cirrhotic patients?
Yes, thanks for your question. I think that the things I've said about fresh frozen plasma and platelet transfusion will also apply to PCC. I don't think that in a regular basis, whenever we deal with the compensated patients, we have to think about infusing them prophylactically with PCC or some other hemostatic agents in order to assist them during the perioperative or during invasive procedure. So I think that PCC, like any other, I would say, strategy for treatment in this patient, may apply only for the rescue therapy. In other words, if the patient is actively bleeding, then you should do something to stop bleeding. And this applies also to a patient with a chronic liver disease. So whenever the patient is active bleeding, you should do your best to stop bleeding, and probably fresh frozen plasma, platelets, or PCC, and even recombinant 7A may be useful. We are totally against the use of these products as prophylaxis before surgery or invasive procedure, because there is a lot of evidence in the literature that this procedure are really not useful and even dangerous, because, for instance, you can increase the risk of thrombosis in these patients.
Okay, thank you for your answer. My second question is about the use of thromboelastograms or ROTEMs to assess bleeding risk prior to surgery instead of using PT-PTT, which are not reflective of the bleeding risk. Would you advocate for the use of ROTEM and TEG?
Okay, thank you for these questions, which is crucial in my opinion. We have here to be very clear. I think that, and also the literature is plenty of evidence about this, we think that the use of ROTEM or TEG in order to see whether the patients are really bleeding during invasive procedure, there are no evidence for this. I mean, in other words, if you think to use ROTEM or TEG just to detect those patients that during liver biopsy, for instance, or other invasive procedure will bleed, I think that you should not use them, because there is no evidence in the literature that these devices are useful to predict bleeding in these patients. On the other hand, if your patient, again, is actively bleeding, because for some reasons, then, in my opinion, you could use the TEG or the ROTEM to make a decision about the appropriate transfusional therapy to be used in these patients, either, for instance, whole blood or platelets or fresh frozen plasma. So again, you should think about two different situations: active bleeding, where thromboelastography, TEG or ROTEM may be useful, or I would say prophylaxis, where these two devices are not useful at all, at least until the moment. Then probably if you have evidence from clinical trials, but we need randomized clinical trials, because until recently, the only experience is a personal experience in the use of these devices, but not, they are not coming from randomized clinical trials.
Thank you. We have a question from an online attendee. There are many added advantages of direct-acting anticoagulants over warfarin and heparin use in patients with cirrhosis?
Well, this is another good question. Thank you very much. I think that at the moment we have some theoretical experience that DOAC may be useful, as it was useful for many years, anti-vitamin K antagonists. So I think that at the moment we should do some more research work, clinical research work, to see whether the DOAC, the direct oral anticoagulants, are safe as the antivitamin antagonists. At the moment, there are very few clinical trials, simply because you know that the registration trial for DOAC have decided to not to include patients with chronic liver disease, because they were expected to bleed. So therefore, the research workers were not really courageous enough to include this patient. So at the moment, personally, I think that direct oral anticoagulants are very promising in the field of cirrhosis for many reasons. The first reasons could be that these drugs do not require laboratory monitoring with the INR, and we know very well that in cirrhosis, the INR is not a valid system just to monitor this therapy, because the baseline INR could be a little bit prolonged. And the second reason is that, as you know, anti-vitamin K antagonists are able just to decrease the concentration of protein C, which is a vitamin-dependent coagulation factor. And I think that in cirrhosis, protein C is already relatively low. So we would like just to increase protein C, not to decrease it. So I think that direct oral anticoagulants having no effect on vitamin K-dependent proteins such as protein C and proteinase would be beneficial in this context. But again, we have to provide more evidence in clinical trials.
Thank you. Any more questions for our first speaker? Okay, so we'll move on to the next speaker. I have a question for Professor Favaloro. A lot of the hospitals here send out the multimers analysis to another country. So we are facing some results that we could not interpret. A lot of the results came back as loss of very high molecular weight multimers that could be attributed to acquired von Willebrand versus specimen issues. So a lot of our cases are pediatrics, and we're excluding acquired von Willebrand. How do we interpret such results?
So you're correct insofar as you can get a loss of the very high multimers simply as an artifact of sample preparation and sample transport. So the high molecular weight VWF molecules are the ones that are most adhesive, and they're the most easily degraded when there's some specimen preparation issues. And you can actually make samples high molecular weight deficient simply by refrigerating whole blood, for example, or by creating serum. You can make those samples high molecular weight deficient because the high molecular weight multimers adhere to the platelets in cold blood, for example. So in terms of trying to avoid that, then it's really just making sure that the transport of those samples is as good as you can get. So any heat, and it's going to be difficult in Saudi Arabia unless you can freeze samples and keep them frozen at dry ice during the transportation. So it's probably mostly likely to be a transport issue.
Currently, we don't have the new assays that you recommended, the glycoprotein 1B, M, and R, and I see a lot of them are now recommended in the most recent guidelines. How do we increase the sensitivity of current von Willebrand panels we have available in Saudi Arabia if we don't have these assays?
So as you can see from some of my data, the newer assays are better overall, for example, than the risk-seeking cofactor assay. But you can run a very good risk-seeking cofactor assay. For example, in our laboratory, we had an automated assay, and in our laboratory, our VWF activity levels for risk-seeking cofactor would go down to 1%. So most of the trouble with the risk-seeking cofactor assay as it stands is really when you're doing those assays using an aggregometer and when you're not actually maximising the effectiveness of that assay. So if you can assess how low your risk-seeking cofactor assay goes to, and if it goes down to less than 5%, then you've probably got a reasonable risk-seeking cofactor assay that you can actually utilise. So the newer assays are less variable simply because they're better automated. So if you can automate your risk-seeking cofactor assay, and you can automate those assays now on certainly the Siemens instrumentation and also on the Stego instrumentation. I haven't seen good data with the Werfen instrumentation, but the Werfen instrumentation actually has a risk-seeking cofactor-like assay, the glycoprotein 1BR. So it depends on the instrumentation that you have, but you can perform good risk-seeking cofactor assays on those automated analyzers.
Okay, thank you. Any more questions for our second speaker? Yes, please. The microphone.
Thanks, sir, for your good presentation on von Willebrand. I would like to give my observation only. As a von Willebrand disease, once it is diagnosed, it is better to leave the patient rather than going for so many assays. You are putting the patient to distress by bleeding again, and the bleeding should be stopped. That's another problem. Of course, to differentiate between type 1 and 2, or then to rule out whether it is actually von Willebrand. But once there is family history, and then von Willebrand has been confirmed, then what I feel is not to proceed further, troubling the patient.
Okay, so you're talking mostly about treatment modalities. So there are some differences in terms of treatment, and Professor Tripodi might want to cut in here, but there are differences in terms of whether you have a patient who has a mild type 1 von Willebrand disease. In those patients, you may not need to use a replacement therapy. You might be able to get away with DDAVP and other agents such as tranexamic acid, for example. If you have a patient with severe von Willebrand disease, and whether it's type 1, type 2, or even type 3, then really the distinguishing those patients may not be as critical. But it's important to distinguish, for example, a patient with type 2B von Willebrand disease versus, for example, 2A or platelet type von Willebrand disease versus, for example, a 2A or 2B. So I think there is value in actually characterising a patient, and eventually those patients will actually be able to be treated as individuals. In other words, you can go for personalised therapies. Professor Tripodi, would you like to cut in here?
Yes, yes. You are quite correct. I agree with you.
Any more questions? Any questions for our third distinguished speaker, Professor Mahalangu? I have a question for Professor Mahalangu. What do you think? Is there an update on a treatment of rare bleeding disorders like combined factor deficiencies? I've seen when you presented that all of them are single factor deficiencies, but what are your thoughts on treating or prophylaxing patients with combined factor deficiencies?
Yeah, thanks very much for that very difficult question. In fact, I was speaking to one of your colleagues here who's probably got the largest series of combined factor 5 and factor 8 deficiency. In those conditions, I think the strategy up to now has been to replace individually the missing clotting factor. And that has worked. I think until we have a genetic basis on which one would be able to tackle both deficiencies at the same time, I don't see the current non-replacement therapy being helpful in that setting. Having said that, I mean, the thought was meant to be purely provocative. We don't have data that non-replacement therapy currently will or does work in rare bleeding disorder, but I'm seeding the thought here because I think the majority of the people in the audience have got the experience and the expertise in managing those conditions. I've only got one patient with a factor 5 combined with factor 8 deficiency, and in fact the way we manage it is to replace each missing factor independently.
Okay. Thank you. I have a question.
Just patient with cancer during their initial presentation or at relapse, sometimes they present with acquired factor deficiency. So do you think there is a role with immunosuppression? They would require a steroid or something to control that acquired immunodeficiency, plasmapheresis, or the treatment of primary disease might, help, relieving that acquired antibody for those patients?
Yeah, it's a very important question. Thank you. Obviously, our talks largely focused on inherited bleeding diathesis. In the context of acquired bleeding diathesis, and I think Professor Tripodi in part tackled that, one would like to see both being tackled. In other words, the underlying reason for the deficiency of the clotting factor, as well as stopping the bleeding, which is often in this case would mean replacing the clotting factor that is being consumed or missing.
Any more questions? Okay, thank you, and thank you for our speakers. This will conclude the panel discussion, and we'll move to our next lecture.
Thank you.
So the next presentation is sponsored by Tamar, and it is a distinct privilege to introduce our special guest, Professor Al-Hussein Khalafallah, who has very high status in the field of hematology, oncology, and bone marrow transplant. Professor Khalafallah serves as a hematology oncology consultant and holds the esteemed position of CEO at the Specialist Care in Australia. Furthermore, his academic contributions span across two prominent institutions, the University of Tasmania in Australia and the University of Heidelberg in Germany. Professor Khalafallah is deeply engaged in several research in the field of hematology, thrombosis, hemostasis, also hematolymphoid neoplasm. Dr. Al-Hussein is an active member in many committees in Australia and Europe, and also a reviewer in many prestigious journals. He is very active in research with more than 60 publications. We are honored to have him with us today. Dr. Khalafallah, you may now begin your talk.
Thank you very much for the kind introduction, and thanks for the organizing committee and Tamer for inviting me today to talk about the paradigm shift in application of intravenous iron in different settings. We try today to give you a focus in patient interest or patient-centered approach, and I will start with to show you how globally iron deficiency anemia is affecting every continent, and you can see here from the darker dark red color that severe iron deficiency, and lighter color is moderate iron deficiency, and prevalence more in Southeast Asia, Africa, and South America, and of interest, of course, in Middle East. You can see Saudi here, fortunately enough, only moderate iron deficiency, and other countries severe. To show you how important to address iron deficiency, it affects actually 2 billion people worldwide, and as the WHO said, year lived with disabilities, they found 36 or more than 1/3 of these years lived with disability is due to fact of iron deficiency anemia. Of course, the more disadvantage for developing countries and can constitute a health crisis and economic consequences if this problem not addressed in the proper way. You can see here in this graph data gathered by the WHO from 188 countries during 90 years to 2013, and you can see here that women are most vulnerable among patients with iron deficiency, and men is less likely, and the iron deficiency constitute 60% of these patients among all other diseases. If you look here, pregnant women in particular, you can find that women in childbearing potential have about 30% prevalence of iron deficiency, and this jumps in 42% in pregnant women due to the increased demand, and compared to men and elderly, this is much higher rate of iron deficiency. If we look at the recommendation how we treat iron deficiency in setting after pregnancy and postpartum in particular, when women loses significant amount of blood during birth, we found that many countries in Europe and Asia Pacific utilize proactive treatment. If the hemoglobin drops below 9.5 gram per deciliter, they start to commence intravenous iron, and Germany has less conservative management with if the hemoglobin below 8 or 12 ferritin per milliliter. And also Asia Pacific, they have active rule in giving intravenous iron in patients who drops the hemoglobin below 9.5. In Australia, we use 11 the marker if the patients did not respond to oral iron. In UK, they watch the patients if they do not absorb oral iron or have any issue with efficiency of the therapy, they switch to intravenous iron. This is the UK guidelines recommend the intravenous iron, as we say, if the patient have iron deficiency anemia and a trial of oral iron was unsuccessful for at least 2 weeks, they commence intravenous iron as the most appropriate way to replace total iron body requirement. So to jump to another topic, and anemia in cancer, and you can see here in this graph that clearly that solid tumors and hematological malignancy are associated with iron deficiency anemia for different reasons. And if you look at the pathophysiology, you found that blood loss could be either due to surgical event to remove the tumor, or due to the blood loss in gastrointestinal tumor or urogenital cancers where blood loss is imminent, and sometimes cancer cachexia also can be imminent in case of malnutrition, of course, and associated with cancer. And another contributing factor, which is very important, that immune inflammation can, of course, make the hepcidin level, which is a peptide produced by the liver, and upregulate the iron as high as it could be, and block the absorption from the duodenal cells of the iron, and hence create what is a status called the functional iron deficiency. And the functional iron deficiency, of course, no matter you give oral iron, wouldn't work because of lack of absorption, and the only way to overcome the hepcidin blockade to commence intravenous iron. Of course, kidney disease can play a factor in cancer patients, either primary or secondary, and use of erythropoietin here is important. And lastly, the bone marrow, either primary disorder due to the leukemia or lymphoma, or secondary due to the bone marrow metastasis, or due to chemotherapy or radiation therapy, can affect the production of erythropoiesis and cause also lack of iron. And the major question now, why we use intravenous iron over oral iron? And the simple answer is most of the iron preparation, iron sulfate, is not really readily absorbable by the gut, and at the same time causes about 70% side effects for the patients and makes a lack of compliance. So it is totally ineffective therapy, and especially if it is co-administered with antacid or say a lot of tea or certain amount of food can block the absorption of iron. Adding to that, if the, as we say, if the hepcidin increases and blocks the absorption of iron, hence can be an issue to administer or ingest oral iron without any efficacy. There was a few consideration of safety in oral iron and intravenous iron, especially intravenous iron in first generation. But now with the third generation, we got very few adverse events, and I will go through it very thoroughly. So the short-term hypersensitivity reaction, fortunately enough, mostly mild, self-limited, and mainly due to the labile iron, which is react to non-transferrin bound iron and causing this problem. Also, hypophosphatemia can occur in short and longer term, and I will explain that later. So there is a multiple randomized control trial, and I will mention all of these trials in later slides, and 401 in nephro and generalized iron deficiency anemia, and also phosphor IDA trial and IBD trial, which both showed that hypophosphatemia occurs significantly with certain product like Ferinject compared to Monofer, with significant increase of hypophosphatemia in case of Ferinject. Why ferric derissomaltose or Monofer, as we call it, is molecule is different from others is because it have a strong iron matrix compound with a carbohydrate, and hence the release of iron is very slow and controlled, and it can take a longer time, and hence the labile iron or free iron or non-bind iron is very small amount, hence doesn't cause much adverse events. And this unique molecule, if you give it as a single infusion, you don't need to repeat it, and most of this study, if you give it 20 milligram per kilogram body weight, as indicated, 3/4 of the patient require only a single infusion, 1/4 require the second one, while if you look at other products like Ferinject, 1/3 require one infusion and 2/3 multiple infusions. The immediate and short adverse reaction is very important to educate our nurses to show them how to deal with the patient, assure the patient, because half of this work done by experienced nurses in our facilities in Australia. And you can see here that fish pain reaction, which is can be common, and patient stop the infusion and they don't like to continue. However, if we assure them this is a very mild reaction, and once you give the infusion very slowly at the beginning, unlikely to happen. And once it happens, you just stop, of course, the infusion, assure the patient, offer something to drink, and so on. And then you can resume the infusion without any side effects. But however, fish pain reaction or the flushing symptoms is common but self-limited and needs assurance for the patient, and it doesn't occur with any vital signs changes like hypotension, lack of oxygen saturation, or tachycardia. However, anaphylaxis, of course, is possible, can occur. This can change the vital signs and has to be addressed appropriately, and cardiovascular resuscitation should occur. A few days later can also a flu-like symptoms, the bone aches occurs, and I keep telling my patients this is the sign that the iron working, because this is the bone marrow start to produce new red cells. Panadol, or again, it's self-limited side effects, and paracetamol can be very efficient in these cases. However, we found assurance for the patient education, experienced nurses is a very important rule, even to put the cannula in the right position without putting in a joint that can cause extravasation is very important. Withdraw blood, to flush with saline, to make sure that there is no obstacles is very important too. So the low phosphate can happen later on after 1 week of the infusion, and I will talk about that in details. So this is a complex diagram. I don't expect you can see all of that. However, it is just in brief, as we said earlier, if the immediate reaction occurs, and we have to stop the infusion and reevaluate the patients. And if it is a fish pain reaction, you can re-challenge after a pause, and of course the patient settled and with a very slow rate. And if it is isolated symptoms, urticaria or itching, you can use antihistamine. And of course, if it is symptoms indicative for anaphylaxis or something like that, we can't re-challenge, and we have to, of course, to apply the measurements you have in your institution. And you can see in the picture here how is the fish pain reaction and redness of the skin occurs. Here is in this slide to show you how rare is serious hypersensitivity reaction with a third generation intravenous iron. We looked at about 8,600 patients. Most of them received iron isomaltoside or monofer, and then 1,800 received ferric carboxymaltose and iron sucrose, 2,700 patients. And we found that hypersensitivity reaction, it is all around 1% mark, was the lowest in monofer group, and a ferri inject 1.4 and iron sucrose 1.1. So the adverse events is rare and with new iron preparations. If you look at here the monofer total dose infusion, the result is actually fewer adverse events. And you can see in the graph in the blue here that the monofer single infusion much lower adverse events than multiple infusion with iron sucrose. The important trial, as we said, to manage randomized control trial for iron deficiency anemia, the 401 program analyzed about 3,000 patients, and we give here 1,000 milligram, a single dose of monofer versus multiple doses of iron sucrose. And we found that safety and efficacy endpoint showing clearly that in the left, that patient hemoglobin improved with monofer group. And if you look at the middle graph, this is the ferritin, has a sharp increase with the monofer and was superior than the iron sucrose group. And the last graph is iron saturation or ferritin saturation. Also, transferrin saturation increased significantly with the monofer group versus the iron sucrose group. The phosphor IDA trial to look at the hypophosphatemia, which is a very important part I wish to attract your attention to, that even FDA issued a label change in this regard with ferri inject. In this case, we have a monofer single infusion versus tandem ferric carboxymaltose infusions, and we looked at patients here at all points. You can see that hypophosphatemia occurred up to 75% in ferric carboxymaltose group versus less than 5% in monofer group. And if you look at day 7 and day 8 and maximum at day 14, the hypophosphatemia occurred in 70% of the patients in ferric carboxymaltose, and is still less than 5% in monofer group or ferric isomaltoside. So in summary here, you can see that even not only the hypophosphatemia matter, but also the fatigue scale is affected with, if you see the blue line in the left graph, that the patient with greatest decrease in phosphate have the lowest improvement in the fatigue scale, and vice versa. And this is clearly associated with ferric carboxymaltose group. while the hemoglobin response by decrease in phosphate did not change significantly. To talk about regulation of phosphate metabolism or homeostasis, we have a very important player or growth factor, which is fibroblast growth factor family 23, and it helps in urinary excretion of phosphate. And you get the parathyroid gland, which regulates the vitamin D as well as calcium and urinary excretion of phosphate. And you can see that Ferri inject can increase the F23 and increase the urinary excretion of phosphate, and hence cause of hypophosphatemia. If you look at the signs and symptoms of anemia, we can overlap, of course, with hypophosphatemia. They share the weakness, fatigue, and tiredness. However, if you look at short term, the bone pain start to occur, and the longer term, the osteomalacia, of course, and pseudofracture can be devastating. So because of importance of hypophosphatemia, the cancer National Comprehensive Cancer Network issued a warning that whenever you utilize ferric carboxymaltose, you have to increase the awareness of and complication of hypophosphatemia and to monitor the phosphate level regularly. This is a case study published in Gastroenterology in 2017 and showing perfectly normal pelvic bones and femur and head of the femur in particular. The patient has severe groin pain and waddling gait, and he has a background of Crohn's disease and received about more than 20 infusion of Ferri inject. If you look at the MRI scan, which couldn't demonstrate in the X-ray, there is a hyper intense focus in the neck of the femur, indicating why the patient has the pain and liable to fracture, and treated, of course, with internal fixation, and this caused later on stress fracture because the bone was osteoporotic. If you look at this particular case, you can find that 27 grams of ferric carboxymaltose infused, and also that hypophosphatemia was very evident while infused with carboxymaltose, and hence caused the osteomalacia and through the FGF23 pathway. So to this point, the ferric carboxymaltose induced hypophosphatemia getting attention, and all regulatory authorities in Europe, in US issued warning or alert to all users, and even in Saudi and Japan and Korea as well. If we look at the latest issue from Denmark and DFA as well, and Hong Kong, alerting that there is a bone risk, serious outcome, including osteomalacia, fracture can occur, and as well as symptomatic hypophosphatemia being reported after even one dose, and there is a clearer guidance on monitoring and treatment. So this is something we have to be alerted to. The risk factors for hypophosphatemia here in all authorities labeled as history of gastrointestinal disorders, vitamin D deficiency, inflammatory bowel disease, and also hyperparathyroidism. And all of these conditions should be monitored for hypophosphatemia and osteomalacia, especially if we're using ferric carboxymaltose, which is known to cause hypophosphatemia as compared to other molecules of iron. So to this point, I wish to share with you that we are in Australia. We have Monofer or iron isomaltoside labeled in 2019. And ever since, we used it in our facility with about 4 hospitals, 5,000 patients received the infusions, and without major adverse events. And the average hemoglobin increased by 2 grams after the infusion, and the average ferritin was 200 microgram also compared to before the treatment. And this increase in hemoglobin and the ferritin levels are highly significant. The treatment in general was well tolerated without serious side effects. There is some fish pain reactions occurred which self-limited and required no treatment. And about 15% receives a higher dose, which is about 1,500 milligram in a single infusion. And this also well tolerated and given over longer period of time, 30 minutes. In summary, and to wrap up my talk, the anemia has been recognized, as you know, as independent risk factor and predictor for poor prognosis, not only in cancer patients, but also in women with childbearing potential, pregnant women, other diseases like IBD, chronic kidney disease, perioperative anemia, and it is important in cancer patients, like a study assessed 60 different trials with survival and risk of mortality in cancer patients, found that 65% with overall increase of mortality and with anemia compared to those without anemia. So it can has effect not only in quality of life, but also survival as well. The impact of anemia and hypophosphatemia should really be alerted and highlighted, and especially when it affects the overall outcome and survival. And it can delay treatment, of course, and can have devastating consequences. Addressing all of issues with hypophosphatemia is a key goal or ultimate goal for better outcomes, to avoid any complications with osteomalacia. And finally, addressing anemia in different settings, very importantly, to apply also intravenous iron, and can improve overall outcome and survival as well as quality of life for patients. Thanks for your attention, and happy to take any questions. This is where I work.
Thank you, Prof. Hussein, for your extraordinary talk. Any question for Prof. Hussein? Okay, again, thank you, Dr. Hussein. So now we have a prayer break. So we'll meet. Do you have a question? عندك سؤال؟ اتفضل. Please.
My question is there any complication regarding iron transfusion to the hemophilias or hemolytic disease, like left ventricular hypertrophy? Do you have any kind of this side effect?
It's a very good question. In fact, chronic heart failure and study from cardiologists found that intravenous iron can improve the cardiac function, and so they used it, recommended in chronic kidney disease, gastrointestinal disease, IBD, and also heart failure. So it improves the cardiac muscle functionality and also contractility.
My question is there any complications regarding iron transfusion? Because I have found several lectures that are talking about left ventricular hypertrophy, risk effect of iron transfusion to the hemolytic patients.
I mean,
iron deficiency.
with a single iron infusion shouldn't affect the hypertrophy of the ventricle. However, iron overload, it does, you are right, but this is in a different setting with hemochromatosis and iron overload that can interfere with that. A transient iron infusion, in fact, with heart failure, there is many study supporting and recommended by FDA actually to give iron in these cases because it improves heart functionality. But overall, if you have iron overload, it can have adverse effect on the heart, and hence you have to release the iron with desfloxamine or something like that.
Did you find any cases like this?
No, I mean, we mostly treat patients are healthy, pregnant women or women in childbearing potential or CKD or IBD, and we never counter this problem.
What about sudden death of iron transfusions? Is there any?
Fortunately, I used more than 5,000 patients. Again, this is extreme cases, and you can see if you have a very sick patient, you wouldn't give iron necessarily. There is other alternatives, but again, it's very rare. These things can happen with any treatment, I guess, but in this particular setting where the patients are nutritional iron deficient and you give them a single infusion, shouldn't really affect or cause sudden death.
Thank you so much.
No worries.
Okay, inshallah, we'll meet again after a break at 4 or 5, inshallah.
Come back, everybody, for this last session of today. It's pediatric side, and it's my great pleasure to welcome everybody to this session, whether in the auditorium or those whom they are online. And I know the pediatric, it's only one session for all the program. But it is the best session, I hope. It's given me a great pleasure to welcome our chairperson, Dr. Mohammed Al-Isa, Consultant Pediatric Hematology Oncology, National Guard Hospital, Riyadh, and Dr. Ali Al-Ahmari, Consultant Pediatric Hematology Oncology, King Faisal Specialist Hospital, Riyadh. Welcome.
Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Ahmed, for this kind introduction. We'll be starting the pediatric session as mentioned by Dr. Tarawa. We will start the first session. Dr. Richard Ablank is a professor of pediatrics at Children's Hospital of Philadelphia University of Pennsylvania. He will be talking about docetaxel in pediatric AML.
Good afternoon. My name is Richard Applens, and I'd like to thank the organizers of the committee very much for inviting me to give a talk at your wonderful meeting. I'm very sorry that I can't be there in person, but I hope that I'll be able to join in person in the future. I'll be talking today about cardiac toxicity in pediatric acute myeloid leukemia. Since this is a recorded presentation, I won't be able to take questions in the context of the presentation, but certainly, please feel free to reach out to me if you have any questions afterwards. I'd be very glad to try to answer them. So we have two learning objectives for today's talk. The first is to review the data regarding anthracycline-associated cardiac toxicity in pediatric acute myeloid leukemia. And the second is to review the data supporting the use of desoxyriboxane for cardioprotection in the pediatric AML setting. So I'd like to start with a little bit of background about pediatric AML chemotherapy. This will be very familiar to many of you, but in the chance that there may be some people who may not be so familiar with AML, I thought it would be helpful to do a brief review. First of all, there are two cycles of anthracycline-based chemotherapy that start AML chemotherapy, and then there is consolidation afterwards, and the consolidation is determined by cytogenetic and molecular features as well as disease response. Consolidation therapy often relies on high-dose cytarabine with additional anthracycline in some cases, or stem cell transplantation. And as you probably know, there's a wide range of transplant conditioning regimens as well as donor type and stem cell source, and we won't be speaking about those today. This is a summary slide showing pediatric AML dose intensity across multiple clinical protocols. I think what's important here to take away for this talk is that the anthracycline exposure is very close to the maximum cumulative anthracycline exposure that we think is appropriate for children. Certainly the studies that we'll be talking about, and the data from those studies, are at exposures of over 400 milligrams per meter squared, which are on the high end, but certainly well within the range of anthracycline exposure that many children receive around the world. I think the other large point to take away is that AML chemotherapy is harder than an autologous stem cell transplant, but easier than an unrelated donor transplant. And I think for me, this helps organize my thinking around the risks of toxicity and the severity of toxicities. So this is a slide that summarizes some pediatric AML historical outcomes across multiple cooperative groups. And what you can see here is that on these historical data, event-free survival is in the 50 to 60% range, and overall survival is in the 60 to 70% range. There are some newer data, particularly from the European groups, that may have a higher event-free survival, but at least in the US, we're still looking at about 50 to 60% EFS and an overall survival of 60 to 70%. Now, you will be very well familiar with the fact that pediatric patients who receive AML therapy are at risk for cardiac toxicity, and I think I previously mentioned the cumulative lifetime exposure. We know very well that late cardiac toxicity is a leading cause of morbidity and mortality in children who survive pediatric AML, but the contribution of early cardiac toxicity, either on therapy or immediately after therapy, has been not recognized, or at least not quantified for as long a time, and those really will be the data that I'm presenting. Here it's important to note that we think there are really two different types of early cardiac toxicity, one which is associated with infections and the other which is not. And in our data that we'll present, we'll show a breakout by those two groups. And currently, the Children's Oncology Group mandates desroxazoxane as standard of care in all anthracycline courses that are not liposomal formulations. And we'll talk about those data. Now, the data that we're going to talk about come from two clinical trials. The first one is the AAML 0531 trial, which we sometimes refer to as 0531. And the second trial is the AML 1031 trial, which we sometimes refer to as 1031. 0531 randomized patients to gemtuzumab with or without standard chemotherapy. And we got echocardiograms after cycles 1, 3, and 5. And we collected adverse events in about 1,000 echocardiograms. On the 1031 trial, we randomized patients to standard chemotherapy with or without bortezomib. Importantly, this standard chemotherapy had one course less than the 0531 trial, but that was not an anthracycline-containing course. So the anthracycline exposure in these two trials is essentially identical. Here, we did require echocardiograms after every cycle, not just cycles 1, 3, and 5. And in addition to collecting adverse events, we also asked sites to report an ejection fraction and a shortening fraction number after every cycle of chemotherapy. And so we were looking for cardiac side effects differently on those two trials, and that's really important to bear in mind as we go forward. The fact that we asked sites to look for cardiac toxicity differently resulted in different compliance with echocardiograms. So on the left hand, you can see on AML 1031, we had almost greater than 90% echo compliance after every cycle of chemotherapy where we recommended or required an echo. And that means that we have an ejection fraction and shortening fraction after every one of those cycles. On the 0531 trial, however, we only required echoes after cycles 1, induction 1, intensification 1, and intensification 3. And as you can see, the compliance for the echocardiograms dropped off very substantially. So for example, in induction 2, on 1031, 9 out of 10 children, or 90%, had an echo to look for cardiac function. On the 0531 trial, only 46% of children had an echo, so less than 50% of children had an echo after the second cycle on 0531. It's very important to remember that we're looking differently for cardiac toxicity. So these are data that were published in 2019 in the Journal of Clinical Oncology that showed that patients who had infection or non-infection cardiac toxicity had a significantly decreased event-free survival, and you can see the rates there. So for patients who didn't have any left ventricular systolic dysfunction, their EFS was 50%. But patients who had infection or non-infection associated LVSD, their event-free survival was 32 or 36%, so substantially different. And this difference in event-free survival translated into a difference in overall survival for patients without infection-associated cardiac toxicity. So specifically, patients who had no left ventricular systolic dysfunction had a 5-year overall survival of 66%. However, the patients who did have non-infection-associated left ventricular systolic dysfunction had a 5-year overall survival of 45%. So an absolute 20% difference in survival based on the occurrence of cardiac toxicity that was not associated with infection. This is a magnitude of impact that is larger than the benefit of gemtuzumab that was seen on this trial. And it's a very, obviously 20% is a very substantial difference. So based on these data, we concluded that actually there was clinically impactful on protocol toxicity, and that this toxicity affected both event-free and overall survival in the setting of infections, for event-free survival, but only impacted overall survival in the setting of non-infection associated cardiac toxicity. And these data for us really indicated that we needed to do further studies to really examine carefully the patients who we had not gotten echocardiograms on in the second cycle and in the fourth cycle. And so this takes us back to the slide that I showed you previously for the 1031, where we see that we have 9 out of 10 patients on average getting echoes after the first 4 cycles of chemotherapy. Now, with those data, which include actually a numerical ejection and shortening fraction, we determined the prevalence of grade 2 or higher left ventricular systolic dysfunction. And what you can see here is that it's twice as high as the same outcome defined on 0531. So on 1031, that overall incidence is 22%, and on 0531, it's 12.1%. Now again, this is essentially exactly the same chemotherapy. The only difference is that we're looking more frequently. And I think that is very important as we think about what these data mean for the care of our patients. Specifically, if we don't look for cardiac toxicity, we won't find it. And you can see below in the second part of the table, the course-specific prevalence that across all courses, there was a higher incidence of cardiac toxicity on 1031 than 0531, again, given essentially the same anthracycline exposure. Now, because we collected ejection fraction and shortening fraction after every cycle, we can actually trend those over time for this trial. And when we look at the full population, and this is the figure on your left, you'll see that, excuse me, the ejection fraction starts at about 67% and then trends down, increases slowly between at the end of therapy and about 1.5 years after therapy, and then begins to trend down again. And this is really important data because this is really, to our knowledge, the first really longitudinal description of what happens to cardiac function in a large number of patients receiving AML chemotherapy. And on the right-hand panel, you can see the trajectories for patients who have cardiac dysfunction and who don't. And here, although the drops are much steeper for patients who have cardiac dysfunction, as you would expect, they both have the same trend, which is that they gradually decrease they decrease over time, increase, and then begin to decrease again. We're also able to look at trends by age and by randomized arm and by gender. And when we look by age, we actually see that infants who are 0 to 1 years of age, there in the blue line, they actually have less of a drop in their cardiac function than older children. And this is actually very different than what you would see in the survivorship data, where the younger children actually have higher risks of cardiac dysfunction in the long-term setting. And we think that's actually because of survivor bias, that they're the patients who are actually surviving that long, and therefore they're the ones who then are presenting with more frequently with cardiac dysfunction and late follow-up. You can also see that there was a difference in the rates of cardiac toxicity between the bortezomib and non-bortezomib arms. This was mainly related to infection, but important obviously for the trial. And finally, for reasons we don't understand it, it appears that females have a greater drop in cardiac dysfunction than males. Now here are the event-free survival curves for 1031. And what you see here is actually really interesting, that the patients with infection-associated cardiac dysfunction actually have a slightly higher overall survival than patients without any cardiac dysfunction, and that's not something we understand. But the rate of the event-free survival for patients who have non-infection associated cardiac toxicity is 38%, which is substantially less than was in either of the other two groups, and very, very similar to what we saw on the 0531 trial. Likewise, for overall survival, we see almost exactly the same results on 0531, where there is no difference between infection-associated cardiac dysfunction and no cardiac dysfunction in terms of overall survival. But the grade 2 left ventricular systolic dysfunction patients who didn't have that in the context of infection have a significantly decreased survival, which again is about 20%. So 66 versus 49, almost 20%. So very similar in magnitude of effect as we saw in the prior study. So for us, our conclusions are that in this separate data set with better or more comprehensive monitoring, let's say, we saw again clinically impactful on protocol cardiac toxicity. And this toxicity is again associated with overall survival in patients who do not have that cardiac toxicity, excuse me, in the context of an infection. And we also saw some subtleties to the data that we did not see when we were monitoring less completely. And we also noticed that the overall survival for patients who had any cardiac toxicity was improved, and we wonder whether that may be due to the fact that early monitoring detects the toxicity later, which allows us to intervene sooner, and that may help improve the overall survival. That's not yet a proven hypothesis, but one that we're working on understanding actively right now. So finally, I'd like to present some data about desrizoxane. And so this is the study design, and you can see on the left-hand side, we had all patients with without a FLT3 ITD mutation, and we separated those into patients who never were exposed to desrizoxane. Those are the 918 patients in the middle box at the lower part of your screen, and 173 patients who got desrizoxane at some point in frontline therapy. Of those 173 patients, there were 78 who got desrizoxane at some point during therapy, but not in every cycle, and we eliminated those patients and instead focused on the 95 patients in the blue box who received desrizoxane in every anthracycline-containing course. And then we compared these two groups of patients, specifically the 918 who never received desrizoxane and the 98 who received it in every cycle. And when we do that, we see that the overall incidence in this group of patients, subset of patients on 1031, was about 19.5% for left ventricular systolic dysfunction. Again, importantly on 0531, it was 8%. And that, again, is because we're monitoring more carefully. But when we look at the rates of cardiac dysfunction by desrizoxane exposure, we see that they're dramatically different. So it's 8.1% in the patients who received desrizoxane and 20.7% in the patients who didn't, and that's statistically very significant. And you can see that comparison here circled in red with the arrow. This difference in rate of left ventricular systolic dysfunction held true in every cycle of chemotherapy. So you can see below that in general, the rate of cardiac dysfunction is about half in the desrizoxane exposed patients in every cycle than in the desrizoxane not exposed patients. And then we obviously looked at the impact of desrizoxane on survival, because the concern here is that if we protect the heart with desrizoxane, we'll actually protect the leukemia, and that will translate into a greater risk of relapses. The panel on the left-hand side of your screen shows that there is actually no difference in event-free survival between patients who got desrizoxane and patients who didn't. The desrizoxane-exposed patients had an event-free survival of 49%, which was a little bit higher than the 45% of the never exposed, although that was not statistically significant. And When we look at treatment-related mortality, we see a difference of 5.7% versus 12.7% that approaches but doesn't reach statistical significance. And so, this is some data suggesting really that desrisoxane may prevent cardiac-associated mortality in the context of the AML setting. So in our conclusions for desrisoxane, we thought that desrisoxane is associated with a statistically and clinically significant improvement in cardiac function, that there is no impact on event-free survival, but desrisoxane may decrease treatment-related mortality. And so these data for us strongly suggest that patients should receive desrisoxane in all anthracycline-containing cycles in AML therapy where the anthracycline that is being used is not a liposomal formulation, and that is now the standard of care in the Children's Oncology Group. So with that, I'd like to thank you very much for attending this session. Certainly look forward to any questions that you might have offline, and would like to thank all of my collaborators, particularly Kelly Getz, who drove forward many of these analyses and extraordinary data collection, as well as, of course, everybody on the AML 0531 and 1031 study teams, and the patients and the individuals that have supported us. Thank you very much.
Thank you, Prof. Richard, and I wish you have a chance to join us in the panel discussion at the end. And now I will I'll pass the mic to my colleagues, Dr. Mohammed Al-Isa.
Thank you, Dr. Ali, and also with great pleasure I would present Dr. Sami Thbeiti, our colleague and friend, consultant pediatric hematologist, oncologist, BMT at King Abdulaziz Medical City, National Garden, Jeddah. He will be talking to us about upfront management in Hodgkin lymphoma in pediatrics with the advances and some of the controversies between consortiums. Thank you.
Thank you very much. It's my honor and pleasure to join this prestigious Congress. I would like to thank the organization committee and the moderator for this kind introduction. Okay, so my objectives today actually approach for patients with Hodgkin lymphoma, regimens that we recommend for upfront treatment, review potential long-term complications, as well as to review novel agents that have been used in upfront treatment. So we all know that Hodgkin lymphoma is constitute around 7% of children with cancer, and it is only constitute of around 1% of childhood cancer death in the United States. There is a high chance of cure in patients with Hodgkin lymphoma. However, these are associated with long and short-term toxicity. So the goal of treatment in patients with Hodgkin lymphoma is usually to continue maintaining high survival rate, as well as to attempt to reduce therapy-related long-term toxicity. Just to go over the pathology of Hodgkin lymphoma, we classify them into classical Hodgkin lymphoma and nodulolymphocyte predominant Hodgkin lymphoma. Both are associated with lymphadenopathy. However, Hodgkin lymphoma are classically associated with Reed-Sternberg cells that are CD15 and CD30 positive, whereas nodulolymphocyte predominant Hodgkin lymphoma usually associated with popcorn cells that are CD30 and CD15 negative. If we look at the incidence of Hodgkin lymphoma across pediatric and adult age, we can see that from series data that Hodgkin lymphoma is start usually at the ages of between 5 and 9 and continue along the years. However, there is 2 peaks early in life and later on. Data from Saudi Arabia, as recently published in the Cancer Incidence Report, we can see here that the annual standardization rate of cancer in children is slightly higher than in Western regions. So this is something that to be considered for future studies. To evaluate patients with Hodgkin lymphoma, after history and physical examination, excisional biopsy is strongly preferred. Fine needle aspiration usually underdiagnose these type of tumors. Other evaluations include laboratory investigations, PET scan, X-rays, and echocardiogram, just to assure adequate cardiac function before anthracycline-based chemotherapy. The principle of staging in Hodgkin lymphoma in pediatric is based on Arbor staging system, where staging is ranges from stage 1 to 4 based on the location of the lymph node and whether it is above and below diaphragm. Also part of the staging system is to assess the bulkiness of the disease, and the definition as per Children's Oncology Group is bulky disease is more than 1/3 of the thoracic diameter, or peripheral lymph nodes more than 6 centimeters. Also, B symptoms is very important in risk stratifying patients, where patients who have fever, night sweats, or drenching or weight loss are considered to have B symptoms. Based on that, different consortium risk stratify patients to either low, intermediate, or high risk, and you can really see that there is no consistent between risk stratification between cooperative group. You can see here Euronet usually consider stage 2B, 3, 4 as high risk, whereas in the Children's Oncology Group, stage 3A is an intermediate risk, and other important prognostic factor like ESR and disease bulk is being considered. Just to look at the outcome of recent cooperative group outcome in treatment of children with Hodgkin lymphoma, we can see that we are being successful in treatment of Hodgkin lymphoma in general. So overall survival, you can see it's touching the 100%. However, there is substantial amount of radiation therapy that are delivered to patients with Hodgkin lymphoma. It ranges between 30% and 60% in high-risk group. And you can see that, that most of this therapy are anthracycline alkylator-based chemotherapy, which is associated with both long and short-term toxicity. So NCCN came up with the guidelines that are recently published, and the last version of it usually recommends for low risk to be treated as per Euronet chemotherapy, 2 cycles of OIBA, plus minus radiation for based on slow responders. Other chemotherapy for consideration is as per adult, the ABVD regimen. For intermediate and high risk, both regimens as per the Euronet and Children's Oncology Group are preferred options, and ongoing clinical trials is always recommended for those group of patients. Very important to know that over time, Children's Oncology Groups and other groups are successfully able to reduce both doses of radiation as well as the field of radiations. So you can see historically the treatment was involved regional radiation therapy, and this came down to response adaptive radiation therapy, where patients who responded to treatment, they don't need to receive involved site radiation, where some bulky disease might receive radiation. Why is that important? Because the long-term effect. We can see that this is data for patients of around 3,000 patients followed up by the childhood cancer survival group. They really show that high risk of development of long-term toxicity for patients, particularly who receive anthracycline, alkylators, and radiation therapy. More the dose of anthracycline and radiation therapy, more the risk of long-term complication. This being also observed that the new contemporary studies showing that there is reduction in this type of complication because of response adaptive therapy. Just shifting gears to novel therapies, we know that classical Hodgkin lymphoma expresses CD30, and it is amenable for target antibody-based targets. So brentuximab is an immunotherapy that targets CD30 in classical Hodgkin lymphoma. Data from adults show that using brentuximab combination with chemotherapy, it resulted in a higher survival rate, both in progression and overall survival, in high-risk group. A similar study was done in pediatric using combination of brentuximab with OIPA Cobadak backbone, and as we can see that it resulted in higher event-free survival and overall survival. So this led to a study, a randomized control trial by Children Oncology Group to look at incorporating brentuximab into the backbone of the ABV-EPC, which is a standard chemotherapy in a high-risk group of patients. It is a one-to-one randomization for patient age from 2 to 21, and high risk here is defined by patients who have stage 2B with bulky disease, stage 3B, 4A, and 4B. And they receive response adaptive chemotherapy, where they had interim analysis by PET scan after 2 cycles. And those who are slow responder receive radiation endotherapy. And all those who have large mediastinal mass at diagnosis will receive radiation therapy. The data is published last year, and it showed that brentuximab resulted in improvement of overall survival and event-free survival, and reduction of events by more than 50%. This was true across all subgroups, so age, stage, whether it be symptoms or no, bulky disease. However, bone marrow involvement was not really shown any difference whether a patient receives brentuximab or no. So this is a landmark paper that resulted in a new standard of care in treatment of children with Hodgkin lymphoma. Very important to know that this also was true for both slow responder and rapid responder. So brentuximab was the winner in this randomization. In terms of toxicity, there was no different toxicity between the 2 arms. Particular toxicity related to brentuximab, which is peripheral neuropathy, was comparable to the brentuximab arm and the standard arm. So the other immunotherapy that are being tested in Hodgkin lymphoma is PD-1 inhibitors. As we know that Hodgkin lymphoma really express high level of PD-1, and this is mainly because of amplification of chromosome number 9, and this been shown to be effective in relapse, and it's been tested recently in upfront setting. So basically, PD-1 inhibits the T-cell engagement, and so by inhibiting this, will activate T-cell to engulf and engage in classical Hodgkin lymphoma tumor cells. So in a plenary session this year, SWOG 1826 study asked to randomize patients to 2 arms, nivolumab, which is a PD-1 inhibitor, and brentuximab, with a backbone of AVD, which is an adult-based backbone. For the first time, pediatric age group, 12 to 17, were included in this study, and they received 6 cycles of chemotherapy, followed by assessment endotherapy, and those who have PET positive endotherapy, they might receive radiation therapy. So the results showed that nivolumab arm resulted in higher event-free survival. This is a 12 months progression-free survival, and compared to brentuximab arm. Nivolumab across all subgroups was showing that it is effective, stage, age, and whether this patient have B symptoms or no. And in terms of overall survival, it is near 100% in both arms, indicating that the retrieval rates for those patients who relapse is very high. In terms of side effects, we can see that it is comparable between the two arms. However, the neutropenia is higher in the nivolumab arm, where it is lower in the brentuximab arm, and this is maybe because of in the brentuximab arm, the G-CSF was required for this group of patients. In terms of peripheral neuropathy, was slightly higher in the brentuximab arm as expected. So if you want to compare these two recent high-risk group study together, we picked the winner of the AHOD 1331, which is the brentuximab APC arm, and compare it to the recent SWOG study. Very important to know that the age group is different. So pediatric treat patients from age 2 to 21, where SWOG you treat patients age 12 and above. The risk and staging are different between the two groups. In terms of brentuximab dosing, it's higher in the SWOG study compared to the AHOD 1331. Whereas the anthracycline is nearly around 250 to 300, which is not a much big difference. In terms of peripheral neuropathy, is comparable to the both group, and indication of radiation therapy in the AHO study is based on the interim response. So after 2 cycles, if you are slow early responder, they will receive radiation, or if you are large mediastinal mass, end of the therapy. Whereas in the SWOG study, it is based on the end of the therapy response. The percentage of radiation therapy received in AHOD 1331 patients is around 57%, whereas less than 1% in the SWOG study, which is a very substantial reduction in radiation therapy in those group of patients. Very importantly to know that chemotherapy frequency in the COG backbone usually is more frequent, so they need to come day 1, 2, 3, and 8. So if we take 5 cycles, the cumulative amount of chemotherapy visits per patient is around 20, versus every 28 days in the SWOG study, which is day 1 and 15, and cumulative chemotherapy visits around 12 days. For the COG study, the 3 years event-free survival and overall survival is 92 and 99%, where for the SWOG study, we just have the 12 months event-free survival and overall survival, and we're looking forward to have a longer-term follow-up. Also, children oncology group are now ongoing new active studies, AHOD 2131, and basically another study trying to harmonize treatment between children and adults. So they are using the ABVD backbone in both arms, whereas in the favorable risk group, if they are rapid early responder, they will be randomized to 2 cycles of ABVD or immunotherapy consolidation with brentuximab and nivolumab. For the slow early responder, they will be randomized to escalating chemotherapy, escalating BIACOP, or to be randomized to 4 cycles of immunotherapy. Whereas for those unfavorable risk, they will be induced by 2 cycles of ABVD, and based on response, whether they will receive 4 cycles of AVD or immunotherapy-based regimens. And for those who are slow early responder, they will be randomized to chemotherapy escalation with BIACOP versus immunotherapy escalation. And we'll be really wanting to hopefully see the effect of immunotherapy consolidation in this risk group. So for us, what is the criteria to select standard of care is one want to select most effective treatment and less toxic chemotherapy, most effective augmented therapy with to the high-risk group or those who are slow responder, and regimen that has the least amount of radiation therapy. So to conclude, risk and response adaptive therapy led to improvement in outcome of children with Hodgkin lymphoma. A novel combination of chemotherapy further improved outcome in high-risk group. There are significant reduction in radiation therapy doses and field in recent studies. Long-term follow-up is needed to evaluate the outcome of immune therapy-based regimens. I think harmonization with adult chemotherapy is feasible, and there is ongoing children oncology group trial that try to extend this to a low-risk group. Of course, long-term follow-up for those groups is mandatory to assess both side effects and patient-reported outcome. In adult-based or adult-inspired chemotherapy, they usually don't use steroids, cyclophosphamide, and etoposide, which is very important toxic medication in both long and short terms. As we heard in AML, cardioprotective agents is very important to be considered in patients who receive anthracyclines. And hopefully in the future we'll be eliminating radiation as much as possible, because it is really associated with long-term toxicity in this group of patients. By this, I would like to thank you, and looking forward to hear from question end of this discussion. Thank you very much.
Thank you very much, Dr. Sami. We'll leave the questions to the discussion panel. And actually, with great pleasure, I would like to welcome Prof. Michael Pulsifer. He's a very well-known in the field, and I've been, discussing Dr. Ali. So we'd like really to welcome Prof. Michael. He's a chief of pediatric hematology at Intermountain Primary Hospital, Children's Hospital, and Oncology Director, Children's and Adolescent Cancer Initiative at Huntsman Cancer Institute, and also the Presidential Chair in Pediatric Oncology Hematology at University of Utah in USA. Of course, he's very well known, published, contributed to the whole transplant leukemia society around the world, received life achievement awards by several societies. And you will talk to us today about the use of key biomarker before and after infusion of CAR T cells, and the dilemma of who to transplant, how can we monitor, etc. So thank you, Mike.
Thank you so much. I really appreciate this invitation. It's my first time to Saudi Arabia. What a pleasure. I'm enjoying my visit. I also am privileged to be part of this particular session. The two previous talks were outstanding. Amazing advancements have occurred both in AML and Hodgkin's. So what I want to do today is try to talk about important measures that we can make before and after CAR T cell therapy that can really help us understand. My goal in treating patients with ALL, specifically with CAR T cell therapy, is to avoid transplantation as much as possible. But unfortunately, that's not the case all the time. So let's talk a little bit about how we can potentially transplant those who need it and don't transplant the others. So I have a few disclosures to mention. I was heavily involved in the original Novartis studies, and continue to consult with Novartis on occasion. My first topic in looking at this is going to be to talk briefly about CAR T cell outcomes, and then really spend a lot of time talking about risk factors, about specific things when you are prepared to treat a patient with ALL with CAR T cells. What can you do to understand that patient's risks, and also potentially to improve their outcome? So this particular graph is a really nice illustration. On the left, this was my career 10 years ago, where if a patient relapsed after a transplant or had multiply relapsed ALL, there honestly, you see that graph on the left side, there was nothing left to do. Survival was dismal. It was very difficult even to get those patients into remission. And then if you were lucky enough to get them into remission, only about a third of them survived transplant. Contrast that with the graph on the right, which is results of the Eliana trial when it was first published by our group in the New England Journal. in 2018, what you see is a marked improvement in overall survival and event-free survival. This is recent data published in the JCO that shows long-term effect of CAR T cells in curing patients. Now the challenge is I want to do better than just curing about half patients. You can see on the left is event-free survival, and notably a small percentage of patients didn't go into remission with CAR T cells, and then many went on to relapse or have other events, such that at about 24 months you reached a median, and really the long-term outcome, survival with only CAR T cells, occurred in about 45% of patients. If you were lucky enough to get into remission, then the graph on the right applies to you, where at 3 years after your treatment, about 52% remained in remission. But we're still missing half of the patients. So how can we improve those patients' outcomes? How can we potentially cure them? Well, some have suggested that we should transplant patients afterwards. Now this graph, this particular slide talks about CD28 based CAR T cell approaches. This is data from the National Cancer Institute where they used a CD28 CAR. This particular CAR lasts somewhere between 8 to 12 weeks on average. And it's very well known that without follow-up transplantation, there's a high risk of failure. So in children where goal is our cure, it has been shown very clearly that follow-up transplantation can really benefit these patients. And the graph on the bottom on the right shows that if patients achieve an MRD negative remission and go to transplant, they can have very excellent survival at about 80%. So what about 4-1BB based CAR T cell therapy? This is the type of CAR T cell therapy that can actually cure your patient with no further treatments. The trouble is, when you're going to fail half the time, what do? Well, this particular study was a study by the Seattle group who used a 4-1BB based approach. And their goal was to try to cure patients with the CAR T cells alone. But they realized that transplantation potentially could have a role. So their approach in general was if a patient was eligible for transplantation and had not previously been transplanted, they took them directly to transplant. So what you can see here is out of 64 patients who went to CAR T cell therapy with their 4-1BB vector, 5 of them did not respond, and some of them relapsed early, and 1 patient died. So that left 50 eligible patients in order for them to assess whether transplantation benefited patients or didn't benefit patients. Now, of those 50, the vast majority had already undergone transplant. And the vast majority, in fact, coming to that center did not want to undergo a second transplant. They had a strong preference to try to avoid second transplantation if possible. So what ended up happening is 16 of them were considered for upfront transplantation, and 13 of them actually received the therapy, while 3 did not. Of the 34 subjects who had a history of transplant, 10 of them decided to receive a transplant for various reasons, and 24 did not. And you can see on the right hand outcomes of this particular approach, where overall survival was reasonable in the group, but event-free survival, they cured about half the patients, typical of CAR T studies. Let's dissect this just a little bit. If the patients had had no prior transplant, what was their outcome? So leukemia-free survival, as you can see there on the left, seemed to be better, although it was not statistically significant, if they underwent transplant. Overall survival, though, of course, was not changed because those patients who eventually relapsed got another treatment and went on to survive. What about patients with a prior history of transplantation? And what you can see there is both leukemia and overall survival essentially overlapped in this group. So this suggests that patients who've already had a transplant, there may not necessarily be a benefit of going directly to transplantation. So what about better potential markers? What this group decided to do was look at loss of B-cell aplasia. So if you recall, these CARs are aimed at CD19. And if the CAR is effective, that means that B cells will be completely eliminated, and if the CAR continues to be present, they will stay eliminated for an extended period of time. In my experience, best outcomes occur when you have elimination of B cells for at least 1 to 2 years, kind of like maintenance therapy in ALL. I don't know if it's truly analogous or not, but bottom line is the longer the CAR is around, the better chance you have for overall survival. So what about that as a marker? Looking at leukemia-free survival, you can see from these graphs on the left that there was a difference, and this was statistically significant. If patients lost their B-cell aplasia within the first couple of months, meaning their CAR didn't last very long, they had a significant benefit in leukemia survival, although again, their overall survival wasn't that different. Overall survival with these type of CAR T-cell studies is unfortunately not a great marker because we have lots of things you can do for B-cell therapy. So really, the key here is to pay attention to leukemia-free survival. Those patients who had persistent B-cell aplasia at day 63, the benefit of transplant was certainly not clear, and there was no benefit for overall survival. So let me show you another large database that we put together that gives insights into risk of patients receiving CAR T-cell therapy. This is a group, we called it eventually the KARMA study, so the CAR multi-center study. This group looked at a very large number of patients, over 420, who underwent treatment with CAR T cells at a number of different centers. There were 4 types of CAR that we looked at. We looked at CTLA-19, which is the same as tisagenlecleucel, the approved treatment in the US by Novartis. We also looked at CD28 CARs, and remember those are short-lived, they don't last quite as long. We looked at the commercial product, Kymriah, and we looked at another 4-1BB-based product from Seattle Children's Hospital. Now what you can see here is that response rates differed slightly in that the CD28 patients didn't respond as much, and we have to qualify that because most of the patients who got CD28 CARs failed a previous CAR and then went to the National Cancer Institute to get that treatment. So it's not quite a fair comparison. Now looking at factors that could potentially influence our decision to do transplant after CAR, what you see here is cytogenetics probably doesn't play a role. Now, cytogenetics is very important in ALL and has been a cornerstone of therapy. So it's interesting that when it comes to treatment of patients with CAR Ts, an immunotherapy, cytogenetics isn't yet playing a role. Now there is some hint that TP53 by some other studies may be important in this treatment, but for now we don't see a specific measure of cytogenetics really telling us who's at high risk in CAR T cells. What about other factors? The one factor that we looked at very specifically was CD19 targeted blinatumomab as a factor. There was a great worry that a previous targeting of CD19 could potentially affect outcomes of CAR T-cell therapy. What you see here is the results of this very large study. On the left, this graph shows the T-cell burden, excuse me, the lymphoblast burden of patients prior to CAR, when they were treated with blinatumomab. And as expected, patients who had a low burden, in other words, patients who had less than 5% when they were treated with their blinatumomab, went into remission almost all the time. So you can see here about 80% of those patients went into remission. And that's been shown in other studies, so we replicated that with this trial. And patients with high tumor burden, what you see is about just under 40% of them achieved a remission, whereas the rest of them did not achieve a remission. So basically, on the left-hand side, you see we essentially replicated what we already knew about blinatumomab. Now, on the right, in the upper corner, what you can see is the complete remission rate if a patient underwent blinatumomab therapy and went into remission was actually excellent and exceeded 90%. So blinatumomab therapy prior to CAR did not adversely affect the CAR therapy if the patient was responsive to blinatumomab. On the other hand, if patients were not responsive to blinatumomab, they still went into remission most of the time. It actually was 65% of the time. But you were much less likely to respond than if you had responded to blinatumomab, whereas about 35% of them did not go into remission. And the graph on the lower right corner shows this very clearly. This basically shows the entire cohort, comparing the patients who had CR with blina and no blina therapy with the patients who had not been responsive to blina. And you can see patients going into CAR who had failed blinatumomab before had poor long-term outcomes. So that's an important thing to keep in mind. If your patient is going to CAR, they may go into remission, but they have a high chance of failing long-term if they have failed blinatumomab previously. Now, the second thing was noted on this study was a very clear signal based on the amount of disease present at the time of infusion of the CAR. And what you can see is patients who had low disease burden, and we defined this by less than 5%, they went into remission and had a long-term survival that much more frequently than patients who had high disease burden. Now, we don't know the exact cutoff. This particular cutoff was 5%. I've seen other studies going as high as 40%. But bottom line is patients who are responsive and have a lower disease burden tend to do better long-term with CAR, and that makes sense. Now, this is a combination analysis looking at both resistance to blinatumomab and CAR, and burden at the time of CAR infusion, and you can see that they're independent. I want to now talk about a few other factors that I think are really important and in fact get at the heart of probably the best way we can choose patients who are at very high risk for failure with CAR. And that is specifically looking at minimal residual disease. So this particular slide shows three approaches to looking at minimal residual disease. On the upper left-hand corner, you see multi-channel flow cytometry. This particular method is highly accurate, highly sensitive in that it can detect patients' levels of disease in up to about 1 in 10,000. Sometimes we can sneak a little bit higher than that with higher channel flow cytometry. But in general, about 1 in 10,000 cells can be detected. If you use quantitative PCR, you can probably get another log, maybe 1 in 100,000 cells. But on the right-hand side, you see next-generation sequence minimal residual disease techniques. This particular approach is incredibly sensitive. You can detect reliably up to 1 in a million or 1 in 10 million cells by looking for specific recombinations of VDGJ. What you need is a baseline sample on that patient so you can detect exactly what change their cell has, and then once you know that, you can detect whether it's present in your population. So what you can see here is that as we are trying to measure true remission, if we look at just PCR, we're going down to the 10 to the minus 4. There's still lots of disease, up to 10 million cells probably left in that patient. As we get to next generation sequence, we get down to 10 to the minus 6 or 10 to the minus 7. There's still 100,000 cells left. What matters most, though, is what level you achieve and stay below. And as I'll show you, knowing that your next generation sequence negative matters. Now these plots really kind of give you a hint at what we can detect with patients who have flow bone marrow assessment versus next generation sequence bone marrow assessment. And what you can see in the upper right hand corner here is that you miss a lot if you only depend on flow cytometry to assess your patients. And what you can see there is looking at flow bone marrow on the x-axis and NGS on the y-axis. There are a lot of patients who have detectable next-generation sequence and who were not detected if you only look at flow cytometry. And this is another way of looking at it. When this particular assay for next-generation sequence has two ways of measuring it. Something called the level of detection and the other the level of quantification. Level of detection refers to how consistent this is. And the people who developed this assay at Adaptive basically were aiming to have their ability to detect something be present 93% of the time you assess it. Now that may be difficult when you take a bone marrow sample and you only have 100,000 cells in it, and the actual level of presence is 1 in 10 million cells. So you probably are not going to be able to detect it. So bottom line, there may be disease in that patient that's actually below their official level of detection. And what you can see is in this very detailed study that we performed, we had a number of patients on the left-hand side who had detectable disease, but it was below their level of detection. They also quantified it, but it was below their official level of quantification because the level that they chose at this was 1 in a million cells. Now, does it matter whether you ignore all of these patients who may be detected because their levels are there but they're super low? Are they just an artifact? Is that a false positive? In this case, we did an analysis of over 100 patients who had CAR T-cell therapy. And we looked at patients who were positive, but only if they were positive above the level of detection, which was 10 to the minus 6th. And what we see is if we consider those patients who had low-level disease as being negative, then it throws everything off, and we can't tell the difference between a negative and a positive patients. And that's because those patients are actually positive. So let's look at the same group detected at 28 days if we look at any level of positivity, even if it's 1 in 10 million cells. And what we see here then is it matters. There's a huge difference in your ability to detect who's going to relapse and who's not going to relapse if you consider any level of detection positive. This is at day 28. Now at day 28, what you can see is maybe there's a slight amount, there's a small percentage of patients where you're just detecting that lymphoblast population disappearing. As you can see, because there's about 20% of patients who seem to have long-term response who had some detectable disease. But by the time you get to 3 months, which is graphs E and F, and 6 months, which is graphs G and H, all of the patients who had any detectable disease eventually relapse. So this is incredibly important. And if you know this, then you potentially can act on it and do something. Well, how much time do you have to act on it? What this graph shows is the amount of time you have for relapse in CAR T if you depend on certain assays. So the blue line is the time from first detection of flow cytometry to the time when they actually relapsed. And as you can see, half of your patients relapsed at the time you first detected. If you follow out the rest of them who just had MRD positive detection, then you see you have somewhere between 30 to 90 days before 100% of your patients are going to relapse. If you do your cutoff of 10 to the minus 6, then you got up to 6 months, and about a third of your patients have relapsed by the time you detect it. But if you allow any detectable disease to be your marker, then what you can see is you detect almost all of them before the relapse actually occurs, and you have some time with a median of about 5 to 6 months. Now, the second marker of B-cell aplasia I already mentioned, and this is a nice curve that shows if you have B-cell aplasia loss early on the left-hand graph at 3 months, then your outcome is very poor. But if you get out to 6 months, then your outcome is better. The graph on the right shows that if you're lucky enough to keep your B-cell aplasia for 12 months, then your survival is excellent in the 80% range. So what this has come to is a nice trial that we are opening right now to try to see if we can predict who is going to relapse and treat them and salvage them with transplantation. So we're calling this the CAR Cure trial. We're opening this at about 6 centers in the United States. And we're starting with patients who are treated with CARs. And if they become NGS negative, our plan is to continue to monitor them. If they lose B-cell aplasia early, or if they become NGS positive, our plan is to move forward with transplantation and see if we can salvage those patients. If, on the other hand, they are NGS positive, then we move them immediately to TBI-based transplantation. Now, one thing to mention, and this is a quick thing, I'll try to go over this. The assay is not 100% straightforward. There are times when the next generation sequence MRD assay can mislead you. So you have to know this and understand it very well. The important thing to understand is that there are different types of recombination events that lead to the signature that can give you your MRD signal. First thing to understand is if you have IGH recombination, it's almost always accurate, and there's a measure of uniqueness. And you can see that uniqueness by something that's called the level of detection. And the company provides this to you so that you can have a good idea of just how accurate it might be. But light chains, called kappa or lambda, can also be a signature. And if you get this as your output measure, then realize that there are fewer V's and fewer J's and no D's, so they can be less unique. So you may see false positives. If you have a single sequence and it happens to be a kappa or a lambda, you should suspect it. The other thing is that you can't get 100% of patients with IGH recombinations. ALL is not quite that way. About 10% of patients don't have IGH recombinations. And you have to rely on T-cell recombinations in order to assay them. The T-cell assays are not quite as sensitive and not quite as specific, and so you may have possible false positives. This is a nice study which our adult colleagues, Emily Liang and Lori Muffley and colleagues published just recently, which showed this. The key here is if you see no clonal detection, then essentially no patients relapse. There was a single patient who relapsed in their outcome, whereas patients who had IGH positivity almost always relapsed. So that's an important thing with B-cell ALL. With T-cell ALL, in looking at the T-cell measured outcomes, what you can see is it's not quite as straightforward. Where you have patients who are TCR beta, that's not as good a marker, and we need more in order to understand that better. If they're only TCR gamma positive, those patients can have a small level gamma detection and still be positive. The key here is you need multiple clones in order to prove that it's truly positive. So what you need to do is if you detect it positive, you need to understand that you might need to follow up and do some subsequent studies. This is a nice little approach that we put together in a How I Treat that was published in Blood a short while ago that kind of divides patients into risk, looks at potential risk factors associated with outcome, and suggests different ways of monitoring patients in order to decide if and when you should consider transplantation. So in summary, transplantation of CAR T cells should be tailored to individual patients based upon risk. There are higher risks pre and post that you can detect by biomarkers and minimal residual disease. And I hope that over the next few years we can do more studies that allow us to be more specific. And I also hope that we can improve our approaches to CARs so that we have less failure. I hope that we can figure out how to have T cells that last longer, and that we can figure out how to avoid having escape with CD19 negative disease. And I think that's all I have to say, and I'm very happy to participate in our discussion. I want to acknowledge a great team that I've worked with on all of these trials. Thank you so much.
Thank you so much. Now we will have 10 minutes for panel discussion. Can we have the speakers on the stage, please? Dr. Sami. I'm not sure Dr. Richard is with us virtually. I hope he will be able to join us virtually. He join? He will not be able? Okay. So thank you so much for distinguished speakers and very elegant talks. Okay, with us now. I'm not seeing. Dr. Richard, are you with us?
I can hear you. Can you hear me?
Yes, yes, clear. Thank you so much and welcome to this pediatric session, and thank you for your excellent talk. Probably we'll start with you, just in case if we have any technical issues in the coming few minutes. Regarding use of dextraxane, now probably there is a consensus in using this cardioprotective agent upfront in AML. But what do you think other category of subgroups or a group of patients like relapsed ALL protocol? We know that there is metanzentron and previous exposure to anthracycline, as well as those patients probably they need in the future conditioning with TBI and cyclophosphamide. Do you think that is the second step?
Personally, we would at CHOP on the data from the Dana-Farber Cancer Institute was published extensively on desoxyrizine and ALL. So I think their data in combination with ours would really argue to that would be appropriate. I would say that there are some European groups who are not yet convinced that desoxyrizine should be added, and it's looking forward to seeing their data. They say that they don't see the rates of cardiac toxicity that we do, and I think it's an interesting question as to whether they're not experiencing the cardiac toxicity or whether it's actually not being observed. So I think there is some additional European data that could be interesting, but certainly, here locally, we have moved to giving desoxyrizine to all of our patients who are getting higher anthracycline exposures, even those with Hodgkin's disease.
Okay, thank you so much. You have shown us in one of your slides that the inferior outcome of the LV systolic dysfunction group. Do you have the breakdown of those mortality, whether it's treatment-related mortality versus disease-related mortality? As we know that those group, some of them already adjusted or corrected the dose of anthracycline, which can negatively impact the disease outcome.
That's a great question. We have some data limitations there in that in the clinical trials, understanding the cause of death is really difficult. So early on or on protocol mortality, we can often get a sense for whether it was directly toxicity related, but there are some challenges there. So we are doing some additional analyses to really try to tease apart exactly what you're describing, what component of that mortality is disease related and what component of it is toxicity related. So perhaps next year I'll be able to give you an update on that.
Thank you so much. Floor is open now for questions. Yeah, can we have one question by Dr. Michael here?
Rich, I'm sad you're not here. I'd love to hang out with you, but
yeah, I'm so sorry.
I have a couple specific questions. Just a follow-up to your question. Do you have a breakdown yet, just with relapse? First, in desresoxane patients, do they receive less total anthracycline because do they receive less total anthracycline or the same amount? And is there a correlation between total dose of anthracycline given and relapse?
Yeah, so it's so hard to know that on the COG data, right? Because on the COG case report forms, the question is, was there a dose reduction? But it doesn't ask you in which chemotherapy agent, and it doesn't ask you how much the dose reduction was, right? And our hypothesis in the COG data is that patients who received desresoxane got more anthracyclines because they had less cardiac toxicity, right?
Yeah.
But we don't have evidence of that. So we're working to develop a different data set, a real world data set of, right now we have about 1,000 children in the US where we do actually have information about some dose adjustments in regard to chemotherapy, and hope in the next year to be able to really demonstrate that, or really sort of answer the question that you're asking with data more specifically.
Yeah, I look forward to that. And the second and final question is, has anyone tried desresoxane with TBI? There's no doubt that it probably causes acute cardiac toxicity. And I'm just curious, it's too difficult with cyclophosphamide, because that's too diffuse. But TBI is a big slug, and it would be interesting to see if it could protect the heart during transplantation-based TBI.
That's such an interesting idea that we hadn't thought of. So, we'll think about it and we'll give you credit if it pans out, because that's a great idea. We hadn't thought about that.
Dr. Nasser?
Yeah, yes. Nasser Bakshi, hematopathologist at King Faisal Specialist Hospital. To Dr. Pulsifer, a question for you. It's very compelling to consider any NGS result, for MRE being positive, and consider it as work on as an indication for treatment or not to treat, right? Is that what I understood from your talk? But is it like something you can extrapolate to flow cytometry when anything which is positive in MGS, no matter what the level is? Because we tend to always, in flow, we always say numbers in points of 0.1, 0.1%. So is that something you think can be extrapolated to flow cytometry as well?
So let's talk about the two different reasons for detecting it. One is to decide on subsequent transplantation based therapy, or to decide on subsequent post-CAR based therapy. So in both circumstances, flow cytometry is absolutely an indication to do something. So if you detect any flow post-transplant, it's important. Now, there's one small caveat to that, and that is that very early post-transplant, you have to have a very good flow cytometer because you might get hematogones, and you've got to be extra careful with some of your very early post-transplant measurements. But bottom line, as you get a few months out from transplant, any detection by flow cytometry, that's real. Something bad is going to happen, and you need to do something about it. And typically people withdraw immune suppression or consider other therapies. The question is, after CAR, is flow cytometry something that you can rely on? Absolutely. If you detect it after CAR, bad things will happen, for sure. The only challenge, if you only have flow cytometry, is that it may be too late for you to do something meaningful. So, for example, if you get to flow cytometry positivity after CAR, most people won't take someone to transplant if they're flow cytometry positive, especially at a high level. And so it's going to require more therapy to get your patient into a deeper remission. If you get someone flow cytometry negative prior to transplant, or at least on the lowest end of flow cytometry, your chances of survival after transplant are much, much better. So NGS offers a big advantage in that you have a little time to organize yourself, confirm that it's correct, and then plan an intervention. I'll need it by the microphone. Thanks.
Yeah, sorry. How long does it take for the NGS result, the MRD, to come to the,
So I showed you on one slide where if you have MRD positivity with flow cytometry, your median time to relapse is approximately 40 days. Whereas if you have only NGS detectable at any level, your median time to relapse is just shy of 180 days. So yeah, the time course is much faster if you're
my
flow.
question is, how long does the lab take to result the NGS?
For NGS, it takes about a week. Now, the challenge with NGS is, in order to do the study, what you have to do, you remember NGS barcodes your disease. You detect exactly which IGH or TCR rearrangements are associated with your disease. And so you have to have that baseline sample. If you don't have your baseline sample and you try to get your detection, it can take up to 2 weeks, because they have to spend 1 week figuring out what your barcode is and then 1 week running your test. So because NGS is so important in all that I do, I establish NGS on all of my high-risk patients so that I have several markers ready to go. And then I can get my levels detected in most cases about 5 days.
Thank you. A question for Dr. Mike about actually 2 practical questions about blinatumomab and the burden of disease. So the first question, I mean, we've been following COG and the relapse protocol and ALL, which is 1331. So blina is a standard of care at the moment in most centers in the country here. One question comes back again to us. Pre-CAR T blina, is it going to affect or not? But our practice currently is to go with a regimen, but based on the data, our assessment is end of induction, the first block of the protocol. And based on that, we're looking into going ahead with blina or not. Do you think it's reasonable to switch protocol if the burden of disease is higher than, say, than 5%, and go ahead with another kind of bridging therapy and move to CAR T, and instead of going to blina, probably the effect, it's 50-50 or even less?
I absolutely support that approach. And the reason why is it's been shown over and over that high disease burden with blinatumomab means poor response. Now, we use this arbitrary cutoff of 5% because that's what people do. It may be that 20% is the right cutoff. It may be that there's a different cutoff. I've seen one study that suggests that a little bit higher disease burden, 30%, may be a little more responsive to blinatumomab. I think 5% is the best one to use. Bottom line is, you have an 80% chance of getting an MRD negative response if you're at 5% or less. If you're above 5%, it's usually way higher than that. Typically, it's 20, 30, 40%. Those patients almost invariably are not only going to fail blinatumomab, they may fail CAR. So I would recommend any patient who has primary relapse disease, especially early relapse, if they are over 5% after reinduction, I do recommend CAR T cell therapy.
By BMT.
As far as following it with BMT,
with the other factors,
it depends. If you have NGS detection and you have a study, you don't have to do that. If you have a really high-quality 401BB vector, if you have the Novartis vector or a high-quality vector that's been shown to have long-term response. If you treat them with a CD28 CAR, for sure they should get a transplant. And then in the absence of a study, you might consider a transplant in someone who's never had a transplant before.
The second question is about the burden of disease assessment in someone who is going for CAR T. when you look at it. So practically speaking, people have been doing different things. Is it pre-lymphodepletion or post-lymphodepletion? Yeah.
So, this is a bit controversial. So there's an earlier paper from the from CHOP, from Children's Hospital of Philadelphia, where they did pure assessment, where they did their lymphodepletion, and then they actually conned their patients into doing this. They gave them LD chemo, and then they did a bone marrow right before the CAR infusion. And so they knew exactly what the LD chemo did. Their cutoff was, they felt like 45% was kind of what they used, although further analysis is way lower. But almost all the studies that we have done that show disease burden matters were done pre-lymphodepleting, mainly because almost all centers, it's easier for them to do that. It's part of their workup. They can do it prior to CAR, and they don't have to, prior to LD chemo, and they don't have to do it again prior to CAR. So almost all the data is based on pre. I think that the principle behind this is patients with a high disease burden have a higher chance of relapse, and that makes sense. That's always been the case in ALL. So whether it's pre-LD or post-LD matters less. But one thing I would caution people from doing is to beat their patient over and over and over again before CAR T-cell therapy to try to get them to be less than 5%. What I find is that if a patient takes more than 2 or 3 cycles of therapy, or they're especially fragile, they will never get to be below 5%. And yet they have a really good chance of getting into a good remission with a CAR and and potentially being in much better shape prior to a transplant. So there I would be cautious about, again, beating someone into remission when you know that they're almost 100% going to get into remission with a CAR, and if you're going to follow that with a transplant, then they should be okay.
Thank you, Michael, for your great talk. I want to hear your thoughts about isolated CNS relapse, early isolated CNS relapse, as the data show that chemotherapy only, or chemotherapy transplantation, late isolated CNS relapse, chemotherapy only might not do the job. Do you offer them a CAR T cell when they are in remission, isolated CNS relapse?
So that's a really important question. I just finished going over a really great review that was put together by the Inspired Consortium about this particular issue. So there's a problem with isolated CNS disease, and that is that the COG 1331 protocol, and I was part of that protocol, so I take full blame for this, blew it with CNS disease. They did not account for the fact that blinatumomab has no penetration into the CNS, and their outcomes with isolated CNS disease were very poor, worse than the past. And the people who didn't participate in that study know it very well. So there are other approaches for isolated CNS disease, especially late relapsing isolated CNS disease, where use of cranial radiation and more CNS intense chemotherapy lead to very good outcomes. But that does come at the cost of CNS radiation. Now, the question is, should CARs be used for isolated CNS disease? There's 2 reasons for concern. Reason number 1 is there's some data suggesting that you have to have at least a small amount of CD19 positive disease in order to get a significant expansion of your CARs so that you can have persistence. That hasn't been proven, but it was the case with Seattle data, and we confirmed that with my data at Children's Hospital Los Angeles, that at least about 15% at the time of infusion of CARs helps improve your chances of long-term CAR survival. So if you want to treat someone with only a CAR, and you want to avoid a transplant that contains TBI, how should you approach that? I don't know. I think it requires study. I think that our goal should eventually be no transplant and no radiation. But I think it's going to take us a while before we get there.
Can I have one question for Dr. Michael? What is your thought on those patients who responded very well to Blina, to the degree that MRD negative before collection? Will you collect them?
You'd have to give me more context. You mean, if someone responds really well to Blina, aren't you going to take them to transplant?
Actually, people, they afraid from the second transplant. This is post first transplant, so it's not transplant naive, second transplant. So they treated, they control the disease with Blina or Eno, and becoming now B cell 0, MRD negative. So what is the best option for them? To go for second transplant or collect?
Here's my opinion, my biased opinion. Blina almost never cures anyone by itself. Almost invariably, although there are some reports, the Blina literature, especially, I'm forgetting his name, from Germany, who did all the original Blina trials. They keep claiming that there's a small percentage of patients who just get a whole bunch of courses of Blina and they can survive. But bottom line, in my opinion, Blina alone, even if you're really responsive, will not cure you, and you need a curative therapy, whether that be transplant or CAR T cells.
But in case if you want to avoid the toxicity of the second transplantation, now you don't have a disease to really collect T cells and for later on CAR T expansion and persistence.
I see. You want to collect something and maybe do CARs later? Yeah, you can certainly do that. That's.
Even the CD19 expression is not there.
I see what the comment was. Even if the CD19 expression is not there, here's my approach to collection. I would prefer to collect a patient who I think will ever get CAR T cells before they get anything. So if you have a high-risk patient that comes to you, and you have an opportunity, and so again, I try to do this. If someone relapses post-transplant and they haven't had CAR before, I'm going to immediately collect them, even before giving them any chemotherapy. The same thing with a very high-risk early relapse patient or an infant who I've controlled disease, and I know they have an incredibly high risk. I try to collect them. And the reason why is if you treat someone with treat someone with therapy that's going to reduce their disease burden, and then you treat them with blinatumomab, by the time you get around to collecting your CARs, who knows what shape your T cells are going to be in. I think early collection of T cells is something I would emphasize. Later, in the future, I have something we're working on in the lab, and there are a number of individuals who are trying to help with this. We're trying to design T cells that are totally refractory to that, and that work and can stay central memory and can last a long, long time. But for now, with the current things that we're using, try to get your T cells as early as possible.
Thank you so much. I guess we are very much behind, so probably if you have any questions, you can approach the speakers after the session. Thank you so much for your excellent talk, and thank you for the audience for being with us at this time. And thank Dr. Richard. Thank you so much for joining us in this panel discussion.
Thank you so much. Hopefully in the future we'll be able to meet in person. So thank you.
Thank you. Thank you. Have a good night. Okay. Thank you so much. Dr. Isa.
Yeah, so now we'll move to two extra sessions that the next one will be given by Dr. Naeem Chaudhry. So he's a professor, a colleague in King Faisal Specialist Hospital. He's the chairman of the EMBMT, and he will talk to us about the second generation TKI and the value of deep molecular response. Welcome, Dr. Chaudhry, and the mic is yours.
Can you hear? Yeah, okay, good. Thank you very much for your introduction. Assalamu alaikum, everyone. No, is there any session after this or one session? You know, the last sessions are always good because then it's the time for dinner. So let's see. I hope there are a lot of people on the online. Anyway, I was asked to, if I can present something on the long-term outcome in CML-CB patients, chronic phase patients, frontline, second generation TKI. So I'm not here to convince you what to do. I'm here to present some data, and then you can make up your mind why is there is any rationale for using a second generation TKI up front. I'm not going to say what I do. I may do it differently, but this is what the data would show. So looking at this as a role and rational upfront therapy for the second generation tyrosine kinase inhibitor, we all know that patients have been using imatinib for a long time. Just to give you some idea about the Saudi Arabia data, it's usually about 130 or so patients, or maybe now 150. Because I don't have the update on this one for the total disease burden every year, new patients. And we see about 1/4 in King Faisal in Riyadh, about approximately 30 to 40 patients, new patients every year. And there are referral cases of resistance and intolerance. So second generation tyrosine kinase inhibitor not only is getting used as a intolerance or in patients with resistance, but also upfront. So a lot of times the patients who approach or are referred to us have already gone through a second line as a first upfront use. So we all know that it's revolutionized. Chronic myeloid leukemia treatment is like a chronic disease now, like hypertension or diabetes. People take it for drugs. I have patients who have been using this medication for the last 20 years now and remain in major molecular response and deep molecular response. I have patients in treatment-free remission. The longest one is approximately 8 years now. So the 10-year survival rates are anywhere from 83 to 93% based on how they respond and what they maintain as their response. But from the very beginning, since the IRIS data was published, it is very well documented that the time to cytogenetic and molecular response has shown to predict the long-term outcomes. So the earlier their response to cytogenetics and earlier their response to molecular achievement, they do have a better outcome. And deep molecular responses, also, of course, afforded select patients to discontinue therapy, which we call TFR or treatment-free remission. So what we'll do in this talk is to see whether the time to cytogenetic molecular response is different between the first and second generation TKIs, that you may take this data and make a decision on what you need to start the patient on, and whether the deep molecular responses are more or higher or deeper molecular responses with the second generation, so you can make a decision for a treatment-free remission. The survival of adequately managed response patients is determined more by comorbidity. So this is from the original study. So not all patients, you cannot have one box and everybody's in the same box. So there are patients who are young, there are patients who are old, there are patients who have cardiac abnormalities, patients who are liver abnormalities, chronic kidney disease. So comorbidity index plays a strong role in the outcome. So that helps you in making a decision what kind of the first or the second generation tyrosine kinase inhibitor you want to use based on their Charleston comorbidity index, whether it's hypertension, diabetes, cardiac disease, history of pleural effusion, pulmonary hypertension, chronic smokers. We have hookah smokers of 50 years down the line. So the NCCN guidelines has approved from many years now the low risk and the intermediate and high risk, all of them are approved as a first line, and they're all category 1. Maybe the low risk, they say the preferred regimen is imatinib, and then of course the other ones, bosutinib, dasatinib, nilotinib. Now these are labeled as put in this way by their the way that's by the letters, not necessarily which one is the first one or some. It is only alphabetical. That's why. So bosutinib, dasatinib, nilotinib. If you have intermediate or high risk score, then they say that the preferred regimen may be a second generation tyrosine kinase inhibitor, but the first generation, of course. And a lot of us use first generation even in intermediate or high risk. But that's what the NCCN guidelines. And if you look at the risk calculation table, you can do any scoring. So-called score was based on the time of the interferon, although they have validated this also in the analysis in the tyrosine kinase inhibitor. But the ELTS score, which is the UTOS long-term survival score, is based on the current therapy of the tyrosine kinase inhibitor. In my practice, I use only ELTS. I don't use so-called score anymore because in this score, the patients who were in the high risk so-called, a lot of them moved down into the intermediate, and a lot of the patients who were in the so-called intermediate moved down into the low risk so-called score. So based on this one, anyway, the updated guidelines of NCCN has not changed. If you still look at it, the primary treatment, the low risk, the way you calculate it, ELTS or so-called, still a preferred regimen may be imatinib, but second generation tyrosine kinase inhibitor in alphabetical orders, they're listed over there, and also all of them are category 1. So there is no issue that some would say that it is not, no, all of them are recommended, but maybe imatinib is preferred. And on the other side, if they're intermediate or high risk score, then the preferred regimen apparently is a second generation, because as we'll look into the approach to achieve a cytogenetic response or a molecular response earlier time points. To give you a brief statement, the results of all second generation TKIs, whether nilotinib, dasatinib, and bosutinib, and now there are others also, are no different compared to first generation like imatinib in long-term overall survival, because there is availability of so many drugs and the response is good unless they develop resistance to all of them. But efficacy and outcome may be different depending on the treatment goals. So your treatment goal should be an objective. When you see a patient, there could be a young female who wants to get pregnant or get married in the next few years. There may be some old patients who do not have no other medical illnesses and don't care what you start with. So you have to make a decision which patient is going to tolerate which drug and what your goal is. Whether a younger patient is more for a TFR or an older patient is more for TFR. And this is very difficult to make this decision sometimes, because an elderly patient also is a very good candidate for TFR, because you don't want him to be on this drug which have cardiovascular side effects for a longer period of time. So there is no hard and fast rule that the younger patients are better for TFR, or older patients should not go on TFR. So all of them are approved as first line, preferred especially for the high risk so-called and ELTS. So what is the goal of therapy? For example, for the cure, we know very well that 50% of the patients will achieve a deep molecular response beyond a major molecular response. And if you get them into a TFR range, half of them will stay as a treatment-free remission on a long-term follow-up. So the overall cure is about 20 to 25% when you look at the overall picture. 80% will still have to be managed as a successful chronic disease management, just like hypertension or diabetes. So you have to really select a drug that you think that if the patient fails a TFR, if that was your goal, then is the patient going to continue on this therapy for a longer period of time without going through any side effects, or significant side effects, I should say. So successful chronic disease management is also as important as a treatment-free remission. Now this is again from summary of a longer term follow-up on the TKI discontinuation trial. So if you look at these patients ranging about 100 plus, the largest one is the Euroski, which is the lowest one on this table with the largest number of patients. And when you look at the time point that the requirement to stop a drug is anywhere from 12 months to 2 years. Most of the older studies use at least 2 years of either undetectable or a major molecular, a deep molecular response of 4.5 or 5. But lately the trend is that as long as the patient gets an earlier major molecular response and they maintain a deep molecular response for a year or two, beyond 3 to 5 years is a time point for when you can offer them a TFR, because the studies have shown that the duration of use of TKI is also important, not only the deep molecular response, because we have some patients who have achieved a deep molecular response or undetectable at year's time, 1 year of use of TKIs, but they are not a candidate of TFR. Why? Because the duration is also important for how long they have to use. So generally now the trend is the drug should be used for at least anywhere from at least 3 to 5 years before you have to have a year or 2 years of 4.5 and beyond reduction in the transcripts. When you look at the treatment-free remission rate, it ranges anywhere from 40% to 50%, some of them 61% or 30 mg, but the long-term follow-up, which are like 5 years of the eNest freedom and eNest stop, is about 43%, and the shorter term are maybe also the same. But when you look at the STIM study, the one on the top, which is the longest term follow-up, they continue at some time point lose the response, so they are about 38% or so. So do the results from the comparative trial help in selecting the frontline treatment among the first versus second generation? We know that survival by 3 months, some centers did show 3 months earlier, less than 10% did make a difference, but the major trials also have some evidence that there is an advantage, but did not show. But 6 months time point is probably the best time point, whether you can use BCR-able IS transcript of less than 10%, more than 10%. So it's difficult to make a decision at 3 points. I do not do it, and I would not recommend you to switch a drug at 3 months unless there is absolutely no hematological response also. But 6 months is a very fine time point, and most of the studies and most of the guidelines are moving towards that direction to that 6 months is a better time point of change of the drug if they are more than 10%. But you have to understand that even in the IRIS study, the patients who went on to have a deep molecular response or major molecular response at 1 year, even if their BCR-able was more than 10%, and they achieved a major or deep molecular response at 18 months even. So what about the consideration of choice for second generation as a frontline based on the percentage of patients eligible for TFR? Do you expect that there would be expected higher percentage, or is there an expectation that there will be early achievement of deep molecular response? If that is an expectation, then one should consider in select number of patients upfront on the second generation tyrosine kinase inhibitor. And as we discussed already, the deep MR, that is 4 or 4.5, is a prerequisite for many discontinuation trials. So when you look at the decision trial, the molecular response to 3 months was more, 84%, as compared to imatinib, which was 64%. But that is not at that time fine point as 6 months. And the same if you look at the first line treatment in chronic myeloid leukemia with EMR and the eNest, which is the nilotinib, also a whopping 91%, much higher, and the imatinib remains the same as the previous trial as decision, but apparently a significant number of patients did achieve a 3 months early molecular response. Even for the before study, the bosutinib also the same, the imatinib remains the same, and bosutinib not as high as the nilotinib, but did have advantage in getting patients into an earlier molecular response. So what about by 1 year and 4.5? Again, no MR4 in bosutinib, 8%, 4.5, and 3% in so imatinib. So obviously this is not a goal anyway for the start of the TFR. What about the 5 years in decision? Again, 4.5 was in 42%, and in imatinib also 33%, a difference of 9%, which is not that great. But this is just the point to make is that you get 42% of the patients, but eventually these patients will slowly tend to lose their molecular response and get back onto the medication. So 20%, as I put earlier, is actually the operational cure. So this is the 9%, but there seems to be continuous, maintains a difference between the response as the years pass by, about 9%. When you look at nilotinib also, the same, the difference is actually higher starting from 1 year, and approximately 23% difference between imatinib and nilotinib by 6 years. So 56% of the patients did achieve MR 4.5, which is a prerequisite for treatment-free remission. And the cumulative rates so continues to go by 12 months to 21, by almost close to double by 24 months. And when you look at the first-line treatment, CML, treatment-free remission, on frontline nilotinib achieved 4.5 earlier than on imatinib. So the overall years, when you start making a decision that this patient is a candidate for TFR, I'm going to offer them TFR at the next visit in this next 6 to 1 months. Imatinib took a bit longer, and nilotinib took about 3.8 years. And as I said, that the duration of use of TKI is also very important. It has to be at least 3 to 5 years before you put them on treatment-free remission. There is some tendency, and I'm not going to discuss it over here, in combination of drugs where they get patients earlier, deeper molecular response, and tend to put them earlier in the treatment-free remission. So ENEST freedom, patient disposition, just to, because it's interesting to look at this one, more than 2 years on frontline imatinib, they went on to have a consolidation phase of 52 weeks, and as long as they maintained their 4.5 log reduction, they went on to go to a TFR phase. And almost close to 90% of the patients actually completed the consolidation phase. So they went on safely onto a treatment-free remission. And this is what it is, ENEST freedom, 144 weeks, a long-term follow-up treatment-free remission, almost 46.8% or 47%. Nearly 50% of the patients that you selected for TFR remains in remission, which is actually good. But when you look at the whole picture, it is operational cure still about 25% of the total number of patients that you start them on these medications. The good thing is, the moment they lose, as optimal response for any chronic myeloid leukemia patient is a major molecular response. So as soon as when they lose a major molecular response, you put them back onto the same medication, and almost all of them will achieve a major molecular response. 99% almost, and 92.3% will regain the 4.5 log reduction, which was actually the time point that you made, the value that you used for starting the TFR. So it is safe. When you counsel a patient, it has to be mentioned in your documented notes, because you're going to stop the drug. When you counsel the patient, you should let them know that in case we're going to follow you very closely, and in case if you lose a response, the chances of getting a major or an optimal response is 99%. And with the same deeper molecular response, almost like 92% to 93%. And just to, sorry, I think I have to, how to go back. So also, it does not take that long. I forgot to mention that it does have maybe within a 12 to 14 weeks or so, patients, and the regaining of the major molecular response is very short also. So it's not going to take another year for patients to lose a major molecular response. It's within like weeks. The timing is getting back into an optimal response is actually within weeks. 7 weeks for major MMR, and a median of 12.9 weeks in getting the MR 4.5. So in summary, the second generation TCAS as frontline shows a better efficacy. There's no question. This has been published on the comparative trials. Safety profile is manageable. There may be a different safety profile. Imatinib may be somewhat safer, but this safety profile is manageable. Earlier molecular response and deep molecular response on upfront second generation leads to better progression-free and possibly overall survival, although there is no clear-cut indication of an overall survival difference yet. Especially except maybe patients who achieve a deep, very deep molecular response compared to patients who have achieved only a complete cytogenetic response. Whatever the selection, the earlier MR and the deeper MR on second generation TKIs as frontline leads to a higher number of patients eligible for TFR. So one can make that case that if I'm going to get a higher number on deeper molecular response, I can select a larger number of patients to go for a treatment-free remission. And second generation will lead to earlier time point decision for TFR, as I showed you, 3.8 for the second generation, the lotinib as compared to imatinib, which was 5.3 months years, I think. But again, 70 to 80% of the patients will have to be managed as chronic disease because people tend to lose their responses. Understanding efficacy, tolerability, adverse events, and comorbidities all have to be taken into account when you make a decision upfront for a second generation TKIs. Because eventually, as I said, the curative operational cure is about 20%, but you can look at it in two ways. Either you say that, well, this only 20% will be cured, but also you know that you have been able to subject patients for treatment-free remission attempt approximately 50 to 55% of the patients in the second generation as compared to 30 to 35%. So higher number of patients have been given a chance of treatment-free remission. They may or may not, all of them obviously will not maintain a long-term treatment-free remission. So overall, still 25% or so patients will be able to manage as an operational cure. I think that was it. This is King Faisal, our building, and this tall building is the King Abdullah Center for Oncology and Liver Disease. Thank you very much.
Thank you, Dr. Nadeem and Naeem. And now we'll come to the last talk sponsored by AstraZeneca. We'd like to thank them and thank Novartis for sponsoring the previous talk. Will be presented by Dr. Ashraf Warsi. Dr. Warsi is adult hematologist, consultant at Princess Noura Oncology Center at King Abdulaziz Medical City in Jeddah. Dr. Warsi will be talking about the role of C5 inhibitor in PNH management. Dr. Warsi, thank you.
So just waiting for the slides to come up. Okay. Okay. So I've been tasked with a talk about C5 role or complement inhibitor, role of C5 inhibition in paroxysmal nocturnal hemoglobinuria. Slides a bit mixed up. Hold on a second. That's the end. Okay. Okay. So the first time I heard about it was my fellowship actually in 2009. And it's really fascinating the pathophysiology of the disease itself. Paroxysmal nocturnal hemoglobinuria, the name is from the original description where people or the patients would end up early in the morning seeing red urine or dark urine because of the hemolysis that happened more frequently at night. But that hemolysis continues throughout the day. So the name was really more of a description of the patients rather than being the disease itself. What was fascinating and really fun to know was the pathophysiology and how we develop medication to treat it through its pathophysiology. So the first case I'm presenting is a 43-year-old woman. She's actually with us at the moment treating our center. She was referred for anemia and found to have elevated total bilirubin with elevated LDH. Her DAT was negative and with no previous history of thrombosis. Her PNH testing, which I will come later on to, was positive and she was diagnosed with that. She was started on eculizumab and very more recently we switched her to revelizumab and we'll go through those therapies in the next few slides. The second patient is a bit older, and maybe King Faisal knows this patient before, but I saw him 10 years ago. He was actually a young male, 25-year-old, who was even before that time diagnosed with unprovoked thrombosis. And at that point, later on, he did develop some hemolysis. His workup turned out to be had PNH. He was started by 2012 when I was there. He was already in eculizumab. We had some logistic issues, and was very interesting in him that if we delayed his dosing by 2-3 days, he would present to ER with massive hemolysis, acute renal impairment with creatinines in the 300s. You end up supporting him with fluids, sometimes transfusions. He was maintained on warfarin anticoagulation for long periods of time. Eventually, he had a stem cell transplant at King Faisal Specialist Hospital, Riyadh, and in fact was cured after that. I believe he's still alive as well. So it's a acquired genetic mutation in pluripotent hematopoietic cells, where you actually, the gene responsible for that is the PIGA gene. It's located on the X chromosome. You lose the synthesis of the GPI anchoring proteins, and these are anchoring proteins on the surface of red cells that hold proteins, for example, CD55 or CD59, which are responsible for protecting the red cells from complement activation. It's not here on this figure, but I remember the figure where it's like an inverted J shape, and basically whenever the complement is coming, it prevents it from attaching to the red cell surface and activation. Not only that, but CD5 also protects accumulation of CD or complement 3 on RBC surfaces and extravascular hemolysis. So those are the two, are really what happens in the pathophysiology of PNH. Now, it's really important, but I want to highlight on this on this figure here. Complement has 3 pathways, as you guys know: lecithin pathway, classic pathway, alternative pathway, and all 3 pathways eventually go to activate or cleave C3, which on its own produces C3A, which is an anaphylatoxin, but also 3B, which can amplify the complement pathway and convert C5 into C5A and C5B. C5b is the one really responsible for intravascular hemolysis and attachment to red cells, which is prevented by CD59, whereas the C3 accumulation of red cells is prevented by CD55. Now, some of the targeted, so these two, CD55, 59 are the ones used for diagnosing PNH patients. Not only that, you see factor B and factor D. These are targets for therapy. I'll just briefly touch on that. We've also, the C5a accumulation sometimes causes a pro-inflammatory process. So through this normal pathway, we'll go through what happens to these patients who develop hemolysis, our PNH patients. So main complaint, or most of the patients, 80% of them will have hemolysis leading to anemia and fatigue, so those are the common symptoms. Intravascular hemolysis releases hemoglobin or free hemoglobin inside the vessels, which is a scavenger of nitric oxide, and that will cause vasospasm, affect also smooth muscles, and that will lead to dysphagia, sometimes pulmonary hypertension, dyspnea also. But pulmonary hypertension and dyspnea can also be a consequence of thrombosis, and thrombosis happens through the nitric oxide scavenger pathway, but also there is the pro-inflammatory from C5a causing vessel wall or endothelial injuries also in these cells. So it's a multifactorial thing that happens, which explains all the manifestations of the PNH patients. So if left untreated, PNH can lead to nitric oxide depletion, vasoconstriction, smooth muscle dystonia, and subsequent complications that can contribute to impaired quality of life. Not only that, before the era of C5 inhibitors, significant decrease in life expectancy was proven. Up to 35% of patients would be dead by 6 years from diagnosis. It is a rare disease. Different populations have different references, so it can range between 1 to 10 cases per million populations. It can be diagnosed at any age, but median age is usually early 30s. There are also female cases diagnosed with PNH, and that's secondary to lionization, which is selective inhibition of one of the X chromosomes. It's a progressive disease. Uncontrolled complement activation underlies the morbidities and early mortality in PNH cases. So how does thrombosis and end organ damage occur in PNH? As I have showed you, so C5a will be the one responsible for the pro-inflammatory, so it will activate leukocytes, cause endothelial cell activation, leading to endothelial cell damage, release of tissue factors, cytokine release. Also platelet activation will cause fibrinogen cleavage, platelet aggregations. The C5b will cause lysis of red cell, release of free hemoglobin, and increasing LDH, causing scavenging of nitric oxide, leading to end organ damage, small muscle dystonia, and thrombosis. So LDH is an important clinical marker. In general, we hematologists regard it as one of the first or the most sensitive marker for hemolysis. And that's true in intravascular hemolysis, which we see in PNH patients. Not only that, so what are the predictors of thrombosis in these patients? So having chest pain or abdominal pain or dyspnea increases your chances of having an underlying thrombosis, but that combined with an elevated, LDH, which we define as more than 1.5 upper limit of normal, that really increases significantly your chances of developing thrombosis, and that's what's shown in this trial. Thrombosis risk is 7 times greater in patients with just elevated LDH, and you don't need it very high, just above 1.5 upper limit of normal. As you can see, it increases more by 7 times. Which patients should we suspect and we screen for paroxysmal nocturnal hemoglobinuria? So it's a night mnemonic catch. So those who have a Coombs negative hemolysis or have hemoglobinuria or hemosideриnuria, unprovoked thrombosis. I have to say I've been screening for a couple of years now. I haven't thrombotic patients. We haven't seen a patient with PNH yet, but that's still one of the presentations that can happen. Patients with aplastic anemia or patients with cytopenias, especially MDS, usually they do carry a very small clone of PNH cells, 1 to 2% usually, but sometimes these patients may actually be PNH patients who have developed bone marrow failure syndrome. And according to their presentation, some authorities would divide them into different categories. So PNH with hemolysis, PNH with thrombosis, subclinical PNH patients, which are basically having very slight elevation LDH, but no really anemia, no other manifestations, and PNH with bone marrow failure, basically those patients with PNH and aplastic anemia or myelodysplastic features. We will be really concerned with the PNH patients with hemolysis. So ravulizumab indicated for the treatment of adult and pediatric patients with paroxysmal nocturnal hemoglobinuria. So it was built on the backbone of eculizumab, which has been the treatment for ravulizumab for a very long time. It inhibits the C5, complement 5. But ravulizumab have an increased affinity to factor 5. By that, it has a long, by that it's more complete and sustained C5 inhibition, as well as pH-dependent release of factor 5, so it improves its clearance from the system. And the FC region has been modified to have a higher affinity for neonatal FC receptor, and by that increasing its duration in the circulation. And that's why the duration of, or the interval between the doses of ravulizumab is actually 2 months or 8 weeks. So eculizumab is again intravenous. Both of them are actually intravenous injections. Eculizumab is given after the loading weeks or after the loading dose every 2 weeks, whereas ravulizumab is given every 8 weeks. So this is really different in administration and also convenience for patients as well. So the other big difference, fixed dosing for eculizumab, where this is a bit more tailored to patients' weight. So that's a weight-based, gives you the leisure of being more specific to patients. The long-term elimination half-life of intravenous ultramus allows adult patients to receive infusions at adequate dosing intervals, and that was really engineered in the backbone of the antibody. So ravulizumab was studied in 2 randomized controlled trials, nicely called 301 and 302 trials. The 301 basically were naive patients of PNH, so had never received any treatment, and they were either randomized to receive eculizumab or ravulizumab for 26 weeks, and after that all of them continued on ravulizumab. Whereas the 302 trial, basically these patients were all PNH patients who were on ocluzumab after a 4-week observational period. Half of them continued on ocluzumab, where the other half were randomized to ravulizumab, and after 26 weeks, all of them continued on the extension period on ravulizumab. So collectively on both of those data, LDH significantly was more lower in the ravulizumab arm, as well transfusion avoidance or transfusion independency. Hemoglobins were even better with the ravulizumab arm, definitely. Breakthrough bleeds also were better, and I'll touch a bit on that more. So breakthrough bleeds were also better in the ravulizumab arm compared to the ocluzumab arm. LDH also better. So on all parameters, either better or same results. It was a non-inferiority trial, and it did meet its endpoints. So that led to the approval of the medications for that. Now, why do we get breakthrough bleeds? Earlier on, I showed you the figure where the pathophysiology of the disease is. So we do inhibit C5, but we do not do anything with C3. And C3 will accumulate on the red cell surfaces and cause extravascular hemolysis. So that could be a reason. Another reason, which is more common with ocluzumab, is some patients may do not tolerate the 14 days, the 2-week duration. They may hemolyze just before that, so you just need to decrease the duration in those patients. So that's the reasons for the breakthrough bleeds. Looking at the free C5 levels, if you look at the, just because the way ravulizumab works, you will find sustained lower levels of C5 compared to the ocluzumab, where there's hectic and where there are occasions where C5 is higher, which may contribute to breakthrough bleeds through intravascular hemolysis. So there is a more sustained C5 inhibition with ravulizumab. LDH is throughout, whether it was the randomized first 26 weeks or the extended period, was maintained below expected levels actually with ravulizumab. And in the breakthrough bleeds, none of the bleeds in the ravulizumab arm was due to increase in C5 levels. As you can see, they maintained it at 0 levels basically. So that was really reassuring that C5 was, efficacy-wise, was really inhibited with the ravulizumab. The commonest side effects, which we have seen actually, are a headache and upper respiratory tract infections. They're non-severe, so it's easily managed. Probably in the trials, the most severe reactions were just fever. Those were the grade 3 or 4. But apart from that, both of them were tolerated very well and comparable. So, Ultrameds, built on foundation of ocluzumab, is designed to deliver long-acting treatment, has been studied in the largest clinical trial program of adult patients with PNH to date, is indicated for the treatment for adult and pediatric patients 1 month of age and older with PNH. It is a weight-based regimen and was developed to have long terminal elimination, half-life, and clearance, allowing for longer dosing intervals, 4 to 8 weeks. We used 8 weeks for PNH treatment. Ravulizumab or ocluzumab has been studied for over 2,000 and 62,300 patient years respectively. There are other medications. I didn't put a slide on it because we were just discussing the C5 inhibition role in PNH. But you have approved, so the FDA approved, pegcetacoplan, which inhibits actually C3. And the only difference in the trials of that to compare to C5 inhibitors, it has never been used in naive patients. In fact, it was used on patients who were already on a C5 inhibitor, although probably theoretically you could use it from the beginning. I look at it that would be an add-on medication if you have breakthroughs and they have difficulties unmanaged, or if you have persistently lower hemoglobins or hemolysis ongoing. There are other unapproved medications, tablets, so those are off-label use basically, but all of you know the last ASH late-breaking abstract, iptacopan, the oral medication, or danicopan, which may be coming soon also. Both are oral medications. One of them is given, the first one is given twice daily, the other one 3 times a day. That's a bit inconvenience and will cause definitely compliance issues with the patients. Danicopan is actually studied as an add-on to a C5 inhibitor, ravulizumab probably, And that would be really nice in patients who have breakthrough bleeds. That would be because you're going to inhibit both. Pegcetacoplan inhibits C3. Iptacopan actually inhibits factor B, and danicopan inhibits factor D. So all working on the C3 esterase pathways. I think that's what I have. And lastly, all of these complement inhibitors predispose especially to Neisseria meningitidis infections. So you have to vaccinate your patients at least two weeks prior to starting. And if you are in a hurry or the patient wouldn't tolerate waiting for that period, then you should vaccinate him and start him on ciprofloxacin twice daily until the 2 weeks are there and he's have gained immunity against the bacteria. Again, vaccination is not 100% protection. Educating your patients regarding signs of fever and signs of meningitis and seeking early medical care for fever is really, really important. And I thank you for your attention, and thank you.
Thank you, Dr. Ashraf. If you may join us here. That's all right. And Dr. Naeem, if we have one or two questions, burning questions, Dr. Sami.
Assalamu alaikum. Dr. Ashraf, thank you for your talk. Question related to transplant. We usually see TMA, which is transplant-associated TMA. We use sometimes eculizumab in this group of patients. What do you think about this new, I would say, long-standing type of treatment in this group of patients?
I'm just laughing because I was just discussing that outside 2 hours ago. And in fact, some people are already starting studying that. Now, we've done that. We have, 2 or 3 years ago, we had some patients with TMA post-transplant, and we had to give them eculizumab. Ravulizumab had yet not even sufficient data to say anything. It's under study, I would say. But theoretically, it does work. I don't know how comfortable would be the transplanters for a duration of dosing of 8 weeks. But yeah, it's one of the things that they're looking into actually, but no data available yet.
There is a question to Dr. Naeem from the virtual about the persistence of deeper response and stopping TKI upfront. I mean, from pediatricians, for patients who get diagnosed with CML for a long time, this is always a question from the families, when to stop, etc. I believe the adult data is more, there are more studies in adults. So what is your opinion about that?
Yeah, I think they have I know there's more data on the adults, but the disease biology is apparently the same. I don't think there's much difference in it. And I have patients that have been transferred, a few patients on a very deep molecular. And one of them, I've just started the TFR. She's 18 years old. So we'll see how it goes. She's an adult now. So there is, of course, if they're adults, if you say that if somebody is 6 years old or 10 years old, followed by pediatrician for the last 4 or 5, we have some patients, I'm sure pediatricians would know that there are some very young patients with chronic myeloid leukemia. I don't know what's the right answer to that. I think it has to be on, I can't remember if there is any trial on that one. Maybe Ali would know. But I would tend to continue them on TKIs, especially if they're tolerating it. Once they go into the adult agehood, I think it's probably reasonable to stop the drug at the time, or unless they're developing any complications.
Thank you. Any further questions from the group? Let me just check here. Yeah, there is a question to Dr. Ashraf about upfront therapy of rivolizumab and the median time for its effect. Like, would you use it as an upfront? And
well, so once, oh, definitely yes, yes. So the answer is yes. As I showed you in the 301 trial, they used it upfront, naive patients with PNH. Now, if you diagnose your patient with PNH, he has already presented either with hemolysis or thrombosis. Data definitely shows that it does decrease the thrombosis, and you just only need to treat the thrombosis for acute period. Maybe you don't even need it for prophylactic after the 3 months, but you definitely need a PNH-directed therapy. Now, revolizumab, you can use it up front. That's totally fine. It's from the data, yes.
Thank you very much, Dr. Ashraf. Any further questions? We're almost at the end. So thank you for the speaker. Actually, really, this is the last sessions of the day, end of day 2, with that great attendees. And in fact, also, I would like to thank the SSBD for the second day in the annual Saudi Hematology Congress. I must say also, there are also people behind in the virtual, and as of now, I got a message that there are 2,000 virtual attendees with us until now, until the end. So thank you all for staying, and have a great evening.
No announcements or anything for tomorrow?